తెలుగులో చెప్పేస్తుంది. ఈరోజు ఈ కార్యక్రమానికి ఇంటర్నేషనల్ ట్యూబరస్ స్క్లెరోసిస్ ఈ సమావేశానికి వచ్చిన పేరెంట్స్ అందరికీ నా హృదయపూర్వక ధన్యవాదాలు. మన దేశ విదేశాల నుంచి వచ్చిన నిపుణులు ఈ ట్యూబరస్ స్క్లెరోసిస్ మీద ఎంతో టైం స్పెండ్ చేసి మానవ మనుగడ కోసం కృషి చేస్తున్న డాక్టర్లు ఇక్కడికి రావడం జరిగింది. వీరంతా కూడా ఎంతకాలంగా ఈ ట్యూబరస్ స్క్లెరోసిస్ మీద వర్క్ చేస్తున్నారు. ఎంతోమంది పేషెంట్లను చూసి ఎంతో అనుభవం గడించినవారు. వాళ్ళు ఇక్కడికి వచ్చి మీతో ఈ ట్యూబరస్ స్క్లెరోసిస్ అంటే ఏంటి, అది ఏ ఆర్గన్స్ని ఎఫెక్ట్ చేస్తుంది, ఎందువలన ఈ ఆర్గన్స్ ఎఫెక్ట్ అవుతాయి, ఈ ఎఫెక్ట్ అయినప్పుడు ఏం జరుగుద్ది, వీళ్ళని ఎట్లా ఫాలో అవ్వాలి, వీళ్ళకు ఉన్న మందులు ఉన్న వైద్య సదుపాయాలు ఏమిటి, వీటిని గురించి వివరించడానికి ఒక్కొక్క సిస్టమ్కి ఒక్కొక్క నిపుణులు ఈరోజు మిమ్మల్ని విశదీకరించి మిమ్మల్ని బాగా ట్యూబరస్ స్క్లెరోసిస్ అంటే ఎట్లా ఎఫెక్ట్ అవుద్ది, కొంత ఈ ఫ్యామిలీస్కి కొంత సోలేస్ తెప్పించడానికి ట్రై చేస్తారు. నేను డాక్టర్ తిలక్ చంద్రపాల్, ఇక్కడ పీడియాట్రిషియన్ని. మా తరఫున మిమ్మల్ని అందరినీ ఇన్వైట్ చేస్తున్నాం. ఈరోజు కార్యక్రమంలో మొదటగా ట్యూబరస్ స్క్లెరోసిస్ కాంప్లెక్స్ ల్యాండ్స్కేప్, దీని మీద మాట్లాడబోతున్నారు డాక్టర్ డార్సీ ఏ క్రూగర్, ఎండి, పిహెచ్డి. ఈజ్ ది డైరెక్టర్ ఆఫ్ ట్యూబరస్ స్క్లెరోసిస్ క్లినిక్. ఈజ్ ఏ క్లాక్ ఎండోమెంట్ చైర్ ఇన్ ట్యూబరస్ స్క్లెరోసిస్, అసోసియేట్ ప్రొఫెసర్ of clinical pediatrics and neurology at Cincinnati Children's Hospital, USA. He serves on the board of directors for Tuberous Sclerosis Alliance. అంటే ఈ యొక్క సంస్థ తరఫున పనిచేస్తారు. అండ్ డాక్టర్ క్రూగర్ సర్వ్స్ యాజ్ ఏ సీనియర్ అడ్వైజరీ బోర్డ్ ఫర్ ట్యూబరస్ స్క్లెరోసిస్ కాంప్లెక్స్ క్లినికల్ రీసెర్చ్ కన్సార్షియం, through which he directs and participates in a board clinical research portfolio with funding from national NIH of United States, multiple non-profit foundations and pharmaceutical industries. అంటే ఫార్మసీలో తయారైన వాటిని ఈ ట్యూబరస్ స్క్లెరోసిస్లోకి అన్వయించడానికి ట్రై చేస్తున్నారు. విత్ హోప్ నార్థ్రోప్ ఎండి, ఈ కన్వీన్ ది 2012 ఇంటర్నేషనల్ ట్యూబరస్ స్క్లెరోసిస్ కాంప్లెక్స్ కాన్సెన్సస్ కాన్ఫరెన్స్. అంటే వీటికి గైడ్ లైన్స్ తయారు చేశారన్నమాట. ట్యూబరస్ స్క్లెరోసిస్ ఉన్న పేషెంట్స్ని ఏ విధంగా ట్రీట్ చేయాలి, ఏ విధంగా ఫాలో అవ్వాలన్న గైడ్ లైన్స్ తయారు చేయడంలో వీరంతా కృషి చేశారు. అండ్ రీసెంట్ గైడ్ లైన్స్ ఈ ఏడు విడుదల అవబోతున్నాయి. 2019 డాక్టర్ క్రూగర్ వాజ్ గ్రాంటెడ్ ది 2019 Manuel R. Gomez Award for his outstanding contribution towards tuberous sclerosis complex and care for the tuberous sclerosis patients. I invite Dr. Darcy Kruger. Thank you.
It's coming. I don't need it. Thank you.
డాక్టర్ డార్సీ గారు ఇంగ్లీష్లో మాట్లాడతారు. కొన్ని ఇంపార్టెంట్ థింగ్స్ నేను తెలుగులో అనువాదం చేయడానికి ట్రై చేస్తాను.
So thank you for the invitation, and I'm glad that you're here today. This is my third trip to India, but my first to Hyderabad. And it's been a wonderful week that we've been able to meet with doctors and families from Mumbai and then to Delhi. And then this is our last and final stop this time around. So thank you for being here. I've been asked to talk about tuberous sclerosis and all the things that we've been working on to make life better for patients with this diagnosis, and to introduce where are we trying to go next, because we still have more work to do. This is tuberous sclerosis is a very old disease. We've known about it for many years, over a century, and there were numerous early doctors who described tuberous sclerosis, and it was 1879 that it was finally given its name that we have today of tuberous sclerosis disease. Much work has been done to try to understand it, but it really was in 1967 with Dr. Gomez, who we consider the modern father of tuberous sclerosis, that really clarified that this disease was much more common than people thought, and there was much more for us to learn.
ట్యూబరస్ స్క్లిరోసిస్ అనే జబ్బు చాలా రోజుల నుంచి మనకు తెలుసు. ఇది ఆల్మోస్ట్ ఒక 2 సెంచురీస్ ముందే ఉండింది. అప్పటి నుంచి మెల్లగా దాన్ని అర్థం చేసుకోవడము 1879లో దానికి ఆ పేరు అనేది ఇచ్చారు. 1967లో డాక్టర్ గోమెజ్ అనేవారు, తను హీస్ అ పయనీర్ ఈ ట్యూబరస్ స్క్లిరోసిస్ కాంప్లెక్స్ కండిషన్స్కి. I can only translate in one language. You can't understand English? English is okay? Okay. Pratnya.
सो ये कह रहे हैं कि नई बीमारी नहीं है, कई सालों से ये बीमारी पता है. हावेवर गए 50-60 साल से ही इसमें काफ़ी इसको नाम मिला. इसमें और जो ट्रीटमेंट्स में जो काम हुआ है आगे, वो गए 50-60 साल से ही हुआ है. बट बीमारी कई कुछ 100 से भी ज़्यादा सालों से पता है.
Okay. This is a genetic disorder, and it affects millions of people around the world. And surely in India, the great country that you belong to, there are hundreds of thousands of individuals with this diagnosis.
Right. Just want to clarify. He हिंदी भी ट्रांसलेट करनी चाहिए और तेलुगु भी। पर सबको हिंदी समझ में आता है, आपको हिंदी नहीं आता है ना, आपको तेलुगु आता है सिर्फ, और इंग्लिश भी नहीं आता है जी। इंग्लिश और ओके, क्योंकि बहुत डबल समय लगेगा, इंग्लिश तेलुगु और हिंदी टॉक विल। सो what do you want?
What did we decide?
Which language to talk?
I know. So what did we decide? Are we doing 3 languages or 2?
Only one language, right? Yeah. Just so if you can understand English, then we'll stick to
Hindi. Yeah. Okay. Hindi is difficult for me.
Okay.
Okay. All right. No, it's okay. ये बीमारी बहुत पूरे दुनिया भर में है, ऐसे नहीं कि सिर्फ इंडिया में दिखाई देती है, सिर्फ पूरे दुनिया भर में ये बीमारी लोगों को होती है, इसके पेशेंट पूरे दुनिया में हैं, और कई लाखों करोड़ों लोगों को ये बीमारी है। सो कई बार लगता है कि आपकी बीमारी जब भी डायग्नोस होता है और किसी ने सुनी नहीं है, कभी फैमिली डॉक्टर को पता नहीं है, तो लगता है कि अरे बाप रे कुछ बहुत रेयर प्रॉब्लम है क्या, तो ऐसे नहीं है। बहुत सारे पेशेंट्स हैं लाखों करोड़ों में दुनिया भर में और भारत में जिनको ये बीमारी है।
We've known for several decades now why people get tuberous sclerosis. It's a genetic disorder caused by our genes. Here you see a picture of 46 chromosomes that each of us have that define who we are, how tall we are, what color our skin is. And 2 of those genes are responsible for causing tuberous sclerosis. One is on chromosome 9 and the other is on chromosome 16.
सो हम में गुणसूत्र रहते हैं, ये आपको पता होगा, हिंदी में गुणसूत्र बोलते हैं, जीन्स बोले जाते हैं, टिपिकली अपने बॉडी का सॉफ्टवेयर रहता है, तो उसमें जो भी लिखा हुआ रहता है हम पूरे जो है उस हिसाब से है, जो लिखा है हम वैसे है, फिर अपनी हाइट ले या कलर ले या बीमारी ले। तो ट्यूबरस स्क्लेरोसिस क्यों होती है, क्योंकि ये बीमारी क्यों होता है, क्योंकि 2 अमुक गुणसूत्र पे नंबर 9 और नंबर 16 पे के स्ट्रक्चर में अगर चेंजेस आते हैं तो उसके वजह से ये बीमारी एक्चुअली दिखाई देती है।
Tests genetically, if those tests are negative, we are still investigating newer ways to find those mutations. And this is a paper that we did several years ago with Dr. Kwiatkowski, in which we showed that those more advanced tests that we can be done today are able to find those mutations.
सो ये गुणसूत्र चेक करने के लिए टेस्ट है। टिपिकल स्टैंडर्ड टेस्ट में 85% मतलब काफ़ी ज़्यादा पेशेंट्स के गुणसूत्र में जो खराबी है वो जांच की जा सकती है। जो 15% है जिसमें स्टैंडर्ड टेस्ट में नहीं मिलता है, उनके लिए अलग अलग टेस्ट का रिसर्च हुआ है, जिससे हमें दिखाई देता है कि वो गुणसूत्र के स्ट्रक्चर में चेंजेस आए हैं और उसके वजह से ये बीमारी है। सो जेनेटिक टेस्टिंग जो ब्लड पे होता है, ब्लड का सैंपल लेके जो जेनेटिक टेस्ट करते हैं, उसमें ये बीमारी का कन्फर्मेशन मिल सकता है।
We also did a study looking at the specific mutations that individual patients have, and this is the larger of the gene 2C2, and this is the smaller of the gene. And the important thing here is that we see mutations all through the protein that can lead to the diagnosis. This is important for us as medical doctors, as scientists, because as we move into a future where we explore genetic treatments, this makes our job harder, but we are not giving up.
सो जो एक पहले साइड पे दिखाया था क्रोमोसोम 9 और 16 पे खराबी होती है, उधर TSC के जीन्स हैं, एक है TSC2 एक जीन का नाम है और दूसरा है TSC1। तो ये जब भी और बारीकाई में इसका अभ्यास करेंगे तो आप देखेंगे कि सिर्फ एक जगह पे खराबी के वजह से बीमारी नहीं होती है, ये जीन के अलग अलग जगह पे अगर उसमें खराबी है, जो वो बनी है वो ठीक तरीके से नहीं बनी है, तो उसके वजह से बीमारी के लक्षण दिखते हैं। पर लक्षण सेम दिखते हैं, वो ऊपर के जीन में खराबी है, नीचे के जीन में खराबी है, उससे फ़र्क नहीं पड़ता है, जो बीमारी दिखती है वो सेम दिखती है। तो ये क्यों महत्वपूर्ण है, जो आगे के ट्रीटमेंट्स आपने जीन थेरेपी के बारे में सुना होगा, जो नई नई दवाई आएंगी, वो ये जगहों को के काम को चेंज करने की कोशिश करेगी, और अगर इतनी सारी जगह है तो वो दवाई बनाना उतना ज़्यादा मुश्किल हो जाता है। पर उसका भी रिसर्च चल रहा है कि ये जीन के काम को ही बदल दे, जिधर खराबी आई है वो ही दुरुस्त करे, ताकि आप बीमारी को बहुत अच्छी तरीके से ट्रीट कर पाए।
What we are starting to do is start to do types of research that if we can, that once we know the specific mutation of an individual, to try to use that information to predict what is going to happen in the future for that specific patient. This is still a lot of work to be done. These are just very few of the first papers that start to look at that analysis, where each individual can have, hopefully, their story planned out. That helps us to know how to treat better. But this is something that we're still working on today, that we don't have full answers.
हमारे मन में हमेशा ये सवाल आता है डॉक्टरों के कि अमुक जगह पे वो जीन में खराबी है, तो उसके वजह से जो बीमारी होती है उसका कुछ कनेक्शन है क्या, कि ये जगह पे जीन में चेंजेस है तो बीमारी में दिखने में ये दिखेगा, अमुक जगह पे है तो अमुक दिखेगा. तो ये जो फाइनल कोरिलेशन है, कांट थिंक ऑफ हिंदी वर्ड फॉर दैट, मतलब जीन में किधर खराबी है और आपको जो बीमारी के लक्षण दिखते हैं उनमें जो संबंध है क्या, ये एस्टैब्लिश करने की कोशिश कर रहे हैं. ये सब करने का अगेन उद्देश्य यह है कि ट्रीटमेंट, जो जीन डिसीज़ मॉडिफाइंग ट्रीटमेंट आएंगे, जो फाइनल बड़े ट्रीटमेंट आएंगे, उनमें ये सब रिसर्च बहुत महत्वपूर्ण होता है. तो आपके नज़र से ये देख के आपको हौसला बढ़ना चाहिए कि इतना डीप में इतना गहरा रिसर्च हो रहा है जिससे ये बीमारी को एक्चुअली जड़ से बदल सके.
So we talked a lot about the genes, and this is what we call DNA. And the way that genes make a person is that the DNA gets copied into what we call RNA, and RNA gets copied into what's a protein, and then the proteins together form a full person. The example I like to use to explain this is that we have a cookbook of many different recipes, and when we want to cook something, we pull out the specific recipe and copy its instructions. And when we follow those instructions, we're able to make a specific type of food. And when we put all those foods together, we have a complete feast. And so this is the process that our genes make up who we are.
So ये जो जीन्स कैसे जीन में जो भी लिखा है उससे हम कैसे बनते हैं, ये एक समझने की कोशिश है. तो जैसे पूरी थाली बनानी है खाने, मैं उल्टा एक्सप्लेन करूँगी. इट्स नॉट प्रॉब्लम. यू कैन नॉट बी वर्ड. सो पूरी थाली बनानी है, रोटी सब्जी दाल चावल सब फाइनल खाना चाहिए. तो हर एक पदार्थ सेपरेटली बनाना है. वो पदार्थ कैसे बनाना है उसका हर एक का एक रेसिपी है. तो वैसे ही हम जो पूरे बने हैं, अगर बिल्डिंग ब्लॉक्स जो बोलते हैं किस चीज़ से बने हैं, वो छोटे छोटे चीज़ें साथ में आके बनता, जैसे पूरा थाली बनता है, वैसे ये सब जीन्स एक साथ में काम करके प्रोटीन मतलब अपने स्ट्रक्चर्स बनाते हैं, और वो सब साथ में आते हैं तभी हम बनते हैं. पर तो फाइनल उसका जो सॉफ्टवेयर है, जो लिखा हुआ है, जो कोडिंग है, वो अपने जीन्स में या डीएनए में है.
So this is that same process for tuberous sclerosis. Because of the genes, we see that every part of the body can be affected by tuberous sclerosis, including the brain, the lungs, the kidneys, the heart, the eyes, and the skin. And it's all these different manifestations that make TSC a complicated disorder for us to treat, and we need lots of different doctors working together.
सो जो TSC की जीन है, वो जो प्रोटीन बनाती है, वो केमिकल काफ़ी सारे बॉडी के सिस्टम्स में यूज़ होता है. तो ब्रेन में भी उसका वो केमिकल का काम है, हार्ट में काम है, आँखों में काम है, स्किन पे काम है, त्वचा पे, किडनीज़ में है, लंग्स में है. जैसे नमक 10 चीज़ों में डलता है, आप खाना बना रहे तो वो नमक कैसा है उसके ऊपर आपका रोटी का भी टेस्ट डिपेंड करेगा, सब्ज़ी का टेस्ट डिपेंड करेगा, दाल का टेस्ट डिपेंड करेगा. वैसे ही TSC जीन में अगर चेंजेस आते हैं तो सिर्फ ब्रेन में या सिर्फ हार्ट में प्रॉब्लम होता है, ऐसे नहीं है. क्योंकि ये जो जीन जो केमिकल बनाती है वो ये सब इतने सारे ऑर्गन्स में यूज़ होता है. तो अगर वो TSC जीन में खराबी है तो बीमारी के लक्षण ये सब ऑर्गन्स में दिखाई देते हैं. ब्रेन में दिखाई देगा, हार्ट में दिखाई देगा, आँखों में, किडनीज़ में एंड सो ऑन. तो फिर ये पेशेंट की अच्छे से अगर बराबर से उनको मेडिकल ट्रीटमेंट देनी है तो ये सब स्पेशलिटी के डॉक्टर को साथ में काम करना है ताकि वो पेशेंट को पूरे बीमारी का बराबर ट्रीटमेंट मिले.
And after lunch, we will hear from several of these different specialists on how they recommend that we treat tuberous sclerosis.
खाने के बाद डॉक्टर प्रणति ने ये हर एक बीमारी के स्पेशलिस्ट को बुलाया है. तो हार्ट को कैसे मैनेज करेंगे, स्किन को कैसे मैनेज करेंगे, ये भी डिटेल में दोपहर को आपसे बात होगी.
Yes.
So they say that it's a genetical disorder, right? But my question to you is, mine was a normal pregnancy. And when my son was born, he was normal, healthy child. But his body, his skin, he had white color patches. So when he was 3.5 months old, we got to know that his a TSC, he was diagnosed with TSC. So now my question to you is, since my pregnancy was a normal one and I was very healthy, I did not have any idea that that my baby had some kind of defect.
Mm-hmm.
So in such cases, as we say that the chromosome TSC1 and TSC2 is affected. If it is present in a person's genes, then it is affected, right?
Mm-hmm.
So as a normal human, how will I get to know that that I need to get this genetical test done?
So it is a genetic disorder, but in most people, 2 out of every 3 people, the baby is the first person in the family to have the genetic mutation. The mother nor the father have the mutation. Only in 1/3 of cases do we find that the mother or the father also had the diagnosis. Maybe they knew that, maybe they didn't, but only 1/3 of the time do we find the mutation in the parents. So most families have no warning, and it happened. The mutation happened sometime after the seed of the father and the seed of the mother joined, and so that's why nobody else in the family has the diagnosis. What we know then is that child goes on to have children of their own. They will pass that on because they are now the first person in that family to have the diagnosis. As far as making the genetic diagnosis in parents after a child who has been born unexpectedly with tuberous sclerosis, we ask our families to consult with a genetic specialist to help understand how that happened and if and what other tests should be done for the family. And particularly if they want to have more children, if they can help with that process of identifying their options to do so.
Thank you so much. I got it. Thank you.
Okay. Translate for the other families. Yeah.
So सवाल ये था कि बच्चे के जन्म होने के पहले समझ सकते हैं क्या, बता सकते हैं क्या कि वो बच्चे को TSF का प्रॉब्लम है एंड वो ना होने से रोक सकते हैं क्या, प्रिवेंट कर सकते हैं क्या. सो TSC ऐसी बीमारी है कि जो पहला बच्चा अफेक्टेड है, वो पहला पेशेंट रहता है वो फैमिली में, और पहले से पता होना बहुत मुश्किल है. कॉमन बीमारी नहीं है तो रेगुलर टेस्टिंग नहीं होता है जब भी प्रेग्नेंट है. सो ये जब भी बच्चा पेट में है तभी मालूम होना तभी पॉसिबल है अगर माँ बाप को ऑलरेडी वो बीमारी है और फैमिली में किसी को हिस्ट्री है और डॉक्टर्स देख रहे हैं कि नेक्स्ट बच्चे को हो रहा है क्या. बट मेजॉरिटी ज़्यादातर पेशेंट्स में ये पहले से पता नहीं होता है. बच्चे के जन्म के बाद ही विविध लक्षण दिखते हैं और तभी पता चलता है कि ये बीमारी उनको है. सो पहले से पता करके प्रिवेंट करना तभी पॉसिबल है अगर फैमिली में और किसी को है एंड इसके लिए आप चेक कर रहे हैं पहले से कि अगले पीढ़ी में ना हो. बट अदरवाइज जो पहला केस होता है उसको प्रिवेंट कर ना होने देना बहुत मुश्किल है.
Many times we can make the diagnosis even without DNA testing because of the ways that we look for how tuberous sclerosis affects the body. We define these findings that doctors can either find in the clinic by examining a patient with tuberous sclerosis or by ordering tests. We divide those into major and minor criteria. The major criteria are those criteria that when they are found, the doctor should think very quickly about that this is tuberous sclerosis until they can't, until there's something else. I mean, it's the number one diagnosis for these criteria. There's also other criteria which we call minor criteria, and these are things that are common in tuberous sclerosis, but it's harder for the doctors to necessarily know for certain that tuberous sclerosis is the cause.
Could you go back? Yeah. So कुछ लक्षण हैं. So डायग्नोसिस बनाने के लिए, निदान बनाने के लिए कि अमुक पेशेंट को ट्यूबरस क्लोरोसिस है, जेनेटिक टेस्ट की ज़रूरत नहीं होती है. पहला रो है जो आप देख रहे हैं, जो डॉक्टर बिना टेस्ट किए ही लक्षण पहचान सकते हैं. जैसे चेहरे पे छोटे छोटे पिंपल्स के जैसे ट्यूमर्स हैं, वो वाइट पैचेस है जो आपने मेंशन किया, या रफ पैच आता है स्किन पे, नाखून के अंदर छोटे छोटे गांठ के जैसे रहते हैं, आँखों में देख सकते हैं और आँख के पर्दे पे लक्षण दिखते हैं. तो एंड नीचे के लाइन में टेस्ट दिखाई दिए हैं. ये सीटी स्कैन्स और एमआरआई है पेट के, मतलब किडनीज, लंग्स और ब्रेन के, जिसमें ट्यूबरस क्लोरोसिस के लक्षण दिखाई देते हैं. तो अगर इनमें से कोई भी लक्षण है तो जेनेटिक टेस्ट की ज़रूरत नहीं पड़ती है ये निदान या डायग्नोसिस पक्का करने के लिए. ये लक्षण देख के ही कंफर्म हो जाता है कि वो पेशेंट को ट्यूबरस क्लोरोसिस की बीमारी है. नेक्स्ट स्लाइड. फिर कुछ ऐसे भी लक्षण हैं जो दिखते हैं, जैसे बहुत छोटे छोटे वाइट दाग स्किन पे, या दांत में वो डेंटल पिट्स, मतलब छोटे से खड्डे के जैसा दिखता है दांत में. किडनीज में छोटे छोटे सिस्ट दिखाई देते हैं. ये सब चीज़ें बाकी की बीमारियों में भी दिखाई देती हैं. तो सिर्फ ये लक्षण है तो फिर डॉक्टर 100% ट्यूबरस क्लोरोसिस का डायग्नोसिस सिर्फ ये लक्षण पे नहीं बना सकते, फिर जेनेटिक टेस्ट या और किसी टेस्ट की ज़रूरत है. पर जो पहले स्लाइड पे जो लक्षण दिखा है वो अगर है तो जेनेटिक टेस्ट, वो ब्लड टेस्ट किए बिना ही ट्यूबरस क्लोरोसिस का निदान पक्का किया जा सकता है.
One of the other reasons why we need a team of specialists to take care of tuberous sclerosis is because it looks very different depending on how old the patient is. We see certain parts of tuberous sclerosis more common when a child is recently born compared to a child who is in school, compared to a child who is a young adult, or even adults with tuberous sclerosis. It can look very differently depending if you're very young, childhood, or if you're an adult, because different things happen at different times.
सो हमने देखे कि काफ़ी सारे लक्षण हैं. हार्ट में है, स्किन पे, चमड़ी पे है, ब्रेन में है, आँखों में है, किडनीज में है, लंग्स में है. ये सारे लक्षण पहले दिन नहीं दिखाई देते हैं. ये उम्र के साथ कई लक्षण दिखाई देते हैं. सबसे शुरू में हार्ट में और स्किन पे जो वाइट पैचेस है, चमड़ी पे वाइट पैचेस है, वो दिखाई देते हैं. हार्ट का निकल जाता है, स्किन का रहता है, फिर बढ़ेगा, फिर ब्रेन के एमआरआई में खराबी दिखेगी. डाउन द लाइन आप प्यूबर्टी के दरमियान लंग्स में प्रॉब्लम दिखाई दे सकते हैं, और बड़े होके किडनी में प्रॉब्लम्स दिखते हैं. तो ये एक दिन एक टाइम पेशेंट को देखेंगे, उसी दिन वो टाइम पे सब लक्षण सब ऑर्गन्स में है, ऐसा ज़रूरी नहीं है. समय के साथ अलग कोई लक्षण निकल जाते हैं और कोई लक्षण आते रहते हैं. तो इसके लिए सब स्पेशलिस्ट को साथ में ये पेशेंट को देखना, एंड एक बार देखना नहीं, देखते रहना. आपके डॉक्टर बुलाते हैं आपको कि वापस आना है 6 महीने में, 1 साल में ये टेस्ट करनी है. उसका उद्देश्य यही है कि ये जो धीरे धीरे अलग अलग लक्षण पैदा हो रहे हैं वो समझ में आए, जल्दी समझ में आए. सो ये ऐसी चलने वाली, ये खुलती जाती है बीमारी किताब के जैसे. विद टाइम अलग अलग लक्षण दिखाई देते हैं, पर ज़रूरी नहीं है कि सब पेशेंट में सब लक्षण दिखाई दे. किसी में हार्ट में ट्यूमर हो ही ना, किसी में किडनी का प्रॉब्लम हो ही ना, तो ज़रूरी नहीं है कि सब में सब होगा. और इसके लिए आपको डॉक्टर टेस्टिंग करने को भी बोलते हैं.
कब तक, कौन सी एज तक ये दिखाई देगा? उम्र बता ऐसे ही रहेगा या फिर कुछ एज का लिमिट है कि 10 साल 15 साल?
ओके, सो दे आर सेइंग इज इट एज लिमिटेड द कंडीशन, और लाइक फॉर 10-15 years वुड इट बी देयर एंड देन गो अवे, और
No, tuberous sclerosis will be there the entire life because of the DNA is inherited for the entire life.
So ये जन्म भर की बीमारी है, क्योंकि वो गुणसूत्र में लिखा हुआ है. उसमें जो लिखा हुआ है वो अपना भाग है, बेसिकली अपना मूलभूत भाग है. वो निकालना या चेंज करना मुमकिन नहीं है, ना ही CTS में कोई भी बीमारी में मुमकिन नहीं है. तो क्योंकि ये जेनेटिक गुणसूत्र में लिखी हुई बीमारी है, ये बीमारी आपके साथ जिंदगी भर रहती है. वो अपना एक्चुअली भाग है. ओके, पर वो जो लक्षण आते हैं वो अलग अलग समय पे आते हैं, एंड वो पता है कौन से उम्र में कौन से लक्षण आने का चांस है. इसके लिए डॉक्टर्स को टेस्ट करते रहते हैं, जागरूक रहते हैं कि अभी ये प्रॉब्लम हो रहा है क्या, तो पहले से टेस्ट करके पता चले. बट ये लाइफ लॉन्ग बीमारी है, इसके साथ फैमिली को और पेशेंट को जीना है.
So for the second part of my talk, I'm going to talk about now the treatments that we're working on that are specifically designed for tuberous sclerosis. And to understand this, I have 3 cartoons that I'd like to show. I talked about TSC1 and TSC2, and they have one important job. They probably have other jobs as well, but one that they know is very important for tuberous sclerosis, to where they have to keep another signal in the body under control. And that signal is called mTOR, or mechanistic target of rapamycin.
I'm going to try and give my own example. Okay. So ये समझाने की कोशिश कर रहे हैं कि जो नई दवाई आई है वो कैसे काम करती है. ओके. पर ये कैसे डिस्कवर हुई ये समझ के कि ये जीन्स कौन सा काम उनको करना था जो नहीं कर रहे हैं एंड क्या सब्स्टिट्यूट करना है. सो TSC1 और TSC2 आपको दिखा रहा है वो जीन्स के फोटोज़. ये 2 जीन्स में खराबी है. अगर ये खराबी नहीं है ये जीन्स में तो उनका काम है ये एक mTOR नाम के बच्चे को कंट्रोल में रखना. ओके. बट क्योंकि TSC1 और TSC2 जो उनका काम है वो बराबर से नहीं कर रहे हैं, इसके लिए उसके वजह से ये mTOR नाम का बच्चा काबू में नहीं रहता है. ओके. सो इट्स लाइक मॉनिटर है 2 क्लास के, वो उनका काम नहीं कर रहे हैं एंड ये mTOR को कंट्रोल में नहीं रख रहे हैं, इसलिए mTOR जो काम नहीं करना चाहिए वो करता है. ओके.
And in somebody with the diagnosis of tuberous sclerosis, that control is lost and mTOR is allowed to run free.
सो क्योंकि ये पुलिस या मॉनिटर mTOR को काबू में नहीं रख रहे हैं, mTOR उसके मन में जो आ रहा है वो कर रहा है जो नहीं करना चाहिए, पर क्योंकि वो काबू में नहीं है बीमारी होती है. ओके.
And over the last 20 years, we've worked on making medicines that can slow or stop mTOR from running free, and therefore replacing the job that TSC1 and TSC2 can't do by themselves.
वेरी नाइस. सो जो रिसर्च किया गया है वो ऐसी दवा ढूंढने का रिसर्च हुआ है जो TSC1 TSC2 का जो टेक्निकली काम था जो वो नहीं कर रहे हैं वो काम दवा करे. क्या काम है? ये mTOR नाम के नॉटी बच्चे को काबू में रखें. तो ये दवाइयाँ जो आई है ये mTOR नाम के केमिकल को काबू में रखने की दृष्टिकोण से है, क्योंकि वो ओरिजिनली TSC का जीन्स का काम था जो वो नहीं कर रहे हैं.
And we use 2 medicines that we call mTOR inhibitors. The oldest is called sirolimus, and the newer one is called everolimus. But both of them work excellent in the treatment of tuberous sclerosis, and we prescribe both of them in our clinic.
सो 2 दवाइयाँ हैं जो ये mTOR को काबू में रखने के लिए अभी यूज़ की जाती है. पुरानी दवा का नाम है साइरोलिमस, नई दवा का नाम है एवरोलिमस. पर पुरानी नहीं है इसके लिए उनमें फ़र्क ऐसे नहीं है, दोनों बहुत अच्छी तरीके से काम करते हैं ये mTOR को काबू में रखने के लिए, कंट्रोल में रखने के लिए.
And in fact, the Food and Drug Administration that regulates medicines in the United States has approved both of them for specific treatments in tuberous sclerosis, some for brain tumors, some for kidneys, some for the lungs, and some for the treatment of epilepsy. But we use both.
सो गए साल में ही फाइनली अमेरिका में एक ऑर्गेनाइजेशन है FDA जो मतलब कोई भी डॉक्टर उधर कोई भी दवा लिख सकता है ऐसे नहीं चलता है. जो वो FDA बोलते हैं कि ये दवा अमुक बीमारी के लिए चलेगी तो ही लिख सकते हैं, अप्रूव की जाती है ताकि देखा जाए कि ये बराबर दवाई बराबर पेशेंट्स को मिल रही है. तो गए साल में US के FDA ने, और वैसी ही संस्था है यूरोप में जिनका नाम है EMA, यूरोपियन यूनियन में, यूरोपियन मेडिसिन एजेंसी. तो ये दोनों संस्था ने TS के अलग अलग लक्षण के लिए ये दोनों दवा अप्रूव की है. ओके. सो ब्रेन के ट्यूमर्स के लिए एवरोलिमस अप्रूव हुआ है, किडनी के ट्यूमर्स के लिए भी एवरोलिमस अप्रूव हुआ है, लंग्स के ट्यूमर्स के लिए, लंग्स में जो सिस्ट बनते हैं बड़े टिपिकली लेडीज़ में, उनके लिए सिरोलिमस अप्रूव हुआ है. एंड एपिलेप्सी के लिए जो खराब एपिलेप्सी है जो काफ़ी सारी दवा से कंट्रोल में नहीं आ रही है उसके लिए भी एवरोलिमस का यूज़ अप्रूव हुआ है.
generic name of the medicine or
This is no, this is a generic name. This is not the brand name.
is there any Indian medicine name?
There are quite a few.
Yeah.
We might come to it. No, so
Yeah.
So,
And actually, I would like to answer that.
Yeah.
In our clinic, we use generics.
Yeah.
We also use brand names. It depends on which is the easiest for the family to have access to. But our experience, we feel very comfortable with the generic versions in our patients, and we can do blood tests to verify that the medicine is indeed getting to the person's body.
सो सवाल ये था कि ये नाम दवा का केमिकल नाम है कि वो ब्रांड का नाम है. ओके, सो ये दवा का केमिकल नाम है. इंडिया में ओरिजिनल ब्रांड जो है वो भी मिलता है और इंडियन कंपनीज बनाने वाले ब्रांड भी मिलते हैं. अमेरिका में वो उनके क्लिनिक में दोनों यूज़ करते हैं, जो ओरिजिनल है वो एंड जो जेनेरिक मतलब दूसरे किसी ने कॉपी करके बनाया है वो. एंड टिपिकली एक्सपीरियंस अच्छा रहा है. ओरिजिनल मॉलिक्यूल आप यूज़ कर रहे हैं या वो कॉपी वाला यूज़ कर रहे हैं, इफेक्टिव है. एंड चेक भी कर सकते हैं, एक तो पेशेंट में कैसा असर आ रहा है वो, और एक ब्लड टेस्ट कर सकते हैं जिसमें वो दवा कितना है आपके बॉडी में वो नाप सकते हैं, एंड उससे समझ में आता है कि वो बराबर से काम कर रहा है कि नहीं.
And we continue to investigate these medicines for many other treatments in tuberous sclerosis. Although we don't yet have the agency approvals yet, we are still trying to get them.
सो एक 3-4 कारण के लिए ये सिरोलिमस एवरोलिमस यूज़ होता है, ये तो अप्रूवल आया है. पर बाकी के ट्यूबरस क्लोरोसिस के जो लक्षण हैं, हार्ट के ट्यूमर्स वगैरह, उसके लिए भी रिसर्च चालू है, अप्रूवल का प्रोसेस चालू है कि यही दवा यूज़ कर पाएँ.
Because of the time today, I don't have the opportunity to go through each and every part of tuberous sclerosis and its treatments. Some of that we will get with the experts this afternoon. But if you ever want to read on your own what those recommendations are, this website address can get you to the 2 major scientific papers that talk about all the different diagnosed symptoms of tuberous sclerosis and when they occur. And then the other paper talks about the specific tests and treatments that we have studies and approvals for.
सो इसके बारे में और जानना है आपको, तो वेबसाइट पे ये पूरा जो रिसर्च हुआ है और जो गाइडलाइंस है कि कैसे लक्षण के साथ डायग्नोज करना है ट्यूबरस क्लोरोसिस को और उसको क्या टेस्ट करते रहने हैं, ये सब वेबसाइट पे ज़्यादा बारीकाई में आपको पढ़ना है तो अवेलेबल है. आपके एनवलप में आपको बुक्स मिले हैं TS अलायंस के, तो उसमें भी वो वेबसाइट का एड्रेस होगा, लिंक होंगे, जिससे आप अगर अधिक माहिती चाहिए आपको, आपके डॉक्टर को पढ़ना है, फैमिली डॉक्टर को पढ़ना है, पीडियाट्रिशियन को और पढ़ना है, तो ये उनको लिंक दे सकते हैं.
The other resource is Tuberous Sclerosis Alliance of India. They have a website, they have a WhatsApp group. Did you already say that?
Say that, yeah.
Okay,
yeah,
all right. Just know that this information we want everybody to have is my point.
So जितने लोगों को बारे में को ये बीमारी के बारे में पता है, वो बच्चे के सराउंडिंग, फैमिली है, टीचर्स है, अलग अलग प्रकार के डॉक्टर्स है, ये बहुत अच्छी तरीके से पढ़ी गई बीमारी है. उसके बारे में बहुत सारा इन्फॉर्मेशन है कि कैसे अच्छी तरीके से इसकी देखभाल करनी है वो बच्चे की. तो जो भी इंटरेस्टेड है उनको सबको ये पता होना बहुत ज़रूरी है ताकि वो बच्चे को बेस्ट केयर मिले. ओके, सो आप अभी पढ़ के जाएंगे, समझ के जाएंगे, पर और पढ़ना है तो ये वेबसाइट्स है, व्हाट्सएप ग्रुप है इंडिया का, जिस पे ये और माहिती को हिंदी वर्ड क्या है, माहिती से मराठी वर्ड, इंफॉर्मेशन मिल सकता है, पता चलेगा. हाँ.
All right, so I'm going to just focus on some specific parts of tuberous sclerosis that perhaps we won't cover as well, or that are stuff that we're still investigating. And I'm going to start with brain tumors. Brain tumors occur in about 1 of every 5 individuals with a diagnosis of tuberous sclerosis, and it's called a subependymal giant cellular cytoma, which is difficult to say, so usually we just call it SEGA.
सो 5 में से 1 ट्यूबरस क्लोरोसिस के पेशेंट को ब्रेन में गांठ आती है, ट्यूमर आते हैं. ये कैंसर की गांठ नहीं है पर गांठ है, एंड उसका नाम है सेगा.
Okay. We worry about these because if they are not appropriately imaged and followed and treated, they can get quite large and cause major complications or even death.
सो ये सेगा पे अगर ध्यान नहीं रखा, वो बढ़ है कि नहीं, और अगर है तो बढ़ रहा है कि नहीं, ये दो चीज़ों पे अगर ध्यान नहीं रखा तो वो बहुत ज़्यादा बढ़ के ब्रेन में काफ़ी सारे प्रॉब्लम पैदा कर सकते हैं, जिससे दृष्टि पे तकलीफ हो सकती है, कभी कभी मृत्यु भी आ सकती है. वो बढ़ते हैं, दे ग्रो. या
Yes, and I think I heard you say they're not cancer, they're not malignant, but they have complications because they block flow of things in the brain.
सो ब्रेन में जो अपने प्लम्बिंग के पाइप्स हैं, क्योंकि ये बढ़ते हैं, वो पानी के बहाव को रोक देते हैं, एंड उसके वजह से ब्रेन को बहुत तकलीफ होती है. तो कैंसर नहीं है पर बढ़ते हैं, एंड उस पर ध्यान रख सकते हैं.
And so one of the very early studies we did with mTOR inhibitors was to see if the medicines could treat the tumors instead of brain surgery. And this is one of our earliest studies of two patients this is what the SEGA looked like when he started treatment. This is what it looked like after just half a year of treatment. And this is what it looked like after 5 years of treatment. And you can see how it shrunk and then it stayed at a steady space. It doesn't make it disappear completely, but it stops it from growing. Here you see another patient looking from the side view where you see the tumor and then after 6 months and what it looked like after 5 years, and here's how the measurements looked on that response.
सो ये एक्चुअल पेशेंट के MRI के फ़ोटो है, जिनमें पहले इसमें आप देखेंगे कि वो ट्यूमर काफ़ी बड़ा है. उनको ये एवोरिलिमस नाम की दवा दी गई, एंड कैसे धीरे धीरे वो ट्यूमर का साइज़ छोटे छोटे होके निकल नहीं जाता है पूरा, पर इतना छोटा हो जाता है कि उससे कुछ तकलीफ ना हो. तो ये दवा से मुमकिन है, दवा से उसको पूरा छोटा करके काबू में रखना मुमकिन है. और ये एक्चुअल पेशेंट्स के MRI के फ़ोटो हैं. Is the medicine lifelong?
Yes, it is.
लाइफ टाइम चालू रखना पड़ता है.
And here's another example of a patient in the second study we did where she had this brain tumor that occurred after her surgery. And here's what it looked like after 3 months, 6 months, and after 4 years.
ये एक्चुअली पेशेंट है जो इमरजेंसी में आए थे, द सेम वन राइट.
Same case as yesterday.
तो उनके स्कैन नहीं हो रहे थे, एंड अचानक बच्चे की तबीयत खराब हो गई, स्कैन किया तो दिखा कि वो बड़ा ट्यूमर है, तो उनको इमरजेंसी में ऑपरेशन करना पड़ा ब्रेन पे. तो वो पहला फोटो है ब्रेन के ऑपरेशन के बाद का, जिसमें वो पूरा ट्यूमर कभी कभी सर्जन नहीं निकाल पाते हैं. तो फिर वो बच्चे को ये दवाई चालू किया, एंड जस्ट अबाउट 3 साल में वो उतना बड़ा उधर वाइट ट्यूमर दिख रहा है ऑपरेशन के बाद बचा हुआ, और वो लास्ट इसमें दवाई चालू है, दवाई ले रहे हैं, एंड इतना छोटा सा हो गया ताकि उससे तकलीफ ना हो, क्योंकि कैंसर का ट्यूमर नहीं है, सिर्फ उसके साइज के वजह से तकलीफ होती है. तो साइज को कंट्रोल में रखे तो ये ट्यूमर से तकलीफ नहीं होती है पेशेंट को.
Yes. Of course, every medicine has side effects. The major side effects of this medicine is that it can make the cholesterol go higher and it can give patients mouth sores. Those are the 2 most common side effects. We do take precautions with infections because a small number of patients can have different or worsening infections, but most patients have no trouble with infections at all. And there's other side effects that can be very minor. But the 2 biggest ones that almost everybody will have to be monitored for is high cholesterol and whether they get canker sores.
And can you add one thing to it? That
Yes.
Does every patient get these,
No.
or how many patients get these side effects?
Probably we see canker sores in about 75% of patients, most of which are very mild. And as far as cholesterol, we'll see mild elevations of cholesterol in probably 60%, and then we'll have significant elevations of cholesterol, maybe another 20%.
सो सवाल ये था कि ये दवाई के साइड इफ़ेक्ट क्या है, लाइफ लॉन्ग लेनी है तो तकलीफ हो सकती है क्या. सो कॉमनली जो साइड इफ़ेक्ट दिखाई देते हैं वो दो है. एक इज़ मुंह के छाले, जो ऑलमोस्ट 75% पेशेंट में दिखाई देते हैं, बट इतनी तकलीफ नहीं होती है कि दवाई बंद करें. ओके। दूसरा साइड इफेक्ट दिखाई देता है जिस पे ध्यान रख सकते हैं इज कोलेस्ट्रॉल बढ़ता है ब्लड में। ओके, सो अबाउट 60% पेशेंट में कोलेस्ट्रॉल बढ़ता है, बट माइल्ड बढ़ता है। अगेन ज़रूरी नहीं है कि उसके वजह से दवा बंद करनी पड़े। तीसरी एक्स्ट्रा एक केयर ली जाती है कि जब भी बच्चे को ये दवाई चालू है तभी अगर और किसी कारण से बुखार आ रहा है, इन्फेक्शन हुआ है, सर्दी खांसी हुई है, तो वो थोड़े समय तक दवा को बंद रखते हैं ताकि अपना शरीर की प्रतिकार शक्ति बढ़े, जो दूसरा इन्फेक्शन हुआ है उससे लड़ने के लिए, और वापस चालू करते हैं। सो थोड़ी खबरदारी लेनी है जब भी और कुछ इन्फेक्शन हुआ है तभी। बट हर एक पेशेंट को दवा बंद करने की नौबत आए इतने साइड इफेक्ट नहीं होते हैं। सो जस्ट टू ऐड टू दैट, हाउ मेनी पेशेंट्स डू यू हैव टू डिसकंटिन्यू द मेडिसिन?
Very few, probably less than 5 in 100, maybe even only 2 in 100.
Right. So ये जस्ट ताकि आप एक्सपर्ट से सुने, मैंने उनको ये पूछा कि कितने पेशेंट में आपको दवा बंद करनी पड़ती है क्योंकि साइड इफेक्ट इतने हो रहे हैं कि वो टॉलरेबल नहीं है। तो 100 में से 2 से 5, मतलब 2 से 5 तक का पेशेंट में इतने साइड इफेक्ट होते हैं कि नहीं जी सकते उसके साथ और दवा बंद करनी पड़ती है। सो इससे आपको दिलासा मिलना चाहिए। बहुत कम पेशेंट्स में 2 बड़ी दवा है, बहुत कम पेशेंट्स में ऐसी साइड इफेक्ट होता है कि दवा एक्चुअल बंद करनी पड़े।
Good questions. I'm not going to spend very much time on kidneys. I believe we have a kidney specialist later today. Is that correct?
Yeah.
Yes. So the only part I'm going to talk about kidneys is say that we have tested these medicines to treat the kidneys, and we have it approved to treat the kidney tumors. You see an example of a patient here. And while we don't have approval, we've also been able to show that many patients with cysts in their kidneys can respond favorably to the medicine.
सो किडनी में ट्यूबरस क्लोरोसिस के 2 लक्षण दिखाई देते हैं। एक तो ट्यूमर दिखाई देते हैं जिसके लिए दवा अप्रूव्ड है और काम करती है वो ट्यूमर को छोटा करने के लिए। सो जैसे ब्रेन के गांठ को छोटा करता है वैसे किडनी में गांठ होते हैं उसको भी कम कर सकते हैं। किडनी में दूसरा एक प्रॉब्लम होता है टीएससी में इज़ छोटे छोटे पानी से भरे हुए सिस्ट फोड़ी के जैसे आते हैं। वो फोड़ी में भी शायद ये दवा काम करती है पर उसका अप्रूवल पेंडिंग है। सो सिर्फ ब्रेन के गांठ को नहीं, किडनी के गांठ के लिए भी यही दवा यूज़ होती है।
Sorry, what about the medicine we are giving, right? It affects every separately.
So good question. Yeah.
Because
Yeah.
long-term, there are high chances that it will grow and spread across multiple organs.
Yeah.
So when we are treating the medicine and is one organ or multiple organs?
That is an excellent question. You jumped to my last by the same genetic problem at their very start, and the medicine is attacking that genetic problem. We believe that we're treating everything. We just happen to have very specific ways to tell how it's working.
So सवाल ये था कि ये दवा जब भी दी जाती है तो क्या सिर्फ वो ब्रेन पे काम करेगी या सिर्फ किडनी पे काम करती है? तो ये जस्ट डिस्कशन के लिए आपको दिखा रहे हैं, बट जब भी पेशेंट दवा ये लेता है तो रिमेंबर ये दवा क्या कर रहा है, वो एम्प्टोर जो नॉटी बच्चा है उसको कंट्रोल में रख रहा है। फिर वो जिधर भी वो नौटीगिरी कर रहा है उधर सब जगह वो कंट्रोल में आ जाता है। ओके, सो जब भी पेशेंट दवा ये लेते हैं तभी ये दवा का असर ब्रेन पे भी होगा, किडनी पे भी होगा। तो जिधर भी गांठ है वही दवा से ये और जिधर जिधर अगर गांठ है तो वो कंट्रोल में आ जाती है। सिरोलिमस एंड एवरोलिमस। Right. So he's asking.
Yeah, go ahead.
Okay. So
You're the
आपके
expert on
बच्चे को
India. You're India expert.
So आपके बच्चे को अगर ज़रूरत है तो ही ये दवा देनी है। ये सब पेशेंट्स को जिनको ट्यूबरस क्लोरोसिस है उनमें सब में ये दवा की ज़रूरत नहीं है। इसके बारे में चर्चा इसके लिए हो रही है कि अब तक ये दवा का एंगल हमारे पास नहीं था। अगर ट्यूमर हो रहा है तो उसको ब्रेन में ट्यूमर हो रहा है तो ऑपरेशन करो, फिट्स आ रहे तो स्टैंडर्ड फिट का दवा दो, ऐसे काम चल रहा था। पर ये दवाई जो आई है ये बीमारी के जड़ तक जाती है कि कि जो जिस वजह से जो गड़बड़ हुई है ये TSC1 TSC2 जीन में, उसको सुधारने की कोशिश ये दवाई करती है। बट सब पेशेंट्स में ज़रूरी नहीं है, तो आपके बच्चे में अगर ज़रूरी है नहीं है, या आपके डॉक्टर के साथ जाके बात करके देखना है कि देने की ज़रूरत है क्या।
Okay. I'm going to talk just very briefly about skin. There's many different skin manifestations, but we have evaluated these treatments for skin manifestations in tuberous sclerosis, particularly for the face. We see up here these little angiofibromas of the face.
सो ये स्किन पे जो अलग अलग TS के लक्षण दिखाई देते हैं, उनमें भी ये दवा काम करती है। कैन आई जस्ट ऐड दैट इट्स ऑइंटमेंट बेस्ड है। सो पर अगर स्किन त्वचा की प्रॉब्लम के लिए ले रहा है तो गोली खाने की ज़रूरत नहीं है, इसका क्रीम बनता है जिससे ये स्किन के प्रॉब्लम को कंट्रोल कर जा सकता है। कौन से प्रॉब्लम के लिए लगता है? ये जो चेहरे पे दाग पिंपल्स के जैसे बट एकदम छोटे छोटे ट्यूमर के जैसे आते हैं। टिपिकली बच्चे 16, 18, 20 साल के हैं तो उनको वो लाल लाल एकदम अच्छा नहीं लगता है, तो उनके लिए यही दवा का क्रीम बनता है जिससे फ़ायदा होता है। एंड ये जो राइट साइड में छोटे बेबी को वो बड़ा लाल ग्रोथ दिखाई दिया है स्कैल्प पे, उस पर भी ये क्रीम के रूप में काम करता है, सेम दवा पर क्रीम के रूप में। No, yeah.
They buy the medicine and make cream themselves.
That's right, yeah.
So without the cream,
There's
this
a
is...
discussion about skin later, so that they should talk about it.
Yeah, I don't know if we have a skin specialist speaking this afternoon.
Oh, skin we are not having.
Yeah, that's why I chose to put a little bit of time today, okay? So treatment without the cream is using lasers that a dermatologist or a plastic surgeon can use, and use lasers to clear the face. But this usually has where they need repeated treatments every 6 months to 5 years.
So अगर क्रीम नहीं यूज़ करते या ये दवा पता होने के पहले कैसे ये हैंडल करते थे, वो पहले चित्र में दिखाई दे रहा है आपको कि कितने सारे ट्यूमर, जैसे पिंपल के से भी बहुत बड़े ट्यूमर है पूरे चेहरे पे, तो वो लेज़र ट्रीटमेंट करके स्किन के डॉक्टर ये ट्यूमर्स को छोटा कर देते थे, ट्रीट करते थे। आपको फ़र्क दिख रहा है लेज़र के पहले और लेज़र के बाद का।
And as Dr. Gadgil was mentioning, we do now use creams. Here's patients that were treated for 6 months before and after treatment. And we see that many times the redness of the facial angiofibromas can disappear, and sometimes they become more flat. They don't disappear completely, but they make the face much more presentable.
सो अभी जो एकदम लाल 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 एकदम दिखाई देता है वो कम हो जाता है। तो जो कॉस्मेटिक चेंज चाहिए टिपिकली टीनेज बच्चों को, वो ये क्रीम से मुमकिन है।
And this is not yet approved, but we have companies that are working on getting a form of it approved that the doctors can prescribe.
So अमेरिका में अलग अलग कंपनीज काम कर रही है ये क्रीम रेडीमेड बनाने के लिए, जो जस्ट जाके खरीद सकते हैं बाकी के दवा के जैसा। पर एज ऑफ नाउ कोई भी कंपनी रेडीमेड क्रीम नहीं बना रही है ये दवा से, तो जो आप जस्ट खरीद के यूज़ कर सकते हैं।
And so with the last of my remaining time, I want to talk about what we're trying to do in getting to your gentleman's question, can we treat everything? Normally when we see a disorder, we wait till somebody has seizures, or we wait till they have a brain tumor or a kidney tumor, and you go to the doctor and the doctor prescribes treatment for that problem. But it's always after something happens.
सो नॉर्मली क्या होता है, प्रॉब्लम होने के बाद ही आप डॉक्टर के पास पहुंचते हैं। फिट आने लगते हैं, फिट चालू होने के बाद आप डॉक्टर के पास जाते हैं। ब्रेन में ट्यूमर है तो उससे सर दर्द हो रहा है, चक्कर आ रही है, तो ये तकलीफ शुरू होने के बाद डॉक्टर के पास पहुंचते हैं, और उसके डॉक्टर नॉर्मली जस्ट रिएक्ट कर रहे हैं, प्रॉब्लम हुआ तो फिर उसकी ट्रीटमेंट चालू करो। ऐसा टिपिकली सब बीमारियों में होता है।
What we're trying to do in tuberous sclerosis is try to find ways that we can make the diagnosis and start treatment before brain tumors or before kidney tumors, or what I'll give an example of, before epilepsy happens.
So tuberous sclerosis एक बीमारी है, और ये बहुत बहुत यूनिक बीमारी है, जिसमें बीमारी के आप और हम डॉक्टर्स और पेरेंट्स बीमारी के एक कदम आगे रह सकते हैं क्या, ये करने की कोशिश जारी है। अदरवाइज हम जस्ट प्रॉब्लम होने के बाद उसको कंट्रोल करने की कोशिश कर रहे हैं। ये एक बीमारी है जिसमें उसके बजाय बीमारी के एक कदम आगे रहने का चांस है। वो कैसे आपको बताएंगे?
And so we're working on those type of studies for brain tumors and kidney tumors and for skin lesions like I've shown you. But one of the ones that I'm personally involved with is our strategy on how to identify epilepsy before a child begins having seizures.
सो बीमारी के एक कदम रहने के लिए किडनी के ट्यूमर्स, ब्रेन के ट्यूमर्स में तो काम हो ही रहा है, अब डॉक्टर डार्सी का खुद का काम फिट्स चालू होने के पहले कुछ कर सकते हैं क्या, इसमें रहा है.
And I don't want to go through this study in entirety, but this was a study we did of infants who were diagnosed with tuberous sclerosis before they had any seizures.
सो EEG हर महीने में वो बच्चों पे EEG करना चालू किया फिट्स चालू होने के पहले. ओके, निदान था ट्यूबरस स्क्लेरोसिस का, हर महीने में वो बच्चों पे EEG कर रहे थे.
And so when we did those EEGs every 1 to 2 months, we found that almost 80% of the time, the EEG gave us a warning that that child was getting ready to start to have seizures. And then we also found in over 70% of the time that the EEG, when it stayed normal, the child was not getting ready to have their first seizure.
सो ये क्या दिखाई दिया उनको कि जो बच्चों के EEG में खराबी दिख रही थी, जो बच्चों के EEG में खराबी दिखी उनमें काफ़ी अधिकतम शक्यता थी कि उनको आगे जाके फिट्स आएंगे, सीजर्स चालू होंगे, आकड़ी, मिर्गी, दौरा, आप जो भी समझते हैं, एपिलेप्सी चालू होगी. जो बच्चों के EEG में खराबी नहीं दिखाई दी, और रिमेंबर ये एक EEG नहीं, हर महीने में एक EEG, तो उसमें खराबी अगर EEG में नहीं, EEG साफ रहता है, अच्छा रहता है, नॉर्मल रहता है, तो वो बच्चों में आगे जाके फिट्स चालू होने का प्रमाण बहुत ही कम था, ना के बराबर. सो EEG के वजह से उनको बीमारी निदान हुआ है कि TSC है, रेगुलर EEGs कर रहे हैं, तो उससे समझ में आता था कि कौन से बच्चे को फिट आने की शक्यता है और कौन से बच्चे को फिट्स आने की शक्यता नहीं है. ये फिट्स आने के पहले वो जांच कर पाए. Routine, usually
pediatric neurologist will be able to do that.
Yeah, it is a common EEG that all neurologists know how to do.
And it's applicable for the adults also. Like my son is not having the seizure for last 3 years. So in that case, this is applicable for them also, or only for infants?
We've only studied for infants. That would be a wonderful question for us to ask. The study would be harder for us to do because of the wide age range, but that is an excellent question that I don't have an answer.
सो अभी तक रिसर्च सिर्फ बहुत नन्हे बालकों में ही हुआ है कि पहला फिट आने के पहले EEG करते रहे. सर का सवाल ये था कि ये कुछ स्पेशल EEG है या टिपिकली बच्चों के ब्रेन के डॉक्टर के पास जो EEG होता है उनमें से ही है, तो उनमें से ही है. EEG स्पेशल नहीं है, अलग ये है कि फिट चालू होने के पहले से EEG कर रहे हैं. ओके.
And now with that information, in addition to recommending that all infants with tuberous sclerosis have these EEGs done, we're also now starting studies that evaluate or prevent the long-term complications from epilepsy.
डॉक्टर डार्सी का खुद का आगे का रिसर्च इसमें चल रहा है कि हम लोग बता सकते हैं क्या कि किसको एपिलेप्सी होगी और अच्छी तरीके से, सिर्फ बता सकते हैं तो उसको ट्रीट कर सकते हैं क्या, और ना होने देने से मतलब होने से रोक सकते हैं क्या. रिमेंबर, जीन तो है खराब, फिर भी उसके लक्षण ना दिखे, ये बहुत बड़ी बात है. ओके, तो इनका काम इसमें है क्योंकि खुद न्यूरोलॉजिस्ट है. सो TSC जीन के वजह से जो मिर्गी होती है, एपिलेप्सी होती है, वो जल्दी समझे, एंड सिर्फ जल्दी समझे ना, दवा से वो उसको होने से ही रोके, इसमें इनका काफ़ी काम चल रहा है.
And although I am focused on epilepsy, there's other teams of researchers that around the world are working on the other parts of tuberous sclerosis, with the skin, with the kidneys, and with with other aspects of the brain, including TAND, which you'll hear from Dr. Gibson.
सो डॉक्टर डार्सी क्योंकि ब्रेन के डॉक्टर हैं, वो एपिलेप्सी के इसमें रिसर्च कर रहे हैं के विषय में, पर बहुत सारे अलग डॉक्टर्स हैं, सेंटर्स हैं, हार्ट के स्पेशलिस्ट, लंग के स्पेशलिस्ट, किडनी के स्पेशलिस्ट, जो देख रहे हैं कि और अच्छी तरीके से ये लक्षण TS के जो लक्षण होते हैं उनको और अच्छी तरीके से कैसे कंट्रोल में लाएं. एक स्पेसिफिक आज जिसके बारे में बात होगी इज टैंड का अर्थ समझाएंगे. टैंड देखता है TSC के साथ जो बिहेवियर, बौद्धिक विकास में जो तकलीफ़ें आती है उसको कैसे हैंडल किया जाए, उसकी कैसे देखरेख की जाए, तो उसके बारे में डॉक्टर तांजला गिब्सन जो काम कर रहे हैं वो आपके साथ बाद में शेयर करेंगे.
And the last thing we do is we continue to work on new medicines and new treatments. We still continue to use the mTOR inhibitors, but as you asked, is this a lifelong therapy? And for now, it certainly is. But we're looking on expanding from just symptomatic treatment to actually disease modification for the entire body. And we're also working on when to start treatment and what is the ideal dose, and we're looking across all different parts of the body.
जो दवाइयाँ अभी है वो कैसे अधिक अच्छी तरीके से यूज़ कर सकते हैं, कभी चालू करनी है, कौन से डोज में अच्छा रहेगा, क्योंकि लाइफ लॉन्ग देनी है, तो उसका जो फाइन ट्यूनिंग बोलते हैं वो रिसर्च भी काफ़ी चालू है, और सिर्फ ब्रेन में नहीं, सब ऑर्गन्स में.
And we also continue in the laboratory to look for new treatments that even can do a better job than what we already have with mTOR inhibitors.
और रिसर्च चल रहा है जो अभी तक लैब में ही है, मतलब पेशेंट्स तक नहीं आया है, जो इससे भी आगे की दवाई बने.
All of this work is massive teams of doctors across many different institutions, and so I certainly want to thank how much they helped me do this work.
सो ये इतना देख रहे कितने सारे डॉक्टर्स हैं, नर्सेज हैं, कोऑर्डिनेटर्स हैं जो साथ में आके ये बीमारी की ट्रीटमेंट को और सुधारने की कोशिश कर रहे हैं.
Thank you.
धन्यवाद.
Thank you, Dr. Kruger. My question is about, we've talked about and we've seen how effective these mTOR inhibitors such as everolimus on the physical manifestations, how effectively they are arresting or reversing even. What is the understanding of how effective in reversing or containing the learning difficulties or intellectual disabilities?
That is an excellent question, and if I didn't have a world's expert on that answer, I would answer it for you, but I'm going to defer that to Dr. Gibson and her talk. She's had some experience using this medication to treat behavior, and so if you will be patient, I will let her answer that in her talk.
Okay, thank you.
सो सवाल ये था कि ये जो नई दवाइयाँ हैं mTOR इनहिबिटर, वो बौद्धिक विकास पे और बिहेवियर पे में कितना फ़ायदा ला सकती है. तो डॉक्टर तांजला गिब्सन जो हमारी नेक्स्ट स्पीकर है वो ये विषय में एक्सपर्ट है, तो वो ये सवाल का जवाब उनके टॉक में देंगे. और कोई सवाल?
Well, thank you. I know at the end of the day we also have a question and answer period, so we'll take advantage of that. So thank you.
Yeah, cool. Thank you.
Thank you, Dr. Dasi and Pragnya as well for pitching in. Thank you. May I now call upon Dr. Tangela Gibson to speak on tandem spectrum. She's an associate professor of pediatrics and is board certified in both child neurology and neurodevelopmental disabilities. She founded the TSC Center of Excellence at Kennedy Krieger Institute and established an interdisciplinary model of cure for children and adults with TSC associated neuropsychiatric disorders. She has now moved to another hospital and the Bowling Center for Developmental Disabilities at the University of Tennessee Health Sciences Center in Memphis, where she has established a clinical and research unit dedicated to TSC-associated neuropsychiatric disorders. Her patient care emphasizes include tuberous sclerosis complex, adults and children with neurodevelopmental disabilities, and behavioral concerns and disruptive behaviors such as aggression and self-injury. I welcome Dr. Gibson to enlighten us on TAN spectrum. And I request Pragnya to pitch in again. Most of them understand Most of them understand Hindi. The rest of them can follow in English. Yeah.
Thank you for that kind introduction, Dr. Gupta, and thanks to all of you for being here, especially on a weekend. It's our last day. This is our third city, and I have to tell you, I've thoroughly enjoyed my time in your country, thoroughly enjoyed my time in your city. Every city has been a little different and unique, but I'm very excited to be here. So I'm going to speak to you today about tan spectrum.
सो डॉक्टर तांजना बोल रहे हैं कि ये उनका तीसरा शहर है, उनकी पहली विजिट है इंडिया को, इंडिया में। सो मुंबई, दिल्ली और अभी हैदराबाद में डॉक्टर्स के साथ और पेरेंट्स के साथ मिल रहे हैं और उनको बड़ा मज़ा आ रहा है ये करने में।
So I bring you greetings from Memphis, Tennessee in the U.S. This is one of our famous streets. It's called Bill Street. So it's known for blues music, barbecue foods, Elvis Presley. So if you ever visit us, this is a very fun street to visit.
सो ये उनके शहर का फ़ोटो है, सॉरी अभी मेम्फिस में रहते हैं। बड़ी एज यू कैन सी इंडिया के जैसे ही है, बहुत सारे कलर्स है, बहुत सारा जोश, बहुत सारा लाइफ है, ऐसे दिख रहा है। सो वो आपको सबको इनवाइट कर रहे हैं उनके शहर में।
So let's get right into talking about TAN. The term TAN stands for Tuberous Sclerosis Associated Neuropsychiatric Disorders. And the reason we came up with the acronym TAN and the reason that we're emphasizing it is because in tuberous sclerosis, we spend a lot of time on the epilepsy, on the tumors, on the skin manifestations, and those things are important. But we don't want to overlook these things, other things that can happen.
टैंड का अगर मैं कोशिश करने वाली हूँ इसको बराबर से ट्रांसलेट करने के लिए, टैंड का मतलब है ट्यूबरस स्क्लेरोसिस के साथ जुड़ी हुई जो बौद्धिक विकास में तकलीफ आती है, जो बिहेवियर में तकलीफ आती है, समझने में, बोलने में जो तकलीफ आती है, उसके अलग अलग पहलू है जो देखना उतना ही ज़रूरी है जैसे किसी ने पूछा था। तो ये टैंड करके जो एक चेकलिस्ट के जैसा एक है, तो ये सब पहलू को कवर करने की कोशिश करती है।
And each one of you in your packets today should have gotten a copy of the TAN checklist. If you would look in your packets and pull that out, and then raise your hand if you don't have one.
आपको जो एनवलप मिला है वाइट, उसमें टैन चेकलिस्ट है, तो वो अगर निकालेंगे तो डॉक्टर तांजला हर एक सवाल को उसमें से आपके साथ डिस्कस करेंगे। किसी के पास नहीं है, हाँ, ये कैन आई बोरो इट एक सेकंड के लिए, ये वाला सब आपके पास जो वाइट एनवलप है उसमें से ये चेकलिस्ट प्लीज़ निकालिए। आपको नहीं मिला है, आपको नहीं मिला है, आई थिंक आउटसाइड। थैंक्स। यू ऑल्सो डिडंट गेट, ओके। सो ये 4 पेजेस का चेकलिस्ट है जिसमें हर एक सवाल का हम लोग डॉक्टर तांजला उल्लंघन करेंगे।
Okay. And I'll kind of explain what's going on in the umbrella, but I kind of want to give the families who are going back out to get their TAN checklist a moment to get those. And again, if you don't have one, I don't see everybody with one. Did you guys have a TAN checklist in your packets?
No, they're getting some for them.
Okay, so they're getting some.
Oh, thank you. So, Megan, they have. We need a few. Thanks. You want to translate? No, don't worry. Can we have one more? You want one more, right? Okay. One. Oh, thanks. So 1, 2. अभी सबके पास है? आपको मिल गया। They need one. She's got it. You go get one for me.
For you?
No, I'm telling her. अभी सबके पास वो मिल गया उसमें से जो कागज टैन चेकलिस्ट करके लिखा हुआ है. Okay, I think everyone's got.
Okay, everyone has one? Okay, perfect. All right, and so there are different levels in TAN. And again, not everyone will get these symptoms, but we have to think about the behavioral level. And each one of these levels is in a different color on the umbrella. So behavioral, psychiatric, intellectual, academic, neuropsychological, and psychosocial.
ओके सो अलग अलग पहलू है बौद्धिक विकास के जो ये टैन चेकलिस्ट में कवर होते हैं. बिहेवियर मतलब बर्ताव, साइकेट्रिक मतलब आपका मूड कैसा है, इंटेलेक्चुअल मतलब बुद्धि, एक्चुअल बुद्धि समझ कैसी है, एकेडमिक मतलब वो जो समझ है वो आप पढ़ाई में कैसे कन्वर्ट कर सकते हैं या यूज़ करते हैं. न्यूरो साइकोलॉजिकल, ओ गॉड, anybody help me with the translation for neuropsychological in Hindi? मतलब ब्रेन के ना बहुत अलग काम होते हैं. सो इसमें से एक काम है आपकी बुद्धि ठीक है, बाकी सब ठीक है, पर आप ध्यान नहीं लगा सकते. फॉर एग्जांपल सो कंसंट्रेशन करना, एकाग्रता, ये एक साइकोलॉजी न्यूरो ब्रेन का साइकोलॉजिकल काम है. ओके, सो ये पहलू काम के. और साइको सोशल मतलब जो अपना बर्ताव है, जो समझ है, उसके साथ समाज के साथ कैसे हम लोग समाज का कैसा भाग के साथ कैसा डील कर रहे हैं, समाज का हिस्सा बन के कैसे रह रहे हैं, वो लेवल. सो ऐसे अलग अलग लेवल्स हैं ये टैन के स्पेक्ट्रम में.
Okay. So how often should we be screening for TAN? The recommendations that Dr. Kruger put up during his talk call for at least annual screening. In our clinics, we often do the TAN not only annually but at every visit. But if it's not possible at every visit for TSC, at least once a year we should be screening for TAN. And when we say screening for TAN, the screening starts with the TAN checklist that is in your hand currently.
सो ये टैन की जो जांच है वो कितने टाइम में करनी चाहिए. इनके क्लिनिक में पहले दिन जब भी टीएस के पेशेंट आते हैं तो उस दिन होते हैं, एंड फिर हर फॉलोअप विजिट में ये जांच की जाती है. बट कम से कम साल में एक बार तो करना ही है हर एक पेशेंट में कि ये टैन के प्रॉब्लम्स जो मैंने लेवल्स बताए अलग अलग, वो कुछ आ रहे हैं कि नहीं आ रहे हैं. मतलब देख रेख कर रहे हैं, ध्यान रख रहे हैं कि इसमें से कुछ तकलीफ तो पेशेंट को चालू नहीं हो रही है ना.
Okay. And then the second recommendation is that there be a comprehensive formal evaluation at these key ages, so 0 to 3 years and then beyond. And what comprises a comprehensive formal evaluation is an evaluation by a developmental pediatrician or a neurodevelopmental neurologist like myself, a speech and language evaluation, and a psychological or neuropsychological evaluation.
सो सिर्फ टैन चेकलिस्ट नहीं, पर ये उम्र में मतलब पहले 3 महीने में, फिर 3 से 6 महीने में, 9 महीने में, 1 साल में, 1.5 साल के बाद विकास, ब्रेन का विकास कैसे हो रहा है इस पे ध्यान रखना है. सो एक तो हुआ टैन चेकलिस्ट, पर दूसरा है कि जो न्यूरोलॉजिस्ट है आपके वो ये चेक कर रहे हैं, स्पीच एंड लैंग्वेज थेरेपिस्ट चेक कर रहे हैं कि जो कम्युनिकेशन बोलने का जो है वो डेवलप हो रहा है कि नहीं, और न्यूरो साइकोलॉजिस्ट मतलब क्लिनिकल साइकोलॉजिस्ट की बाकी के जो चीज़ें हैं, एकाग्रता का उम्र के हिसाब से विकास हो रहा है कि नहीं, सोशल सामाजिक स्किल्स के विकास हो रहे हैं कि नहीं उम्र के हिसाब से. तो ये हर टाइम, हर इनिशियली तो ऑलमोस्ट हर 3 महीने में, फिर हर 6 महीने में ये चेक करते रहना ज़रूरी है. So the neurologist, so it's a team. So that's what she said. 3 people, which I didn't translate too well, I suppose. So pediatric neurologist या developmental pediatrician, a clinical psychologist, speech and language therapist. Yes, all of them together. मतलब ये अलग अलग स्पेशलिस्ट साथ में आके ये बुद्धि के विकास के जो अलग अलग पहलू हैं वो तपास रहे हैं हर एक विजिट में.
Okay. The second recommendation is that if there is a diagnosed condition like ADHD or autism spectrum disorder or intellectual disability, that the practice parameter management strategies that exist from like the American Academy of Pediatrics or the American Academy of Neurology, different other organizations, that those management strategies be followed as well.
और ये जब जांच कर रहे हैं तो इसमें से कोई अमुक डायग्नोसिस आ जाता है, समझो किसी बच्चे को ऑटिज्म का डायग्नोसिस मिलता है, किसी को अटेंशन डेफिसिट हाइपर एक्टिविटी का डायग्नोसिस मिलता है, तो फिर ये डायग्नोसिस बनने के बाद उस पे भी ध्यान रखना है और उसका ट्रीटमेंट चालू करना है. ये दोनों चीज़ें ज़रूरी है. इनफैक्ट ये सब करने का उद्देश्य यही है कि कोई भी बौद्धिक विकास में तकलीफ आ रही है तो वो जल्दी समझ में आए और उसका हल, उसका ट्रीटमेंट करना जल्दी चालू हो जाए.
And then the need for an individualized education plan should be considered. In the U.S., we call this an IEP, but in every country there exists some format by which the schools and school officials can accommodate for your child or young adult for designated to their specific needs.
और ये अगेन ये करने का उद्देश्य ये है कि इसमें जो भी तकलीफें सामने आ रही हैं उसको ध्यान में रख के हर एक बच्चे के लिए उसका खुद का एक इसको बोलते हैं इंडिविजुअलाइज एजुकेशनल प्लान. मतलब वो बच्चे के लिए उसको पढ़ाना कैसे है, सिखाना कैसे है, उसकी जो भी लिमिटेशंस है, जो भी प्रॉब्लम्स हैं, उनको नज़र में रख के एक प्लान बनाना है जो स्कूल के साथ शेयर होता है, एंड ताकि स्कूल को भी पता है कि ये बच्चे को ये करना मुमकिन है पर ये करना मुमकिन नहीं है, तो इसके लिए फ्लेक्सिबल होके उसके लिए चेंजेस करने हैं, ताकि उद्देश्य ये है कि हर एक बच्चा उसके कैपेसिटी के हिसाब से सीखता रहे.
Okay. And then if there's a sudden behavioral change, those individuals should have a medical evaluation. As Dr. Kruger pointed out, it's very important to get an MRI because sometimes there could be an astrocytoma or a SAGA that can be causing a behavioral change in a child or young adult.
एंड ये सब करते हुए जो मेडिकल टेस्टिंग डॉक्टर क्रूगर ने बताई है वो भी साथ साथ में चलती रहेगी. कभी ज़्यादा भी करनी पड़ेगी अगर सडनली कुछ चेंज आता है किसी बच्चे के बर्ताव में, तो सोचना है कि अरे कोई मेडिकल रीज़न तो नहीं है, ब्रेन में ट्यूमर तो नहीं बढ़ रहा है, फिट्स तो नहीं बढ़े जिसके वजह से ये बर्ताव में प्रॉब्लम आ रहा है. तो ये दोनों चीज़ें साथ साथ में होती रहनी बहुत ज़रूरी है.
And then, so now let's look together at the actual TAN checklist. So I want to point out that this TAN checklist, you can do it yourselves and then bring it to your doctor. Your doctor can do it with you. It doesn't necessarily have to be a certain type of doctor. It can be whoever you're seeing for your tuberous sclerosis. It can also be a psychologist who does this with you. It's just very important for us to get this information and for you to be able to get your thoughts and concerns on paper.
सो ये चेकलिस्ट जो आपके हाथ में है वो कम से कम साल में एक बार आपको भरनी है. ज़्यादा भरेंगे तो ज़्यादा अच्छा है. तो किसके साथ भर सकते हैं, जैसे आपने पूछा, आपके डॉक्टर के साथ जो न्यूरोलॉजिस्ट है या पीडियाट्रिशियन है, डेवलपमेंटल पीडियाट्रिशियन है, उनके साथ कर सकते हैं, साइकोलॉजिस्ट के साथ कर सकते हैं. पर ये करते रहना रेगुलरली हर टाइम पे बहुत ज़रूरी है.
Okay, so what I'm going to do is just kind of go through the TAN checklist briefly just to give you an idea of each section. So this first section is concerned about early development, and we just want to know what age your child accomplished these milestones and if there are milestones they've yet to accomplish.
सो डॉक्टर तांजिला अभी हमें हर एक सेक्शन के बारे में थोड़ा ज़्यादा इंफॉर्मेशन देंगे. व्हाट्स अ हिंदी वर्ड फॉर माहिती, ज़्यादा जानकारी. थैंक यू सो मच. सो हर एक सेक्शन के बारे में ज़्यादा जानकारी देंगे. पहला सेक्शन जो है वो ये समझने की कोशिश करता है कि पहले टाइम आप जब भी टैन चेकलिस्ट कर रहे हैं तभी वो बच्चे का विकास का लेवल क्या है.
Section 2 is all about current level of development. So how does your child speak? How do they take care of themselves? And what is their mobility like?
दूसरा सेक्शन ये देखने की कोशिश करता है कि अगेन जिन कर रहे हैं चेकलिस्ट उस दिन बच्चे को क्या क्या स्किल्स ऑलरेडी है, चल सकता है कि नहीं, अपनी देखभाल खुद से कर सकते हैं क्या, व्यक्त कैसे करता है, बोल के करता है, साइन लैंग्वेज यूज़ करके करता है या कुछ भी नहीं बोलता है. तो ये सेकंड सेक्शन ये आइडिया देता है कि आज के दिन में बच्चे के रोज के फंक्शनिंग का लेवल क्या है.
Okay. In section 3, this is where we tend to spend the most of our times during a TAN screening or evaluation. Section 3 asks about a series of behaviors that can be very common in tuberous sclerosis. And although we ask for a yes or no answer in the TAN evaluations, we not only want to know yes or no, we want to know when did it happen, what treatments were helpful, were there any triggers, and then what sorts of things did the child respond to.
सो ये तीसरा सेक्शन है जो एक्चुअली इसमें सबसे ज़्यादा टाइम बिताने की ज़रूरत है हर टाइम जब ये चेकलिस्ट पूरा कर रहे हैं, क्योंकि ये बच्चे के उस वक्त के अलग अलग बर्ताव चेक करता है एंड इससे बहुत अच्छी तरीके से समझ में आता है कि बच्चे का रोज का बर्ताव कैसे है, समझ कैसी है एंड किधर ट्रीटमेंट में चेंजेस लाने हैं.
And at the end of section 3 and every section thereafter, there's going to be two key questions. One, have you had an evaluation or support for your concern? And two, would you like an evaluation or support for your concerns? And that's important because although somebody may be struggling with a behavior, it may not be something that you necessarily want intervention for, and we want to be able to respect your wishes.
सो ये सेक्शन के एंड में दो सवाल पूछे जाते हैं. पहला इज़ कि ये सब पहले कभी चेक किया गया है क्या, इवेल्युएट किया गया है क्या, कोई डायग्नोसिस ऑलरेडी बना है क्या, और ये जो भी प्रॉब्लम्स है उसके लिए आपको किसी ने सपोर्ट किया है क्या, कुछ ट्रीटमेंट चालू की है थेरेपी के रूप में, आईईपी के रूप में, जैसे भी, एंड इसके पहले हुआ है क्या, एंड ऑन ऑनगोइंग बेसिस आपको मदद की ज़रूरत है क्या, ये जो प्रॉब्लम्स सामने आए हैं ये चेकलिस्ट कंप्लीट करते वक्त.
In section 4, we ask, have these behaviors or concerns, do they add up to a formal diagnosis? Because you can have symptoms of a condition and not necessarily have that condition. So we want to know, has ADHD or autism or any of these conditions been formally diagnosed? If so, when and by whom?
सो सेक्शन 3 आपको लक्षण के बारे में पूछता है. सेक्शन 4 ये पूछता है कि इसके पहले ऐसे कुछ टेस्टिंग में बच्चे को ऑटिज्म है ऐसे दिखाई दिया है क्या, ADHD है ऐसे दिखाई दिया है क्या, सो अमुक कुछ डायग्नोसिस ऑलरेडी बना है क्या वो बच्चे के बिहेवियर के लिए, ये चेक किया जाता है सेक्शन 4 में.
In section 5, we asked about intellectual ability. There was a time we used this outdated term, mental retardation. We don't use that term anymore. We use intellectual disability. And what we mean by that is just simply that a child or young adult is functioning at an age that's less than his actual age. So maybe a 16-year-old child whose behaviors, communication, the way they take care of themselves is more like an 8-year-old child.
सो सेक्शन 5 ये चेक करता है कि बौद्धिक क्षमता आपके हिसाब से वो बच्चे की कितनी है. मतलब समझो कोई 10 साल का बच्चा है पर उसका रोज का बर्ताव, खुद का देखना, बाकी लोगों के साथ ये करना, ये 2, 3, 4 साल के उम्र के बच्चे के जैसे है क्या. तो आपको क्या लगता है कि आपके बच्चे की उम्र इतनी है पर आज के दिन में उनका जो बौद्धिक विकास हुआ है वो आपके हिसाब से कितने लेवल तक हुआ है.
And also in that section, this is where a formal psychological evaluation can give us information about IQ. But even if your child has not had a formal psychological evaluation, we ask, what is your view of your child's intellectual ability, I should say.
Right. सो ऑल्सो ये पूछता है कि आपको क्या लगता है कि बच्चे की बुद्धि आपके हिसाब से, आप बेस्ट जानते हैं आपके बच्चे को, इसके लिए सवाल आपको पूछा जाता है कि आपके हिसाब से आपके बच्चे की बौद्धिक क्षमता ओके है, कम है, बहुत कम है, और इसके पहले और इसके लिए कुछ और टेस्टिंग या आपको मदद की ज़रूरत है क्या.
In section 6, we want to know about academic functioning. We want to know if individuals have had trouble with reading, math, or writing, and if so, whether or not they're getting support in school.
सेक्शन 6 ये चेक करता है पढ़ाई के बारे में. तो बच्चा पढ़ सकता है क्या, लिख सकता है क्या, स्पेलिंग्स बराबर करता है कि नहीं, गणित कितना आता है, ये चेक किया जाता है सेक्शन 6 में. और अगर इसमें प्रॉब्लम्स है तो उसके लिए ऑलरेडी कुछ किया जा रहा है क्या, स्कूल में सपोर्ट दे रहे हैं क्या, शैडो टीचर है क्या, स्पेशल एजुकेशन सपोर्ट है क्या, अगर प्रॉब्लम्स है तो उसमें कुछ हेल्प की जा रही है क्या, ये भी देखा जाता है.
In section 7, what we want to know is, is there trouble with some of the higher order brain skills? So like executive planning, organizing, memory, visual spatial skills, like kind of being able to put together puzzles or find your way on a, using directions like on a map. And also too, if there's any trouble with disorientation.
So Section 7 में अलग अलग काम में बच्चे की क्षमता कितनी है ये चेक की जाती है. मतलब आपने अगर बोला है कि आज शाम को ये करना है, वो बच्चा याद रख के उसके जो स्टेप्स है वो करता है क्या, पजल सॉल्व कर सकता है क्या, ऐसे अलग अलग ये सब के लिए बुद्धि लगती है, पर वो बुद्धि का उपयोग कैसे कर रहे हैं वो अलग अलग टास्क चेक किए जाते हैं.
God bless you. Section 8, we want to know impact on self and family. So we want to know if there's any low self-esteem for the individual. And then also, too, very importantly, how are the siblings reacting to the child with tuberous sclerosis? And then how are the parents, how are the mother and father, how are you guys doing with the burden or the concerns that you've expressed about your child with tuberous sclerosis? Is it impacting your relationship?
सो सेक्शन 8 एक्चुअली ये देखते हैं कि ये जो बीमारी है बच्चे को, उसके वजह से आपके परिवार में कितनी तकलीफ हो रही है. बाकी के बच्चों को ऐसा लगता है क्या कि सब उसको ही देखते हैं, उसके साथ ही माँ बाप ज़्यादा टाइम बिताते हैं, तो मेरे साथ टाइम नहीं बिता रहे हैं. पेरेंट्स में, माँ बाप में, क्योंकि ये बड़ी बीमारी है, कई बार बीमारी बहुत ज़्यादा होती है, तो माँ बाप के रिलेशनशिप में इसके वजह से तनाव आ सकता है. तो वो प्रॉब्लम्स हो रहे हैं क्या, मतलब टीएस, एक बच्चे को टीएससी है पर उसका असर परिवार पे, उसके कुटुंब पे क्या हो रहा है, ये चेक किया जाता है.
In Section 9, we want you to sit back, reflect on everything that you've reported, and give us a score as to how impacted you feel by the things you've reported. So 0 is we have some concerns, but they're not impacting us at all. 10 is they're impacting us very heavily. We're reaching our end, and we really need help. And then 5 is kind of right in the middle.
सो सेक्शन 9 आपको एक ये टीएससी के साथ जो ज़िंदगी है, उस आपकी ज़िंदगी है, परिवार की ज़िंदगी, उसको मार्क्स देने को पूछती है. 0 मतलब टीएससी के वजह से हार्डली कुछ तकलीफ है, हार्डली कुछ चेंजेस आए आपके रोज़ की ज़िंदगी में, और 10 मतलब ज़्यादा मार्क्स मतलब बहुत बहुत परिणाम हुआ है आपके परिवार के रोज़ के जीने पे. ये एक बच्चे को टीएससी है उसके वजह से. तो ये आपको पूछता है कि आपके हिसाब से टीएससी का कितना इम्पैक्ट हुआ है, कितना असर हुआ है आपके पारिवारिक जीवन पे.
In Section 10, we ask you to think about and reflect on what are your goals for your child or your loved one. Sometimes when you go through questions like this and you say, Dr. Gibson, everything's a problem, and that can be pretty overwhelming. But what we want you to do is think about what are your top 3 that you'd like to work on.
So Section 10 ओपन सेक्शन है एक्चुअली. आपको पूछते हैं कि यस ये सब सेक्शन सॉल्व कर रहे हैं, तभी काफ़ी सेक्शन में कई बार आप टिक करेंगे कि हाँ इसमें भी प्रॉब्लम है, इसमें भी प्रॉब्लम है, इसमें भी प्रॉब्लम है. पर ये सेक्शन में आपको आपके मन में सबसे टॉप मोस्ट, सबसे ज़्यादा चिंता देने वाली कौन सी 3 चीज़ें हैं वो लिखने के लिए आपको प्रवृत्त करते हैं. एक्चुअली सोचने के लिए प्रवृत्त करते हैं कि यस ये 10 प्रॉब्लम्स हैं, पर ये 10 में से 3 ऐसे कौन से हैं जिससे बहुत ज़्यादा तकलीफ हो रही है, या जिसमें आपको सबसे ज़्यादा वो हल करने के लिए मदद चाहिए.
And then in Section 11, we ask, is there any other concern or question or thought that you want to express that we didn't talk about in those first 9 sections?
So Section 11 is कि कुछ हमने कवर नहीं किया है क्या, पर आपको उस बारे में चिंता है, तो वो व्यक्त करने के लिए इधर आपको एक चांस मिलता है.
And in Section 12, the person who's interviewing you gives you a score based on their observations of how impacted you may be as a family.
So Section 12 आपके लिए नहीं है, पर जो आपके साथ बैठ के जो साइकोलॉजिस्ट या डॉक्टर ये सॉल्व कर रहे हैं, उनका इम्प्रेशन क्या है, आपके साथ एक आधा पौना घंटा बिताते हैं, ये सब चीज़ों के बारे में बारीकाई में आपसे बात की गई है, तो उनके हिसाब से ये टीएस के वजह से आप पे एज अ फैमिली, एज अ परिवार कितना असर हुआ है, ये वो इंटरव्यूअर को मार्क्स देने हैं, स्कोर देना है.
So once we kind of get all their information, there's one way to look at it. There's lots of ways to look at it, but what we found out is that a lot of these symptoms happen in clusters. And so you may be dealing with one cluster at one time in life and another cluster at a different time in life. But here we have the behavioral dysregulation cluster. It's the first one.
सो ये इतने सवाल 4 पेजेस के सवाल का उत्तर लेके ये समझ में आता है कि वो अमुक पेशेंट को कौन से इसमें से कौन से सेट में व्हाट वुड बी द वर्ड फॉर मतलब जस्ट बौद्धिक विकास का प्रॉब्लम है या बर्ताव का बिहेवियर का प्रॉब्लम है या सामाजिक स्किल्स बिल्कुल नहीं है, तो कौन से इसमें तकलीफ है ये सॉर्ट आउट किया जाता है. ओके कौन से ग्रुप में क्या क्या ये ग्रुप में तकलीफ है. एंड पहला जो ग्रीन वाला ग्रुप है वो बर्ताव का है, बिहेवियर का है, मतलब बिहेवियर के प्रॉब्लम्स कितने हैं ये बच्चे को है कि नहीं है और कि है तो कितने हैं.
The next section or cluster is this hyperactive impulsive type subcluster, and these are individuals who are having more trouble with impulsivity or overactivity and restlessness.
नेक्स्ट क्लस्टर ये समझ में आता है कि वो बच्चे को हाइपर एक्टिविटी मतलब एकदम एक जगह पे नहीं बैठेंगे, कंटिन्यूस इधर उधर घूमते रहेंगे, ध्यान नहीं लगाएंगे, एकाग्रता नहीं है, मन में आया करेंगे बिना सोचे, ये प्रकार के तकलीफ का ग्रुप है क्या.
The third cluster is focused on mood. So this is individuals who may be shy, may be struggling with some depression, sleep difficulties, and memory difficulties.
तीसरा क्लस्टर इसमें से ग्रुप के प्रॉब्लम्स ये समझ में आता है कि मूड के प्रॉब्लम्स है क्या, वो बच्चे को लो लगता है क्या, डिप्रेस लगता है क्या, नींद नहीं आ रही है क्या, तो ये मूड के प्रॉब्लम्स है कि नहीं ये भी ग्रुप का समझ में आता है.
Okay. And then we have the neuropsychological cluster. These are individuals who maybe have trouble with executive functioning, like planning, dual tasking, like doing more than one thing at a time, and trouble with inattention or focus.
So तीसरा है न्यूरोसाइकोलॉजिकल. इसके लिए मुझे हिंदी में ट्रांसलेशन नहीं है, पर ये समझ में आता है इसमें से कि बच्चे को ठीक है बोलता है, कुछ एक काम दिया तो करेगा, पर साथ में 3 काम बोलेंगे कि पहले ये कर, फिर उसके बाद किचन में जा, ग्लास निकाल कबर्ड में से और पानी भर के मुझे लाके दे. 4 स्टेप का काम कर सकता है क्या. तो इसको हम ये ज़्यादा कॉम्प्लिकेटेड है, राइट. बच्चे को सब इंस्ट्रक्शन याद रखना है, किधर वो कैसे होगा और वो पूरा करना है. तो ऐसे थोड़े कॉम्प्लिकेटेड काम वो बच्चा कंप्लीट कर सकता है कि नहीं ये देखा जाता है.
The next cluster is the autism spectrum-like cluster, and these are individuals that might be dealing with self-injurious behavior, repetitive behaviors, or trouble with language, for example.
एंड सेकेंड लास्ट क्लस्टर है ऑटिज्म के लक्षण का, जिसमें बच्चे बहुत धमाल करते हैं, सोशल स्किल्स सामाजिक स्किल्स नहीं रहते हैं, बोले ना बोले, तो ये प्रकार के लक्षण है क्या. स्वयं मंगनता जिसको हिंदी में बोलते हैं ऑटिज्म को, उसके लक्षण है क्या वो देखा जाता है.
And then the last cluster here is the scholastic cluster, or trouble with academics in school.
एंड लास्ट ये समझ में आता है कि पढ़ाई में, जो हम एज इंडियंस को बहुत इंपॉर्टेंट चीज़ है, तो पढ़ाई में उम्र के हिसाब से मुश्किल है कि नहीं है, मुश्किल है तो कितनी है.
So I collected some questions. Shobha from the Tuberous Sclerosis Alliance of India reached out to families and collected some questions. And so I put them here in the presentation to address some of them. Okay, so this one, my son knows and understands everything but does not talk. If we make him repeat words, he forgets it soon. What can be done? Second question, my son is 4 years old. He gets agitated very often. He can't express himself.
Sorry.
No, that's okay. And then third question, my son's understanding is very poor, so he doesn't follow any instructions.
सो डॉक्टर तांजना ने एक्चुअली आपका आई थिंक पेरेंट्स का जो व्हाट्सएप ग्रुप है इस पे शोभा श्रीवास्तव जो एक वॉलंटियर है उन्होंने आपसे सवाल मांगे, एंड वो डॉक्टर तांजना ने मांगे थे एक्चुअली कि ये समझने के लिए कि आपके मन में सबसे ज़्यादा किस बात की चिंता है. तो जो क्वेश्चंस आए ये सब इंडिया के पेरेंट्स ने भेजे हुए सवाल हैं. तो वो डॉक्टर तांजना ने ग्रुप किए हैं अलग अलग सिम्टम्स के अंडर. तो पहला ग्रुप ये सवालों का है, इसमें है कि मेरे बच्चे को सब समझता है, पता चलता है सब, पर बात नहीं करता है. अगर मैं उससे शब्द बुलवाऊं तो बोलेगा, रिपीट करेगा, पर फिर जल्दी भूल जाता है. क्या कर सकते हैं. दूसरा सवाल यह है कि 4 साल का बच्चा है, बहुत बार बेचैन हो जाता है, एंड वो बेचैनी किस वजह से है वो बता नहीं सकता है. तीसरी चिंता ये है, मेरे बच्चे की समझ बहुत कम है, एंड उसके वजह से मैं उसको कुछ बोलूँ तो वो कर नहीं सकता है.
Okay. Last question for that slide.
एंड चौथा ये है कि मेरे बच्चे को सेंसरी इश्यूज है. आई थिंक सेंसरी काफ़ी लोग समझते हैं, आई डोंट थिंक उसके लिए ट्रांसलेशन है, बट वो बार बार उसके हाथ झाड़ेगा. उसको शांत करने के लिए किधर किधर प्रेशर लगेगा जिससे वो शांत होता है. तो काफ़ी सारे सेंसरी इश्यूज है, उसके लिए क्या किया जा सकता है.
And here's some additional questions. You could just read it.
और कुछ सवाल ये है. पहला सवाल ये है कि मेरा बच्चा बहुत स्टबन है, बहुत हट करता है, बहुत जिद करता है, एंड कुछ चीज़ें चाहिए ही, और अगर वो नहीं दी तो बहुत गुस्सा होता है, उसका बिहेवियर बहुत ही ख़राब हो जाता है. दूसरा सवाल ये है कि मेरे 4 साल का बच्चा उसके जिधर हाथ नहीं लगाना चाहिए, सेक्सुअली ऑर्गन्स को टच करते रहता है, पेशाब के जगह पे खुद को टच करते रहेगा. तीसरा सवाल ये है, मेरे बच्चे को कभी कभी कोई ना कोई उसके साथ चाहिए ही, अकेला नहीं रह सकता है, कोई उसके साथ होगा तो वो खुश रहेगा, एंड फिर वो खुद से भी खेलेगा. लास्ट सवाल ये है, मेरा बच्चा बहुत ही ज़्यादा हाइपर है, मतलब एक जगह पे नहीं बैठता है, एक जगह पे नहीं बैठेगा, एकाग्रता नहीं है, एंड मैं जो भी उसको इंस्ट्रक्शंस दूँ कि ये कर, वो कर नहीं सकता है.
Instead of TSC patient, normally जिसको ये behavioral करते ना.
That's right, yeah. So the question is, it's not necessary that these symptoms are seen only in patients with TSC. They're seen in kids otherwise as well.
Correct, absolutely. Okay, and here are some more questions that we received from the group.
और कुछ सवाल ये है कि मेरा बच्चा खुद को हर्ट करता है, काटेगा या नोचेगा खुद को, तो वो कैसे कंट्रोल करूँ. नेक्स्ट है कि मेरा बच्चा खुद को ही मारता है छाती पे दोनों हाथों से जब भी उसको कुछ चाहिए, एंड जब भी मारता है खुद को तभी पॉसिबली उसको दर्द होता है क्योंकि वो बहुत रोता है. तीसरा है कि मेरा बच्चा दूसरे लोगों को काटता है, दूसरे बच्चों को मारेगा, लात मारेगा, और बहुत ज़्यादा अग्रेसिव है, बहुत वायलेंट है. एंड लास्ट है, मेरा बच्चा गुस्सा होता है और फिर हम उसमें फिट्स देखते हैं. गुस्सा आता है और फिर फिट दिखाई देते हैं, फिट आती है, खींच आती है, दौरा आता है.
Okay. So I pointed out all of those questions, one, to acknowledge the questions that you guys have, but then also to try to bring it all together. When we approach these different questions, even though they may seem very different, there is a common theme. And so the first thing I'd like to talk about is some common misconceptions.
So ये सवाल बहुत लोगों के मन में कॉमन है, पर ये जब ये सवाल पूछे जाते हैं तो काफ़ी सारी गलत फहमियाँ हैं इनके बारे में. तो डॉक्टर तांजिला ये गलत फहमियों के बारे में डिस्कस करेंगे.
First misconception, sometimes when families come to me, they may have been dealing with behaviors on their own for a very long time. So let's take, for example, there was a person who said their child is very hyperactive. In my clinic, I've seen patients who come in and the parents will say, I've tried everything. I spank him and he still doesn't listen. I yell at him and he still doesn't listen. I take things away and he still doesn't listen. When children are not responding to whatever conventional discipline you might be accustomed to using, then sometimes that clues us in that there may be a disorder. Not that the parent did something very wrong or that the child is just, doing so poorly, but maybe there's something we're missing.
सो कई बार माँ बाप बोलते हैं कि ये ऐसा गलत बर्ताव करता है, तो हम उसको बच्चे को डिसिप्लिन करने की कोशिश करते हैं. मराठी में उसको शिस्त बोलते हैं. आई एम स्ट्रगलिंग फॉर हिंदी वर्ड. तो बच्चे ने गलत काम किया तो मैं उसको चिल्लाती हूँ, कुछ भी फ़ायदा नहीं है. बच्चे ने गलत काम किया तो 1-2 पढ़ते भी है, मारते हैं, फिर भी फ़ायदा नहीं होता है. तो ये मेरी गलती है क्या कि मतलब ये तरीके जो स्टैंडर्ड आपको और हम जब बच्चे थे तभी जो तरीके यूज़ किए गए हैं बराबर चीज़ें सिखाने के लिए, वो मेरे बच्चे पे बिल्कुल काम नहीं करते हैं. पर ऐसा जब भी हो रहा है तभी डॉक्टर तांजिला का कहना है कि आपको जस्ट एक स्टेप बैक लेनी और सोचना है कि ये क्यों आपके ट्रेडिशनल मेथड्स क्यों काम नहीं कर रहे हैं. कुछ तो डिस्कनेक्ट है, कुछ तो मिसिंग लिंक है जिसके वजह से आप बोलते हैं फिर भी बच्चा, और डिसिप्लिन भी करते हैं फिर भी बच्चा सुनता नहीं है या समझता नहीं है.
The next misconception is what I call can't versus won't. Sometimes you saw that there was one parent who said that their child was very stubborn. Stubborn meaning that he just won't do what I'm asking him to do. But sometimes when we look a little deeper, we find that it's not that the child is so stubborn. It's that they physically can't comply because of some other reason, something else that we need to address.
सो ये बड़ी गलतफहमी है जो आई थिंक हम लोग भी क्लिनिक में बहुत देखते हैं. पेरेंट्स आके बोलेंगे कि मैं कितना भी बोलूँ ये बच्चा करता ही नहीं है. वो डॉक्टर तांझाला बोल रही है कि एक सेकंड के लिए सोचना है कि उसका वो हट है कि वो करता नहीं है या वो कर ही नहीं सकता है. मतलब आपकी उसकी काबिलियत और आपकी अपेक्षा में इतना फ़र्क है क्या, ये सोचना है. आप अपेक्षा कर रहे हैं कि वो अमुक काम कर पाए पर उसकी काबिलियत ही नहीं है वो करने की, तो उससे अपेक्षा करना फूल है. बट माँ बाप कभी कभी देखने का नज़रिया ये रहता है कि बच्चा हट के वजह से करता नहीं है, लेज़ी है, नॉटी है, बहुत ज़िद्दी है, इसके लिए नहीं कर रहा है. तो ये हमेशा सोचना है कि वो कर सकता है कि नहीं.
Okay. The next misconception is about medications. I put risperidone here because it's a very, very commonly used antipsychotic medication, and I'm not just picking on that medication. My point is that oftentimes a medication, whichever one you choose, is not the total answer. Sometimes it can mask behaviors, it can make the children sleepier, but we haven't really figured out what's going on.
कई बार माँ बाप की अपेक्षा रहती है कि ये जो कठिन बर्ताव है उसके लिए जस्ट दवाई दी जाए. एंड इवन हमारे देश में भी रिस्पेरिडोन नाम की दवाई, सबसे सिस्डोन नाम की दवा काफ़ी कॉमनली यूज़ की जाती है. पर कई बार आप एकदम सॉर्ट ऑफ शॉर्टकट ढूंढ रहे हैं उनका बर्ताव कंट्रोल में लाने के लिए दवा के रूप में. वो करते वक्त एक तो दवा के साइड इफ़ेक्ट हो सकते हैं. रिस्पेरिडोन एंटीसाइकोटिक है तो बच्चा लूज हो जाता है, ढीला हो जाता है, डल हो जाता है. एंड एक्चुअल प्रॉब्लम किधर है वो मिस हो जाएगा क्योंकि आप वो बर्ताव जस्ट दवा से काबू में रखने की कोशिश कर रहे हैं.
Next misconception is wait and see. So sometimes families will come to me and say, well, we're not having any of those issues. I don't need this TAN checklist. We'll just wait and we'll see. The only problem with that wait and see approach is that sometimes, and again, not everyone will have behaviors associated with tuberous sclerosis. However, when behaviors do happen, there's typically a wait for an evaluation. There's a wait for therapy. There's a wait to get the school on board. And I think it's probably better to start early and make sure you're aware of your local resources before things become problematic.
सो कई पेशेंट्स फैमिलीज बोलते हैं कि हो जाएगा, बोलेगा अभी छोटा है इसके लिए ज़िद कर रहा है, वो ज़िद बंद हो जाएगी, देखेंगे और 6 महीने 1 साल वेट करते हैं, अभी तो कुछ बड़ा प्रॉब्लम है नहीं. पर ये वेट करने से शायद आप एक क्रूशियल अपॉर्चुनिटी, एक क्रूशियल ये खो दे रहे हैं. क्योंकि आप जितना जल्दी ये प्रोसेस चालू करते हैं कि कुछ प्रॉब्लम्स है कि नहीं ये देखने का, उतना जल्दी आप वो बच्चे को मदद करेंगे. रिमेंबर, सब चीज़ें फटाफट नहीं मिलती है. न्यूरोलॉजिस्ट मिलना, डेवलपमेंटल पीडियाट्रिशियन मिलना, फिर बराबर जगह पे थेरेपी मिलना, आप उधर जा पाना, ये सबको टाइम लगता है. पर आप पहले से ही बोलेंगे कि देखेंगे तो वो टाइम जस्ट ऐड होते रहता है और फाइनली बहुत लेट हो सकता है बच्चे को मदद मिलने तक.
Mild versus severe. I put mild in quotations because in tuberous sclerosis, it is true that there are some individuals who have more symptoms, more tumors, more seizures, more behaviors than others. However, to say that someone who has less symptoms is just mild and doesn't need a TAN evaluation is incorrect. Because oftentimes what we find, and I have the privilege of seeing some pretty high-functioning individuals with tuberous sclerosis, pharmacists, lawyers, nurses. However, when we do the TAN, we find out they may have been struggling with anxiety or trouble with language.
So कई बार फैमिली का ये कहना होता है कि इवन डॉक्टर्स का, टू बी ऑनेस्ट, कि थोड़े ही प्रॉब्लम्स है तो ये टैंड हमेशा चेक नहीं करना है. पर डॉक्टर तांझला के क्लिनिक में ऐसे भी टीएस के पेशेंट्स आते हैं जो ऑलरेडी बड़े हैं, खुद डॉक्टर है, खुद लॉयर है, चार्टर्ड अकाउंटेंट है, एंड उनके साथ भी वो जब भी तो ऐसा ऊपर देखने में उनको कुछ प्रॉब्लम नहीं है और उनको भी खुद को भी भी लगता है कि अरे मुझे टीएस से बड़ा प्रॉब्लम नहीं है बिहेवियर में, बुद्धि में वगैरह, पर जब भी उनके साथ टैन चेकलिस्ट करते हैं तो उनको भी ध्यान में नहीं आया है कि उनको कई बार बहुत टेंशन रहता है, एंग्जाइटी रहती है, और ये सब चीज़ों से ऑब्वियसली उनकी ज़िंदगी और काम अफेक्ट होता है। तो ये टैन चेकलिस्ट सिर्फ वो पेशेंट्स में जो किसी को भी पता चले कि इनमें प्रॉब्लम है, सिर्फ उनके लिए नहीं है, ये सब टीएस के पेशेंट्स को रेगुलरली करते रहना है ताकि प्रॉब्लम छोटा भी क्यों ना हो वो सामने आए और उसकी मदद कर पाए।
One size fits all. I love social media, and I think it's important for families to share. But sometimes when we look at websites and Facebook and Instagram and WhatsApp, these different portals, somebody might say, "Well, you know, I'm using CBD, or I'm using THC, or I'm using a different medication," and then other families may assume, "Wow, I must need that one too." And what we need to do is be thoughtful about that and recognize that each person is unique, and not just start doing some treatment or therapy only because someone else is doing it.
सोशल मीडिया मतलब व्हाट्सएप ग्रुप, फेसबुक, ये सब पे भी जो इन्फॉर्मेशन मिलती है वो ज़रूरी रहती है, पर ये ज़रूरी नहीं है कि एक टीएस के पेशेंट को एक दवाई से या एक विशिष्ट थेरेपी से फ़ायदा हुआ तो आपके बच्चे को भी उसी चीज़ से फ़ायदा होगा या वो दवाई देना बराबर है। ये जो ट्रीटमेंट्स है ये बहुत हाई लेवल की है। हर एक पेशेंट को जैसे शर्ट सिलाते हैं तो वो टेलर आपका नाप लेके टेलर बनाएगा, वैसे हर एक बच्चे के लिए, बड़े के लिए क्या ज़रूरी है उस हिसाब से कौन सी ट्रीटमेंट, कौन सी थेरेपी ये तय करना है। ज़रूरी नहीं है कि वो आप ग्रुप पे कोई पेरेंट बोलता है मेरे बच्चे को इसका फ़ायदा हुआ तो आपके बच्चे को भी वो सही है। तो ये आपके डॉक्टर के साथ जाके बात करनी है कि मेरे बच्चे के लिए क्या सही है क्या नहीं है।
And then another one, more is better. So there are some individuals who aren't getting any of the therapies that their child or loved one might need. But then there are other people who may be spending all their time on appointments and therapies, and there needs to be a balance. You can't spend all of your time just doing therapies.
कई बार क्या हो जाता है, आपने देखे हैं कितने सारे टेस्ट करने हैं, कितने सारे डॉक्टरों को मिलना है, थेरेपिस्ट को मिलना है, स्कूल है, बाकी की भी ज़िंदगी है, तो कई बार ये सब चीज़ें बहुत ज़्यादा हो जाती है। तो उनमें भी किधर तो एक रैशनल लेवल लाना है कि जो ज़रूरी चीज़ें हैं वही करनी है। जस्ट बिकॉज लिखा है कि ये सब करते ही रहना है, ज़रूरी नहीं कि हर एक पेशेंट में करे, तो वो भी फैमिली को हेल्प एडजस्ट करने में हेल्प करना है कि वो जितना कर पाते हैं उतने लेवल तक वो ये सब टेस्टिंग और वो सब लेके आए।
Outings and travel. Oftentimes when individuals have children who are struggling with behaviors, they feel as though they can't go anywhere. They feel as though they can't take trips. And I think that's a misconception. Yes, maybe there maybe needed to be more support, but you still should be able to go places, even within this room. I don't mind if someone cries. I don't mind if someone has a little tantrum. That's why we're here. So it's very important not to close yourselves off from everyone else just because your child may be having some behavioral difficulties.
सो ये बहुत लोगों ने एक्सपीरियंस किया होगा कि आप बाहर नहीं लेके जा सकते आपके बच्चे को, जस्ट होटल में एक दिन रात को खाना खाने के लिए जाना मुश्किल हो जाता है, शादी में लेके जाना मुश्किल हो जाता है बच्चे के साथ, पर ऐसा खुद को बंद कर देना, बांधना भी अच्छी बात नहीं है। जैसे इधर देख रहे हैं, वो बोल रहे हैं कि इधर देख रहे हैं बच्चा कोई रो रहा है, तो क्या फ़र्क पड़ता है उसका, मतलब उसके बिहेवियर के वजह से आपका जो सोशल लाइफ है एज अ परिवार वो जो अफेक्ट कर देते हैं वो करना भी सही नहीं है। एंड इट्स ओके टू बच्चे को बिहेवियर है वो सॉर्ट आउट करके जितना हो सकता है, पर जो लाइफ के स्टैंडर्ड एक्सपीरियंसेस हैं वो करते रहना एज अ फैमिली बहुत ज़रूरी है।
And many times individuals who when their children are struggling with behaviors associated with tuberous sclerosis, they're told that there's nothing that can be done, that they're untreatable. And that's just not true. It's not easy. It's very hard work, but these conditions are very treatable.
सो कई लोगों को ये बताया जाता है कि अरे ये तो टीएस है, जेनेटिक है, कुछ कर नहीं सकते। ये सच नहीं है। इसमें से बहुत सारे जो सिम्टम्स हैं उनका इलाज है, वो हल किए जा सकते हैं। तो ये मान के स्थित नहीं होता है कि ये अनट्रीटेबल, कुछ भी मदद नहीं है, कुछ भी नहीं कर सकते हैं। ट्रीटमेंट्स है, सही डॉक्टरों के पास पहुंच के वो एक्सेस करनी है।
So now let's talk about our diagnostic approach. Very first thing, very important, is we want to make sure that all of the routine medical issues are addressed. One of the parents in, I think we were in Delhi, pointed out that sometimes children are prescribed anti-seizure medicines, but we forget to tell you to take vitamin D supplementation because some of these medicines can lower vitamin D levels. We want to make sure that that's addressed, that children are getting good sleep, that they're eating well, that the routine immunizations are complete.
क्या क्या करना है? पहला है मेडिकल, जैसे समरी कर रहे हैं. मेडिकल जो भी चीज़ है, सिंपल ऑफ कोर्स फिट या और कुछ प्रॉब्लम है तो वो दवा लेनी ही है, पर जो विटामिन की ज़रूरत है, वैक्सीन्स, जो सब टीके लगवाने हैं, वो सब भी होते रहना ज़रूरी है, जैसे दूसरे बच्चों का भी होगा.
Okay. The second level of diagnostic approach is getting a neurodevelopmental examination. So in our clinic, that's a thorough neurologic examination, and then also specific developmental screening. So if you come in and you say, my child has, features of autism, we want to actually do some observations to see what their behavior is like, what their language is like in the examination room.
So मेडिकल हुआ तो उसके बाद डेवलपमेंट, विकास कितना हुआ है, ये चेक करते रहना है. ऑटिज्म के लक्षण है क्या, ADHD के लक्षण है क्या, ये चेक करते रहना है.
We want to make sure all indicated TSC medical evaluations, like Dr. Kruger pointed out in his talk, are complete, especially at MRI.
सब जो टेस्ट बोले डॉक्टर क्रूगर ने, हर साल में MRI करना है, 5-5 साल में ECG करना है, ये टेस्ट बराबर से हो रहे हैं कि नहीं, इस पे ध्यान रखना है.
The neuropsychological or psychological evaluation is very important. Again, we want to know what functional age is your child or young adult.
फिर IQ, सबको पता है, बौद्धिक क्षमता क्या है, ये चेक करना है.
A thorough speech and language evaluation. We want to know exactly how your loved one communicates and how they understand language.
So बच्चा बोल सकता है कि नहीं, और बोलता नहीं है तो व्यक्त कैसे करता है. बोलना एक ही तरीका नहीं है खुद को व्यक्त करने का. तो बच्चा कम्युनिकेट, मतलब खुद को व्यक्त कर सकता है कि नहीं और कैसे करता है, ये भी बहुत डिटेल में टेस्टिंग करना है.
So let's consider these two questions again. In both of these scenarios, the child is having trouble with communication. So one thing we might consider, in addition to the standard, is an assistive technology evaluation. This is an evaluation in which a speech and language pathologist who's specially trained will work with you and your child to figure out what sorts of methods are going to be useful for them to express themselves. It can be high tech, but it can be something as low tech as a yes and no picture.
सो जो दो सवाल थे पहले कि बच्चे को समझता है सब पर बोल ही नहीं सकता है तो व्यक्त नहीं कर सकता है, तो बोलने के बिना और व्यक्त करने के क्या तरीके वो बच्चे को हम लोग और फैमिली को सिखा सकते हैं. इसके स्पेशल स्पीच थेरेपिस्ट होते हैं जो ट्रेंड होते हैं असिस्टिव कम्युनिकेशन टेक्नोलॉजी में, एंड अलग अलग है. सिंपल चीज़ है कि कार्ड्स है, बटन है हाँ या ना बोलने का, या आईपैड यूज़ करके टाइप करके या चित्र दिखा के बच्चा खुद को व्यक्त कर सकता है कि उसे क्या चाहिए क्या नहीं चाहिए, गुस्सा है खुशी है क्या है.
Another consideration. So in these questions, we're looking at aggression and self-injury. When children are exhibiting those signs, it's very important to look for signs of what we call occult or very subtle pain.
सो जो बच्चों में ये सवाल है जिनमें बच्चे खुद को मार रहे हैं या दूसरे को मार रहे हैं टिपिकली बिना वजह, तो इनमें एक बहुत ज़रूरी चीज़ है कि बच्चे को खुद को किधर दर्द हो रहा है क्या, ये देखना चेक करना, क्योंकि रिमेंबर कई बार ये बच्चे दूसरे तरीके से खुद को व्यक्त नहीं कर सकते हैं, तो ये उनका मारना पीटना दर्द का लक्षण है क्या.
And this is typically our approach to looking for pain. We want to get an abdominal x-ray, a good dental exam, check the skin all over for any signs of pain, check the scalp, nails, and then even check a urine to make sure they don't have a urinary tract infection that can be causing back pain.
सो डायरेक्टली बच्चे को शांत करने के लिए दवा देने के बजाय देखना है कि दर्द है क्या, एंड कैसे देखेंगे किधर दर्द है कि नहीं. कॉमन प्रॉब्लम्स ये बच्चों में ये होता है कि कॉन्स्टिपेशन मतलब संडास में बहुत तकलीफ होती है और उससे बहुत दर्द होता है, तो वो एक्सरे करते हैं देखने के लिए कि कॉन्स्टिपेशन है क्या. दांत चेक करने हैं, दांत में खराबी होना बहुत कॉमन है एनीवे सब बच्चों में, वो खराबी है क्या. किधर भी त्वचा पे नाखून में जो ट्यूमर्स होते हैं उसके वजह से दर्द हो रहा है क्या. यूरिन चेक करना है, तो ये आपके डॉक्टर का काम है, आपको नहीं करना है, पर एक पहली चीज़ करनी है कि बहुत बच्चा मार पीट रहा है खुद को या दूसरों को, तो किधर दर्द है क्या, एंड ये सब चीज़ें चेक करनी होती है डॉक्टर को, वो दर्द है कि नहीं देखने के लिए.
So possible diagnoses. So after we've kind of thought about the TAN checklist, after we've thought about diagnostic procedures, we want to consider possible diagnoses. So here are another 4 questions, and kind of the theme that might link all these questions together are a few diagnoses.
सो ये जो नेक्स्ट 4 सवाल थे जो माँ बाप ने पूछे थे, तो ये सॉर्ट ऑफ खुद में खोए हुए बच्चों के लक्षण हैं। तो ये लक्षण से बाकी आपसे सब चेक किया है, मेडिकल किया है, पेन है कि नहीं देखा है, तो और कुछ डायग्नोसिस निकल रहा है क्या? ये टैन चेकलिस्ट अपने हमें मदद करती है वो डायग्नोसिस तक पहुँचने के।
Okay. And here are some that we can consider. So one could be intellectual disability with limited generalization. So that's, again, a child or young adult who is one age physically, maybe 16, but mentally, functionally is a lot younger, maybe 8 years old. So they may learn something in one setting, but then when you ask them in another setting, they seem to have forgotten. But it's not that they've forgotten, it's just that they haven't reached the developmental level to be able to apply that skill in a different setting.
सो क्या क्या डिफरेंट अलग अलग डायग्नोसिस निकलेंगे, उसमें से पहला ये है, इसका मतलब है मंदबुद्धि, बुद्धि कम है, तो सीखते हैं पर आपने कलर सिखाए हैं और फिर डॉक्टर के सामने जाके वही कलर पूछेंगे तो वो उनको आते नहीं हैं, तो लगता है कि अरे ये भूल गए क्या या सीखे ही नहीं बराबर से, तो वो नहीं है। पर वही क्योंकि बौद्धिक क्षमता कम है, ऐसे लगता है कि ये सीख ही नहीं रहे या भूल गए हैं।
Or an actual disorder.
ये सिर्फ भाषा का प्रॉब्लम हो सकता है, मतलब ऑटिज्म नहीं है पर बोलना और समझना भाषा के रूप में वो बच्चों को पॉसिबल नहीं है, इसे हम लैंग्वेज डिले या डिसऑर्डर बोलते हैं।
Similarly, there can be a speech and language regression related to epilepsy. So this is an individual who was speaking just fine, had a really large seizure, or had persistent seizures and then lost their language.
और एक है कि सीखते हैं, बोलना सीखे हैं, पर बड़ा फिट आता है, एडमिट होता है, और जब भी डिस्चार्ज होता है तभी जो सीखे थे बोलना व्यक्त करना वो पीछे चले जाते हैं।
There can be anxiety with pragmatic language impairment. And what I mean by pragmatic language impairment is not that the individual doesn't speak and understand, is that they have some trouble with social cues, body, personal space, jokes, or sarcasm.
सो एंग्जाइटी मतलब चिंतित, हमेशा टेंशन में रहने वाला, ये एक डायग्नोसिस आ सकता है। और उसमें प्रैग्मेटिक लैंग्वेज इम्पेयरमेंट मतलब बोलना समझना सब ठीक है पर किसी ने कुछ जोक मारा कि अरे क्या मैं इतना हंसा कि आई लाफ टिल आई डाइड, तो उनको ये नहीं समझता है कि वो जोक बोल रहे हैं, उनको लगता है अरे आप क्या हुआ, मर गए, ऐसे कैसे हुआ। तो वो लैंग्वेज के जो अलग अलग पहलू है जो हम फिगर्स ऑफ स्पीच करके सीखे हैं स्कूल में, वो लैंग्वेज के बोली भाषा तो समझ में आती है पर उसके जो अलग पहलू है वो समझ में नहीं आना, is called pragmatic language impairment.
Another possible diagnosis is selective mutism, and this is a case when a child or young adult, typically a younger child who, when in a setting with folks who are unfamiliar with them, may not be able to answer questions or do tasks, but when they're comfortable, at that point they're able to do everything just fine and they don't really have autism or intellectual disability.
ये सिलेक्टिव म्यूटिज्म एंड हम लोग बाकी के बच्चों में भी देखते हैं, मतलब आपके सामने फैमिलियर जो कंफर्टेबल एनवायरनमेंट है उधर सब सवाल बराबर से आंसर करेंगे, डॉक्टर के केबिन में गए, स्कूल में इंटरव्यू के लिए गए तो वही सवालों का जवाब उनको पॉसिबल नहीं होता है, इसे बोलते हैं सिलेक्टिव म्यूटिज्म। तो ये सब प्रॉब्लम्स टीएससी के बच्चों में हो सकते हैं और ये टैन चेकलिस्ट पर हर एक प्रॉब्लम का हल अलग है, ट्रीटमेंट अलग है। तो टीएससी है एंड पर फंक्शनिंग बराबर नहीं है, तो इसमें से कौन सा कारण के वजह से प्रॉब्लम हो रहा है, ये हमें टैन चेकलिस्ट मदद करता है वो कारण तक पहुंचने के लिए, ताकि उस हिसाब से आप ट्रीटमेंट कर पाए।
Okay, so when you have all these concerns, you have these possible diagnoses, who do you need on your team? So there's a lot of different professionals who can be helpful. And so I want to just kind of give you the set of like non-physician professionals that can be helpful. There are psychologists, behavioral specialists, psychiatric mental health nurses, social workers, speech language therapists, physical therapists, and educators.
सो कौन कौन मदद करेगा आपको ये सब समझने में, सुलझाने में एंड ट्रीट भी करने में? तो साइकोलॉजिस्ट के अलग अलग प्रकार होते हैं, न्यूरो साइकोलॉजिस्ट, बिहेवियर साइकोलॉजिस्ट, बिहेवियर थेरेपिस्ट रहते हैं जिनको बिहेवियर स्पेशलिस्ट बोलते हैं, मेंटल हेल्थ नर्स रहते हैं, सोशल वर्कर, स्पीच एंड लैंग्वेज थेरेपी, फिजियोथेरेपी, ऑक्यूपेशनल थेरेपी, स्पेशल एजुकेटर्स, ये काफ़ी इसमें से नाम आपने सुने होंगे। पर सिर्फ डॉक्टर का ये काम नहीं है, ना ही सिर्फ माँ बाप का काम है, ये इतनी सारी टीम चाहिए ये सब प्रॉब्लम्स को समझने में और ट्रीट करने में।
And then there are your physician professionals. So your primary care physician is very important, but then there are developmental specialists and other specialists like genetics, psychiatrists. And then my specialty is here at the bottom, the pediatric neurologist and neurodevelopmental disability specialist.
So ना ही इतने सारे बाकी के प्रोफेशनल्स, पर डॉक्टरों में भी, और वो डॉक्टर आरसी ने भी दिखाया आपको कि अलग अलग प्रकार के डॉक्टर चाहिए। पीडियाट्रिशियन चाहिए क्योंकि टीके लगाने हैं, सर्दी खांसी, वो सब नॉर्मल चीज़ें तो होने ही वाली है लाइफ में, उनमें आपको हेल्प करने के लिए। डेवलपमेंटल पीडियाट्रिशियन जो समझते हैं कि डेवलपमेंट में प्रॉब्लम्स को कैसे हल करना है। जेनेटिसिस्ट चाहिए, बड़े होके साइकियाट्रिस्ट चाहिए, कभी कभी न्यूरोसर्जन की ज़रूरत पड़ती है वो ट्यूमर के लिए। ऑफ कोर्स न्यूरोलॉजिस्ट चाहिए, मोस्ट ऑफ अस हियर आर एक्चुअली न्यूरोलॉजिस्ट, एंड डॉक्टर तांजला इज ऑल ऑफ दिस। शी इज़ अ पीडियाट्रिक न्यूरोलॉजिस्ट है, डेवलपमेंटल, पर उन्होंने उसमें डेवलपमेंटल डिसेबिलिटीज़ में वो स्पेशलिस्ट है, उनका रिसर्च उसमें है।
And none of this would be possible without a team. And so I just flashed this slide just to show you our interdisciplinary team of nurses, specialists who work together with me in the TAN clinic.
So again, ये अकेले करने वाली बात नहीं है। The seniors would agree, इंडिया में ट्रेडिशनली मेडिसिन ऐसे प्रैक्टिस किया जाता है कि एक डॉक्टर और वो डॉक्टर के बल पे सब होता है। तो ये ना ही आज का ज़माना ऐसा है, ना ही ये बीमारी ऐसी है कि एक आदमी की मदद से आप सब प्रॉब्लम सॉल्व करें। तो ये डॉक्टर तांजला की टीम है जिनके साथ ये काम करते हैं और ये सब रिसर्च करते हैं।
Okay. And so I'm going to kind of take you through our treatment approach, but for the sake of time, I'm going to summarize a bit. So there's functional, symptomatic, and organic. 3 different ways to look at behaviors. Functional is kind of all of the non-medication stuff. Symptomatic is what we do medication-wise, and organic is what we can do tuberous sclerosis specific.
तो ये ट्रीट कैसे करेंगे, ये मेन सवाल आपके मन में है। तो इसके 3 हेडिंग्स है, ट्रीट कैसे करेंगे। फंक्शनल मतलब, कैन यू एक्सप्लेन फंक्शनल अगेन?
Functional is anything that in the environment might be maintaining the behaviors, and if we're targeting with treatments, it's everything that's non-medication related, so the therapies and all the non-medication.
So functional मतलब दवा छोड़ के बाकी क्या कर सकते हैं, अलग प्रकार की थेरेपी, कौन सा स्कूल वो बच्चे के लिए सही है, किसके साथ बच्चे को काम करना है, ये सब एक पहलू है ये बच्चों को हेल्प करने के ट्रीटमेंट का।
And so these are some functions of aggression and self-injury, just as an example, but I want to skip to a summary slide. Okay. And again, this is an example of functional treatment type. So again, all of the non-medication things.
So ये उदाहरण है दवा छोड़ के जो ट्रीटमेंट है बच्चों को, ये उनके I'll just quickly go through them. So एक is behavior therapy, मतलब बिहेवियर कैसे चेंज करना है, बर्ताव कैसे मॉडिफाई करना है वो बच्चे का। लैंग्वेज रिच एनवायरनमेंट, बच्चों के आजू बाजू में सब लोगों ने बहुत सारे बातें करती रहनी है, गैजेट नहीं दिखाने हैं, एक्चुअल ह्यूमन कॉन्टैक्ट चाहिए ताकि कंटिन्यूसली उनके ब्रेन को वो स्टिमुलेशन, चालना मिलती रहती है भाषा की। लेबल करना है सब, उनका टूथब्रश लेबल करना है, स्कूल का यूनिफॉर्म लेबल करना है, दूध का ग्लास लेबल करना है, ताकि अगर वो समझते नहीं है तो शायद वो लेबल्स पढ़ के, लेबल पहचान के, नॉट नेसेसरी पढ़ के उनको हेल्प हो जाए। विजुअल पिक्चर शेड्यूल उन्होंने उदाहरण दिखाया है, मतलब सुबह उठना है, दांत ब्रश करने हैं, नहाना है, कपड़े पहनने हैं, ब्रेकफास्ट करना है और निकलना है स्कूल के लिए। ये ऐसे सीक्वेंशली याद रहने के लिए उनके बाथरूम में या उनके बेड के बाजू में ये चित्र लगाना है कि पहले ये करना है, फिर ये करना है, फिर ये करना है, फिर ये करना है। तो वो उनको ऑर्गेनाइज करने में फ़ायदा होता है, वो जस्ट चित्र देख के आपको बताते नहीं रहना पड़ता है। कम्युनिकेशन डिवाइस, अलग अलग तरीके से बच्चों को बोल नहीं सकते तो दूसरे तरीके देने हैं उनको खुद को व्यक्त करने के लिए। कार्ड्स है, स्माइलीज है, वो जो आईपैड आईपैड या फ़ोन पे ऐप है जो बच्चे यूज़ कर सकते हैं। और पॉजिटिव रीइंफोर्समेंट, हमेशा बच्चा कुछ करता है तो उसको अप्रिशिएट करना। मतलब शायद आपने अपेक्षा की थी कि पहले ही महीने में बच्चा उठ के ब्रश करे, नहाए धोए, खाना खा के तैयार हो जाए। ये सब नहीं होता है, पर एटलीस्ट वो बच्चा महीने एट द एंड ऑफ अ मंथ रेगुलरली खुद ब्रश करने लगता है सुबह। तो वो रिकॉग्नाइज करना है, उसको प्रोत्साहन देना है बच्चे को कि 5 काम थे उसमें से एक तो किया, पर किया तो सही। एंड दूसरा इज़ पेशेंस। आपको बहुत पेशेंस इज़ बहुत हाँ सहन शक्ति, मतलब बहुत टाइम देना है। हम लोग ना वो इंस्टेंट के ज़माने में जी रहे हैं, पर ब्रेन के मामले में या जनरली हेल्थ के मामले में कुछ भी इंस्टेंट नहीं होता है। सो इसे टाइम देना है, आपको पेशेंस रखना है, धीरज रखना है कि ये होते रहेगा। एंड रीअसेसमेंट, एक ही थेरेपी चालू की है, एक ही कुछ बोला है तो वही करते नहीं रहना है। हर 3 महीने में, 6 महीने में जो आप जैसे आपके लोकल टीम के साथ चेक करना है कि ठीक है हम 3 महीने पहले इधर थे, ये किया तो अभी कितना सुधार हुआ है, फिर आगे के गोल सेट करने हैं। तो ये कंटिन्यूअस प्रोसेस करते रहना है रीअसेसमेंट का, ताकि समझ में आए कि सुधार हो रहा है कि नहीं हो रहा है। नहीं हो रहा है तो उसके लिए क्या करना है, हो रहा है तो आगे के स्टेप पे चले जाना है।
Okay, and then I'm going to skip ahead to this summary slide. So how do we put it all together? Since I've been here, I am in love with this masala tea, but I recognize that it takes a lot of work to make it, a lot of ingredients, and that's kind of how we need to approach TAN. So in the case of a child with self-injury, so first we have the TAN checklist. We figure out the cluster. We figure out what specialists are needed, non-physician and physician. What's functional, what's symptomatic, what's organic. And then we come up with a treatment plan that at some point we will reassess.
सो फाइनली ये सब कैसे करना है, सब शुरुआत होती है टैन चेकलिस्ट से। वो टैन चेकलिस्ट के 4 पन्नों के क्वेश्चंस आपका आप सवाल देते हैं, सवाल जवाब करते हैं, तो उससे समझ में आता है कि कौन से हेडिंग के अंडर बच्चे को तकलीफ है। रिमेंबर, ज़रूरी नहीं है कि सिर्फ स्वयं मंगनता के प्रॉब्लम्स है या सिर्फ पढ़ाई के प्रॉब्लम्स है। कोई बच्चे को एक से ज़्यादा प्रॉब्लम्स होंगे, तो कौन से वर्टिकल के अंडर, हेडिंग के अंदर प्रॉब्लम्स है पेशेंट को, ये समझ में आता है टैन चेकलिस्ट से। फिर प्रॉब्लम समझता है तो समझता है कि उसका हल करने के लिए आपको किस किस की ज़रूरत है। कोई पेशेंट अगर बराबर बात कर रहा है, व्यक्त करने की कुछ भी नहीं है, तो शायद स्पीच एंड लैंग्वेज थेरेपिस्ट की ज़रूरत ना पड़े, या किसी को सब प्रोफेशनल्स की ज़रूरत पड़े। सो किधर प्रॉब्लम है उस हिसाब से समझ में आता है कि आपको किसकी मदद लेनी है ये चीज़ हल करने के लिए। और फिर वो हर एक प्रोफेशनल आपको फंक्शनल, सिम्टोमेटिक और ऑर्गेनिक, मतलब स्पेशल एजुकेटर आपको बताएंगे कि बच्चे को कैसे सिखाना है, बिहेवियर थेरेपिस्ट बताएंगे कि उसका बर्ताव कैसे चेंज करना है, डॉक्टर्स देखेंगे कि कुछ दवा की ज़रूरत है क्या, किधर पेन हो रहा है क्या, रेगुलर टेस्टिंग हो रहा है कि नहीं। और फिर ये सब साथ में आके हर एक बच्चे का एक ट्रीटमेंट प्लान बनता है जिसमें उसकी क्षमता क्या है, उसको आप और अधिक हेल्प किस तरीके से कर रहे हो। शैडो टीचर दे रहे हैं, असिस्टिव टेक्नोलॉजी दे रहे हैं, स्पेशल एजुकेटर दे रहे हैं, बाकी की जो तबीयत है, कॉन्स्टिपेशन सॉर्टेड है ना, विटामिन टॉनिक ले रहे हैं ना, टीके लगवा रहे हैं ना, और टीएससी के लिए स्पेसिफिक दवाइयाँ क्या है। तो ये जो लास्ट ये है, ये हर एक बच्चे का ऐसा एक प्लान बनना चाहिए एट द एंड ऑफ ऑल दिस इवैल्यूएशन, और ये प्लान बार बार रीचेक करते रहना है कि इसमें और कुछ ऐड करना है, इसमें से किसी चीज़ की ज़रूरत निकल गई है, ये कंटिन्यूस देखरेख के अंडर रहना है।
And this is just an example of TAN over time. And again, we can have these slides available, but it's very important at all times to support the family and to do the annual TAN checklist. This video I can come back to maybe if we have time in the question answer section. But I do want to tell you that as a global team, we're working on this tandem project. And what we aim to do is make this TAN information accessible no matter where you live. And you have a representative Shoba on this project.
So ये TAN का जो प्रोजेक्ट है, एक वीडियो है फेसबुक का जो डॉक्टर तांजिला बाद में दिखाएंगे आपको, पर ये TAN का प्रोजेक्ट पूरी दुनिया में कर रहे हैं। सो जिधर भी TSC के पेशेंट हैं उनको ये TAN प्लान्ड चेकलिस्ट मिलती है क्लिनिक में, वो सॉल्व करते हैं और उसके हिसाब से उनके प्रॉब्लम समझ के ट्रीटमेंट चालू किया जाता है। इसके प्रोजेक्ट को टैंडम प्रोजेक्ट ऐसा नाम है। इंडिया से शोभा श्रीवास्तव जो आपके व्हाट्सएप ग्रुप पे पेरेंट है, वो हमारी रिप्रेजेंटेटिव है अपने देश की, जो ये टैंडम प्रोजेक्ट पे काम कर रहे हैं।
And last but not least, but again, I want Dr. Gatgill to be able to catch her flight, is this is an acronym. And there's a lot of different reasons here, but the main takeaway is no matter how bad it is, no matter what the TAN score is, no matter what you've been told, there is always room for hope. And these are some reasons why we can share this with you afterwards.
सो डॉक्टर तांजला, हम सबको बहुत हौसला देने की उद्देश्य से, होप मतलब हौसला इन इंग्लिश, तो होप का एच इज़ की मदद लेना। सो मदद सबसे लेनी है, ओके? डॉक्टर्स है, बाकी के प्रोफेशनल्स है, थेरेपिस्ट है, आप दूसरों को मदद कर सकते हैं एट अ पर्सनल लेवल। टीएस अलायंस है जो इंडिया का है, जागतिक है, तो ये सबसे मदद लेनी है। इसमें जो स्टिग्मा लास्ट लिखा है कि शर्म की कुछ भी बात नहीं है, ये कुछ शर्म की बात नहीं है, जेनेटिक बीमारी है, पल्ले पड़ी है, इसके साथ शर्म से नहीं जीना है, ओके? दूसरा है ओ मतलब अपॉर्चुनिटीज़। अगर कोई रिसर्च प्रोजेक्ट का कल व्हाट्सएप ग्रुप के आपके आएगा कि हम लोग इंडिया में रिसर्च चालू कर रहे हैं, तो वो अपॉर्चुनिटी है, उसका फ़ायदा उठाना है, एक दूसरे को मदद करनी है। किसी मम्मी को कुछ सिंपल डाउट रहेगा कि अरे मैं दवाई भूल गई, मैं डॉक्टर का फ़ोन नहीं लग रहा है, मैं क्या करूँ? सो यू could help each other in that. Pace. ये 100 मीटर की शरीयत नहीं है कि 10, 15, 20 सेकंड में कंप्लीट करें, ये मैराथन है। जैसे सर ने पूछा कि दवा लंबी चलती है, यस, क्योंकि लाइफ लॉन्ग बीमारी है। तो मेक श्योर आप इसमें बौद्धिक दृष्टिकोण से, मानसिक दृष्टिकोण से, लाइक आपके नॉट बुद्धिक, सॉरी, आपके मानसिक दृष्टिकोण से उसके लिए बजटिंग करना है, पर लॉन्ग टर्म कुछ सालों का सोचना है। अगले 3-6 महीने में हल होने वाला ये प्रॉब्लम नहीं है। एंड एक्सपेक्टेशन, एकदम क्लियरली सोचना है कि इसमें से क्या अपेक्षा करनी है। सब लोग सोचेंगे कि सबको हमें चांद पे जाना है, तो वो तो होने वाला नहीं है, तो रीजनेबल एक्सपेक्टेशन रखने हैं। बट जो पॉजिटिव्स है उस पर ध्यान देते रहेंगे तो आप सबका हौसला बना रहेगा और आप ये बीमारी के साथ अच्छी तरीके से जी पाएंगे।
Thank you.
And that's धन्यवाद। ओ एंड दैट्स तांजला मुंबई में एलिफेंटा केव्स में और द ताजमहल। नाइस, थैंक यू, थैंक यू। आई एम गोइंग टू क्विकली से थैंक यू हियर। मैं डॉक्टर प्रणति की फ्रेंड हूँ, मैं डॉक्टर प्रज्ञा हूँ, पर मुझे मेरा फ्लाइट कैच करना है। बिग थैंक यू। प्लीज़ ये टीएस अलायंस इंडिया के मेंबर्स बनिए, ताकि आपके हौसले के वजह से, रिमेंबर ये जो सब रिसर्च हुआ है परदेश में, ये जो टीएस अलायंस इंटरनेशनल है जिनकी केटी स्मिथ इधर आई है, ये रिसर्च हुआ है क्योंकि परदेश के पेरेंट्स साथ में आए हैं, पैसा खड़ा किया है, डॉक्टरों के पीछे पड़े हैं कि करो 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 करके सेंटर्स रिकॉग्नाइज किए हैं। तो टीएस अलायंस जो है वो एक्चुअली डॉक्टर्स नहीं चलाते हैं, वो पेरेंट्स और उनके रिप्रेजेंटेटिव चलाते हैं, ओके? सो सच की पावर आपके हाथ में है टू मेक अ चेंज। आपको हमारे ऑलमोस्ट पीछे पड़ना है, हमसे करवाना है, ताकि जो केयर परदेश के पेशेंट को मिलती है वही केयर अपने देश के पेशेंट्स को मिलना नामुमकिन नहीं है। वी कैन प्रॉमिस यू दैट, बट वो साथ में काम करेंगे तो ही होगा। एंड विद दैट, थैंक यू, थैंक यू।
Thank you so much, Pradnya. Pradnya has to leave, she has to catch a flight. The next session is on strategies for challenging behaviors by Dr. Manjula Rao. Possibly she can speak in Hindi or Telugu. Manjula is a senior clinical psychologist. She's working at Apollo Rehab Center and Butterfly's Child Development Center. And she's going to give us a talk on this. Thank you. Anybody wants a tea break now, or we'll carry on? Moms and dads.
Thank you all for coming. This presentation will not be very sophisticated and professional like the previous two presentations. This is like in a layman's terms I have prepared. Okay? Yeah, I'll talk in Hindi and Telugu. Yes, I'm getting the reminder, sorry. సో ఈ ప్రెజెంటేషన్ ఇంతకు ముందు మనం చూసిన ప్రెజెంటేషన్ చాలా సాఫిస్టికేటెడ్గా ప్రొఫెషనల్గా ఉండింది, కానీ ఇది అలా ఉండదు. ఇట్ ఈస్ లైక్ ఒక పేరెంట్స్ వ్యూలో ఎలా ఉంటుంది ప్రాబ్లం అన్నది దాని గురించి ఉంటుంది. హౌ మెనీ ఆఫ్ యూ వాంట్ మీ టు స్పీక్ ఇన్ తెలుగు? 1%, okay, 2, okay. How many Hindi? The rest Hindi, okay? ठीक है. तो अगर मैं भूल जाऊं हिंदी में बात करना या फिर तेलुगु में, प्लीज़ पुट योर हैंड अप so I'll remember that I have to come back to this. Okay, I have very poor attention. All right. And ee presentation oka spectator sport la undadu. I want all of you to participate. You have to move from your places. I'm sorry, everybody, even the seniors have to move. Please. Okay? So keep ready with your bags and all. And quickly, let's take the numbers. So we start with you. 1, 2, 3, 4, 1. Okay? Remember your numbers. We have only 3 numbers. 1, 2, 3, 1, 2, 3, 1, 2, 1, 2, 3, 1, 2. There? 3, 1. Remember your numbers, okay? Because you will go back to the group. 1, 2. Ma'am in the green sari, green dress. 1. 2. Sir, after 1 is 2. Ma'am, black chunni, yeah. 3. 1. 2. Sir. 1. 2. आपके पीछे. 3. 1 है आप 2 है, आप 3 है. 1, 2, 3. Yes, we are all done. All the ones, please come here. All the 2s go there and all the 3s go there. Quickly, before I count 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. All the 1s here, all the 2s there, all the 3s there. Sit up here. 2 है आप. क्या भी आप चाहिए? A little bit of movement, please. I am hyperactive by nature. A pure ADHD. Dr. Pranati will tell me the trouble she has working with her. Please bear with me. Okay. Now tell me, what is your favorite fruit? This fruit. Come on, this is a collaborative effort. Please come forward. That's the group feeling. There's no group feeling. Please come forward. Come forward. Everybody, you have to discuss. Come, ladies, get up. If we are special mothers and special fathers, we have to be like this. We can't say, no, I'm feeling shy. You have to come forward. Make the sense of community here. Okay? Yes, what is your favorite fruit? Mango. What is your favorite fruit? This fruit. It's a mango. No, you can't copy. Apple. Mango. You can't copy. Mango, apple, pineapple. Pineapple. Okay, pineapple. Remember your fruits: mango, apple, pineapple. I'm going to tell you a story. In the story, whenever the word mango comes, you have to stand up. And if the word pineapple comes, you have to stand up. And if the word apple comes, you have to stand up. And if the word fruit or fruits come, all have to stand up. And again, when the word comes, then you have to sit. Okay? Let's see how attentive you are. It's before lunch. Okay? Alright. Once upon a time, there were 2 friends, Anil and Sunil. Both of them wanted to buy some fruits. So they went to the fruit shop. Hello, fruit shop. Fruit shop. Yes. Yes. So they went to the fruit shop to buy some fruits. Yes. They saw apples. They saw bananas. Okay. They saw mangoes. And they saw jackfruit and pineapple. Anil loves mangoes. So he bought lots of mangoes. Then Sunil's favorite fruit is apple. Fruit. Yes. Yes, fruit. Anil's favorite fruit. We go on complaining with our children. What about us? Right? Okay. So they bought their favorite fruits. Your standing should say. So mangoes, apples, and pineapples. They went home. They cut the mango and they ate happily. That's the end of my story.
Thank you.
So,
We still have to sit in our groups?
yes, you have to. You have to. Please form that sense of community because there will be lots of group activities now. Okay, not lot, 2 or 3 more, where everybody's help is needed. And preferably, if there's a psychologist, you can grab her. Where's the psychologist? In this group, yeah. So she's there to help you all. Okay, right. Not much of a thing. So, Manu, itlanti word choosinapudu. ऐसे जब हम शब्द देखते हैं strategies to strategies for challenging behavior, तो बहुत खुशी होती है कि okay, our problems are going to end. But I'm sorry, nobody can give you solution to your problems. कोई भी नहीं दे सकता है. The problems will be there always. Everybody can teach you only to manage the problems. And today, मैं कुछ अलग नहीं कर रही हूँ. I'm not doing anything different. What I'm going to say is how to look at the problem. By looking at the problem, we have the solution in that. Okay? And I'm not going to talk any theory. Theory कुछ भी बात नहीं करूँगी यहाँ पे. Whatever we are going to talk is going to be very, very concrete. Okay? Something which is easy to understand. Got it? So I don't think I need the mic. Not necessary, sir. You're already scared of my voice. All right. So that's a little introduction about me, ma'am has said. And I've been in this field of dealing with children for more than 20 years. Not only as a clinical psychologist, I have also been a director of a school. I had my own school. So I got an opportunity to talk and meet many parents in my life. Okay, and I myself am a special parent. Long time ago, that was 20 years ago, when my son had epilepsy, and I had all those stand spectrums, though it was not TSC, but some parent had asked, are these behaviors not found? ये behaviors दूसरे इसमें भी होते हैं. Exactly. Okay. So today we are not talking about the TAN specific, TSC specific behavior problems, but in general the challenging behaviors. Okay. Right. This is the track of the presentation. एक छोटी सी बात. Mike parallel antunaru. Oh, you want to record? Sorry. So, ఇది presentation track ఈరోజు. ఫస్ట్ ఏమో షేర్డ్ యాక్టివిటీ అన్న కాన్సెప్ట్ ఒకటి ఉంది సైకాలజీలో, దాని గురించి మాట్లాడదాము. దర్ ఇస్ అ కాన్సెప్ట్ ఆఫ్ షేర్డ్ యాక్టివిటీ. అండ్ నెక్స్ట్ వుడ్ బి హౌ వీ లుక్ ఎట్ దట్ ప్రాబ్లమ్. దెన్ వీ సీ గోల్ సెట్టింగ్, ఎలా మనం గోల్స్ సెట్ చేయాలి, కావాల్సిన ప్రాబ్లం, ఆ టార్గెట్ ప్రాబ్లమ్ని తీసి కావాల్సిన ప్రాబ్లం కోసం. అండ్ దెన్ ఫైనలీ వీ కన్క్లూడ్. ఓకే, సో యూ ఆల్ హ్యావ్ దిస్ సెట్ ఆఫ్ పేపర్స్ కదండి. You all have? So, yes. Hindi lo, yeah. So, it's a good exercise. Paper nahi mila? Have you registered? So you have to share it. That's why group is here. Okay? हाँ, इससे पहले जो एक्टिविटी हमने किया था, the little activity that we did, isn't it? That activity was like a starter, एक starter थी. But the kind of excitement that you all had, आपको कुछ excitement लगा? कुछ हो रहा है, ये क्या करने वाली है कि नहीं? So that kind of excitement is what you get when you get into a group activity. Okay? And many of our families, many of them, we do not have any shared activity at home. Okay? जैसे कि every day going for a walk. When I ask the parent, father says, हाँ मैं रोज वॉक पे जाता हूँ, I go for 1 hour, 45 minutes. No, that is not a shared activity. That is a self-centered individual activity. What about your child? What about your wife? No, she has lot of work. She has to cook. She has to make breakfast. No, throw all that. You have to be together. This is a simple thing. But this sets the stage for all the interventions you are going to undertake. It need not be everyday laborious activity. It can be an activity of 10 minutes. Like going for a walk for 10 minutes or once a week playing a board game. Let it become a ritual in the family, a tradition of the family that we all are together. So we'll look into it now. When you look at this picture, what is the information you can gather about the shared activity? What do you think shared activity is? Group 1. Group 3.
Number 1.
We have one.
Group 1.
Some activity that we are doing together.
Right, together. If you have notes, you can write down this word, together. Very important word. What else can you see? Group 3. Now I'm seeing. They're having a good time. Group 2. Afterwards, you have some participation prize in the form of lunch. Group 2. They all have same goal. Okay, what do you think the goal is? I'm saying we'll not go into some theory. What you see, you please tell me. They are enjoying, they are happy, they are together. There is freedom of expression. Right? The parents are happy, so the children learn to imitate. Whatever our children have learnt, don't forget they have learnt it from us. They have learnt it from us, okay? Not to a great extent, but little bit. Okay, so shared activity is an activity in the family which is done together by all the family members, okay? Where there is freedom of expression, which is regular and which is done, you know, it has to be followed in a disciplined manner, just like how you have other rules of sleeping, eating on time. Even shared activity has to be taken so seriously, okay? Now, you have this paper with you. This is an extract from a book written by Jim Taylor in 2013. He's a parenting expert who teaches in the University of San Francisco. And he has written this beautiful book called Your Greatest Gift to Your Children. The book is called Your Children Are Listening, 9 Messages They Need to Hear From You. If you get an opportunity, please read this book. If not, you don't have to. You can just, go through this extract. This is informative. लेकिन ये English में है. don't worry, you can always get back to us and we can translate it for you. So one of the most powerful ways you can express love to your children, कैसे हम अपना प्यार दिखा सकते हैं बच्चों को, वो सभी घरों में आज बहुत कम है, और वो क्या है? समय, time. We give them all expensive toys, clothes, luxury, good food, good schools, good school bags, but no time. How much more time I should give? 8 hours I spend in the house. No. That 8 hours, it may be for you. It may be for your personal work. और वो 8 hours, maybe 2-3 hours मोबाइल के साथ होता है. It's a very serious thing that's happening now, okay? And during a shared activity, the message you send when you are with them, mind, body, and spirit, is that you love them enough to make them your priority. आप मेरे जिंदगी में बहुत important हो. This message you have to give to your children. There is one beautiful incident that happened now. It was really such a beautiful incident. That little girl who was coming here, that girl with the yellow dress, whose child is she? She's your, ma'am, she's your daughter? Okay. So, Sonu, yeah. And this child was, just coming in and she was calling mama, ma, all that. And that's a beautiful opportunity for the mother to respond. The mother, don't worry about these people. Beta, I'm here, I'm coming. That behavior will not happen again. If the mother was in the house, if this happened in the house, I'm sure the mother would respond to the child. The child doesn't know. She needs to have 2-3 kinds of behavior. One formal, one informal. The child doesn't know that. And when such a thing happens, when we are special parents, don't care about anyone, don't care about others. We need to be very true, because they cannot be tricky. As ma'am spoke about IQ levels and all that. So all those things have an interplay, and they don't know, the social cues. Mama is not responding, that means I have to be quiet here. वो पता नहीं है उनको. To teach them that, we have to go step by step. Right now, things will be same. But by not responding, the behavior becomes more. Okay? This is a quotation you have to take home today. How many of you are willing to take home? Some of you are raising your hand with a serious look on the face. Come on, what is it? Okay. You have to keep on smiling, keep on laughing. It's okay, it's okay. We have a problem. Whole life we have a special child. But that's okay. That's only part of your life's journey. It's not your life, the whole life, isn't it? You have other aspects, you have other children. And if you're not happy, the other child will be affected. The most affected child in the house is the child who is normal. We don't know that. They often come out and say, if you've seen that movie Black, there's a beautiful speech given by the blind girl's sister. So that day it's a revelation for everyone. वो लड़की कितना सफ़र हुई थी, because हमेशा special child को बहुत attention दिया जाता है, and the normal child is ignored. Okay? So the mother and the father has to remember, this child is part of our life, not the complete life. You have other parts, other aspects. Okay, now coming to the next part of it. Now shared activity is over, और घर में कुछ एक्टिविटी कीजिए आप. अभी आपके साथ बच्चों के साथ एक अच्छा सा माहौल क्रिएट होगा. A good environment is created, and in that environment we are going to see how to look at the problem. Okay, so here यहाँ पे क्या होता है, सभी लोगों को डायग्नोसिस मिलती है, जैसे कि ऑटिज़म है, इंटेलेक्चुअल डिसेबिलिटी है, या फिर ADHD है. The diagnosis, do you think is of any use to the parent and to the psychologist also? Let me get back to you. Come on, discuss and tell me. I'll give you 1 minute. The question is, how is the diagnosis useful? Is it of any practical value to us parents and psychologists? ये डायग्नोसिस कैसे यूज होगा हमको? प्रैक्टिकल वे में कैसे यूज होगा? Okay, I'll give you, ना, this is confusing you, the same confusion we all have as parents. मेरी एक friend है, उसने WhatsApp message भेजा है मुझे, Hey Manju, can you give me some strategies on how to deal with an autistic child who is hyperactive? It is always like my way or highway. So this is the message I got from my friend and I was confused और मैंने कुछ भी help नहीं किया उनको because she used the word hyperactive. What is hyperactivity? I did not understand. Is it talking too much? Or is it running from one place to another? Or is it climbing the chairs and tables and beds and all that? Or is it throwing things? Or is it making loud noise and playing all the time? You see, we have to break the diagnosis into bits and bits, into small bits. Only then can we work with behavior. And breaking into bits is what helps us to set our goals. Agreed? Now, another question for the groups. You have some white papers with you, okay? In one of the white papers, list some 3 behavioral problems in your children. You can, discuss and list them. कुछ 3 behavioral problems आपके बच्चों में जो है, आप वो white paper में लिख सकते हैं और हमें बता सकते हैं. 3 groups. Each group should not copy, okay? You should have different ones. सबके अलग अलग behavioral problems होने चाहिए. Group 3.
Not listening to anything, continuously asking for same particular one thing and after seeing that,
Collaborate. Please stop.
children they are playing.
This is a group activity where you have to coordinate. 3 behavioral problems. 3 behavioral problems. Yeah, write down. Very good. And who is ready? Tell me so that group has the privilege of telling first. So others, if they copied you, they can change. Ready? Time is up. Yes, sir. Come forward. There's a group here. Why are you alone? We are all together today. Please come. Please come here. क्या? तो क्या हुआ? मैंने तो चेंज किया सबका प्लेसेस. आ जाइए. Come. Please come. Whenever there's an opportunity to connect, don't miss it. We have to walk together. Come on. I'm being like a teacher today. Yeah. Tell me, what's the problem? See, group 1 is ready.
मेरा लड़का 17 महीने का है. वो
नहीं, खाली मुझे प्रॉब्लम्स बोलना है. खाली प्रॉब्लम.
जी मैम.
खाली प्रॉब्लम.
जी मैम. कई बार वो हाथों को ऐसे झटकते रहता है.
हैंड फ्लैपिंग. ठीक है. हैंड फ्लैपिंग. नेक्स्ट प्रॉब्लम. 3 things. Throw throwing things, आपने लिख लिया ना? Hand clapping, throwing things. Somebody write down for the group.
When it throws down whatever he hears, she would like to hear the music of whatever throws down.
Yes.
So ideally. So.
We come back to that. We come back to that. Don't mix up. Don't mix up with the reason. I asked, what is the behavior? That's all. You're giving me the reason.
Okay.
Okay?
Yeah.
Yes, he throws things. He taps his hand.
Hits head. Hits head.
Hits his head.
Yeah.
Anybody has that? Please change it.
One more,
Head
ma'am.
banging. Head, only 3. Head banging. Throwing
things.
Clapping hands. That is with the first group. Second group.
Not listening to others. Not listening.
Not listening to others.
When we give some instruction, he's not listening.
Not following instructions.
Not following instruction.
Okay.
And then changing mindset frequently.
Changing mindset frequently.
First he takes some ball and then he plays for 1 minute and immediately somebody else is playing with something, some other toy. He wants that. Then after 2 minutes he wants something else.
Little interest.
Little interest, yeah.
Little interest.
Yeah, okay.
So, not follow instruction, little interest.
Yeah. And the other one is already somebody told you, extreme aggression and anxiety.
No, you can't call
Yeah,
it
okay.
there. You have
Not interested in studies.
Does not like studies.
That's not like studies.
interested in studies. Okay, fine. Next group, don't worry, let children. Sorry. I'm so sorry. I told you I create this trouble everywhere. Yeah, this group.
With strangers when taking for a walk. Just like that. I have a look.
Okay, hitting strangers, how interesting, okay?
Yeah. And the next one is repeating words over and over again.
Repetition of words, verbal repetition, yes. Next.
And next one is even if we want them to get distracted out of something, they don't get easily distracted.
Sameness. Doing something, want to continue to do the same thing.
It's not like that.
It's not that.
If they want something and that we don't want to give them at that moment of time because it is not appropriate, they don't get distracted. Like if they want to have...
Once again, can you explain?
Like if they want to have milk at that time.
Give me an example, yes.
Yeah. And that is not the time for the milk.
Okay.
And we try to distract in numerous ways, n number of ways. My daughter doesn't get distracted at all. If she wants that, she will stand and she will make sure that I make it for her and then she will leave that place.
Okay. Yeah. So it is obsession, isn't it? An obsessive behavior. I want it, and you're saying it is not in everything, only with few things. So we can't even generalize and say it is sameness. You see, this is the spectrum of behavioral problems, right? How it manifests in different ways, right? So now what do we do? We spoke of all behaviors individually. Then why do we have diagnosis? I'm saying diagnosis does not help us in understanding the problem. Then why do we have diagnosis? Isn't it? So diagnosis is there for physicians, for doctors, for smooth communication between the interdisciplinary group. When I tell Pranati ma'am, this child has autism, then ma'am knows, okay, he has restricted interests, he has repetitive activities, and he has this self-absorbed nature and reduced communication and socialization. Okay? And whatever medicine has to be given, she will give. So for them it is useful. But as parents and as therapists, for us we need to look at individual behavior. एक behavior को देखना पड़ता है. ठीक है? Rather than the whole diagnosis. अगर आप आके बोलेंगे my child is autistic, तो क्या समझ में आएगा हमको? मतलब उनको आई कांटेक्ट नहीं है, तो आप बोलेंगे नहीं नहीं आई कांटेक्ट है, तो और कोई फीचर है, isn't it? So we have to break down that and look at it. Are you feeling bored?
No.
Please let me know, okay? Or I'll come out with some other activity. This time it will be a physical activity. Okay, so we need symptoms for clinical psychologists and parents and not the diagnosis. Okay, now you have a white paper, and on that white paper you have identified some behavioral problems और स्किल डेफिसिट्स। अभी जो आपने लिखा है ना 3 बिहेवियरल प्रॉब्लम्स, ओके। द फर्स्ट स्टेप इन होम मैनेजमेंट थेरेपी व्हेन वी एडवाइज पेरेंट्स, कुछ पेरेंट्स बोलते हैं हम बहुत दूर रहते हैं, सो एवरी वीक हम लोग थेरेपी के लिए नहीं आ सकते हैं, तब चाइल्ड डेवलपमेंट सेंटर्स में क्या होता है, पेरेंट को हम ट्रेन करते हैं और ये ट्रेनिंग को बोलते हैं होम बेस्ड बिहेवियर मैनेजमेंट ट्रेनिंग। ठीक है, ये होम बेस्ड बिहेवियर मैनेजमेंट ट्रेनिंग ऐसी चीज़ होती है जैसे कि अगर आपका बच्चा होम स्कूलिंग कर रहा है तो एवरी 3 मंथ्स जाके एग्ज़ाम लिखे, 6 महीने में जाके एग्ज़ाम लिखे, ऐसे ही आप ये ट्रीटमेंट घर पे करेंगे, लेकिन मंथली वंस या 2 मंथ्स में एक बार आपको थेरेपिस्ट के पास आना पड़ेगा। It is not completely independent. You have to come and report what you have been doing. Clear? Okay. So the first step is we are sitting and going to identify छोटे छोटे phrases में behavior को identify करना है. Remember, we are not going to put reason. He gets angry, so he throws things. No, we are just going to define the behavior. He throws things. Now, in the behavior, 3 behaviors that you told me, pick one behavior. Group 1, one behavior. Which needs intervention immediately? Throwing things. Next group?
Not following instructions.
Not following instructions. You see, we often pick out things which causes us distress. Next.
Repeating words over and over again without meaning.
Repeating words over and over again without meaning. Yeah, those phrases, same phrases he repeats, yes. Okay. Now, on what basis or why have we picked these behaviors? कुछ तो basis होगा, क्यों आपने ये behavior choose किया? 3 behavior में से.
Uncomforts others as well as parents.
Okay. It is dangerous to others. Exactly. So when we pick behaviors, we have some criteria. Okay. Like first criteria is self-injurious behavior. If some behavior is causing injury to himself, like biting or banging his head, then we pick that first. And then the next one is hurting others. And third one is which causes learning impairment. Now, not following instruction, not showing interest in academics is causing learning impairment. Please write it down, all these things. This is how we train parents for home-based behavior management. And these are the strategies I can give you this morning. All right? And when you go back home, don't think you have understood the strategy. That is when all the questions come. We are there. You can call us back. Okay? Right. So, how can you explain the behavior? One group can explain the behavior. How will you respond, ma'am? Please. Beautiful opportunity. Very nice. You can call her. Aajao, aajao. Call her loudly. Call her loudly.
Come.
Very nice. Very nice. However, our children are, we should never be ashamed. First thing is that we should never be ashamed, okay? And how we behave in the house, we have to behave like that. So sometimes in my practice, पेरेंट्स आते हैं और बोलते हैं घर पे तो बहुत अच्छा रहता है, पता नहीं आपके ऑफिस में आके ऐसा कर रहा है, आपके सामने ही ऐसा कर रहा है। साहब, आप भी तो घर पे ऐसे नहीं रहते, आपका भी वॉल्यूम तो बड़ा होता है, मेरे सामने तो आप कुछ नहीं करेंगे उसको, and he will test you, isn't it? Okay, so now the most important thing is breaking that behavior into bits, and you have to make it very small, so that setting goal is important. Like when you say he's watching TV, too much TV. Suppose, let us take this behavior problem. My son is watching too much TV, बहुत TV देखता है. तो ये प्रॉब्लम को हम कैसे सॉल्व कर सकते हैं? Isn't it? तो आपका क्या मकसद है? बिल्कुल टीवी नहीं देखना है? Or do you want him to watch TV for a specific time? Isn't it? Yeah, so the goal is we want him to watch TV for 15 मिनट के लिए, half an hour के लिए हम जो टाइम देते हैं वो टाइम में उनको वॉच करना है. ओके, यहाँ पे एक और चीज़ हमें याद रखना है कि he loves TV and that is our secret plus point actually. We can use that as a reward for him. Okay, so now he's watching TV. Explain this behavior. He comes from school. He sits on the sofa, he takes the remote, he switches on the TV, then he switches from one channel to another. Why are you laughing? It is so similar. It happens in every house. Adults also do that. So, and I keep shouting from the kitchen, Sunny, go and have bath. He does not seem to listen. So we have put so many behaviors in this one thing. That is confusing. You just say one thing, he comes from school, sleeps on the sofa, watches TV. What do you want him to do? He comes from school, change his dress, wash himself, have something, then TV. There are so many steps. You have to sit and formulate these steps. Okay? So this is actually a very vast topic. This time is not sufficient. So I'm just brushing through it, but we are always there. Pranati ma'am is there. Through her you can approach us in Butterflies or anywhere, and we will get back. And skill deficits are also there in children. We think they are problem behaviors. जैसे कि खाना नहीं खाना. Okay. That is actually a skill deficit. जैसे कि वो मुंह तक लेके जा रहा है लेकिन पूरा नीचे गिर रहा है. It's a skill deficit. So when you say he does not eat properly, there is also behavioral problem. There is also skill deficit. That is, I have to go on telling him to come and eat. Even then he doesn't eat. Then what do? I go and feed him. So, all these things have to be changed. Your feeding should be stopped. Your calling him so many times should stop. Then how, ma'am, is the question. We will look at it now. Okay? Is this clear, the target behavior, how to define it? Okay? And as I told you, if the child likes TV, it's a very good news for us. Keep it with us, okay, with you secretly, because we are going to use it as a reward. Whenever the child is doing what you want him to do, remember, giving him a reward is very important. And the reward should be always there, ready, okay. After the child has done, oh, wait, let me go to the shop and get a chocolate for you. No. Next time he will not listen to you. He'll also say, Daddy, get the chocolate and then I will do. Okay, keep the rewards ready. और रिवॉर्ड में क्या क्या हो सकता है? रिवॉर्ड में हो सकता है जैसे कि some solid food, a piece of sweet or a cake, okay, or any khara thing, a mixture or something, or some liquid food also can be there, like some juice, okay, a lemonade, a soda, something, and then semi-solid like kheer. Okay, different kinds of things. Not only chocolate and biscuit, a lot of homemade things also the mother can keep ready. And then we have secondary rewards like TV, or giving some material like toys and all that. And activity. जैसे कि shared activity बच्चों को अच्छा लगता है, तो you can say, this week हम पार्क में झूला झूलने जाएंगे, all 4 of us. And when you fall down in front of your children, they feel very happy. My son is not there. The other day I was giving a lecture like this, and from behind he was telling me, it was in a corporate training I was doing. My elder son, he has a great sense of humor. That is the fellow who was special when he was small. He had epilepsy. He was saying, Mom, next time when I operate your PowerPoint, one slide I'll put how you fell down that day in the park. And then I'll tell everyone, oh, sorry, that was not there. They can never forget the memory of it. Okay? So be funny, there's nothing wrong. Okay? And then social activities like taking them to the park. If you do this, then you get to play with your friends. I'm going to take you to your dadi's place, nani's place, etc. As I told you, not only the bad things, but also the strengths of the child has to be made a list of. Like for example, agar bachon mein sitting tolerance hai, like this child, she's able to sit for such a long time without making noise. That's something amazing. Can you all clap for her? She's getting a clap. You're getting a clap. And you also, okay, the sibling rivalry immediately. Yes. And for all the children who are sitting so quietly, okay, so this has to be appreciated. Normally it's very hard for children to sit like that. So that has to be written in the assets. And whenever you make some good point about your child, you should have lot of stationery in the house. Special mothers and fathers के लिए stationery होना घर में बहुत ज़रूरी है. जैसे कि charts, sketch pens, those sticky notes, all that. उसमें जो भी बच्चे अच्छे काम करते हैं, लिखो and then paste it on the wall. And have some happy pictures on the wall. Okay? And then, these are few examples. Some children don't fuss with food. It's a very good thing. Make equal noise for good things also. When children make mistakes, we make a big noise. Why are you doing that? You're always doing that. When will you learn? These are of no use to children. But when they do something nice, make equal amount of noise. Wonderful. You've always been eating so well, and I'm so glad to have you in my life. Put it up. Take a selfie. Make a photo and put it up. Okay? I know this is all time consuming, but in the end, you will be happy. And then you have one paper with you. Please check. In which you have the frequency.
We don't have that.
One family, one paper I gave. Please. And that is why I put all of you in a group. You don't want to mingle in the group, what should I do? Please. Whoever has a paper, run and go to them. Okay. Now, when you look at the behavior, it's just not enough to define the behavior. वो behavior के बारे में हमने define किया ना, वो काफ़ी नहीं है. अभी हमको record करना है कि वो behavior एक दिन में कितना बार होता है. एक 5-6 दिन के लिए अगर आपने रिकॉर्ड किया है तो आपको एक आइडिया मिलेगा कि ये बिहेवियर मंडे के दिन 10 बार हुआ था और संडे के दिन खाली 2 बार हुआ था या फिर ट्यूसडे के दिन 4 बार हुआ था. उसको बोलते हैं फ्रीक्वेंसी. जैसे कि गुस्सा आना, throwing things. How many times he did in the past 5 days? On Monday he has done 5 times. On Sunday he has done only twice. And in the end, remarks column में you can make your own hypothesis. क्यों उसने कम किया? क्यों उन्होंने ज़्यादा किया उस दिन? हॉलीडे के दिन वो हैप्पी था, सो स्कूल उसको पसंद नहीं है, तो हम उसको स्कूल कैसे इंटरेस्ट दिला सकते हैं? सी हाउ क्वेश्चंस राइज वन आफ्टर द अदर. ओके, राइट. एंड नीचे आपके उसमें ये टाइमिंग शीट. कुछ बिहेवियर्स सेंसरी होते हैं, जैसे कि हैंड फ्लैपिंग होता है. That in half an hour it can happen 3-4 times, or in 1 hour it can happen 10 times. Okay, then in that case you can note down the timing. All right, I'm going very fast in this because afterwards you can ask me these questions. And now comes the real therapy. We got the behavior to work on, 1 or 2 behaviors we have picked, and now we have noted how many times in 1 week this behavior happened. Okay? And now we are going to see when he throws things, just before that, what happened? What was the immediate trigger? You don't have to think, you have to note down. Okay, note it down. But I'm happy, yes. Okay, so just before asking for milk, what has happened? That is called antecedent or the immediate trigger. TSC बच्चों में ऑलरेडी स्लो ट्रिगर्स होता है, जैसे कि स्लीपलेसनेस या फिर एपिलेप्सी या फिर यू नो अदर बिहेवियरल इश्यूज, द ऑर्गेनिक बिहेवियरल इश्यूज आर देयर. एंड नाउ द इमीडिएट बिहेवियरल इश्यूज triggers are what happens just before this problem occurred. I told him to change his clothes. When I told him to change his clothes, he got angry and started throwing things. You know, so now we know what happened before that. So now when you tell him to change, you can expect this behavior will happen. So how can we change that, the antecedent? So maybe वो tone को change करना पड़ेगा, language को change करना पड़ेगा. Instead of verbal instructions, we can just go give him a hug. Come on, it's dress changing time now. Let's go. Okay, you have to be creative in this. And then the target behavior, and then the consequences. मतलब वो बिहेवियर होने के बाद क्या हुआ? कॉन्सिक्वेंसेस एनवायरमेंटल हो सकता है, बायोलॉजिकल हो सकता है, जैसे कि हैंड फ्लैपिंग. ऐसे करने से उनको वो सेल्फ स्टिम्युलेटरी बिहेवियर है, उनको कुछ सेंसरी सेटिस्फैक्शन मिल रहा है, वो बायोलॉजिकल है. एनवायरमेंटल, लाइक जब व्हेन ही इज थ्रोइंग थिंग, the sound of it he is enjoying, and also what are the other things that he is enjoying. The way the parents are looking at him, the way the parents are reacting. You may think, my anger, how can you say my child likes my anger? Because that's the only attention he is getting from you. Okay? You change the consequence and you see. And also see the child's immediate reaction. How he is going to react after that. He has thrown it, the sound has come, and then he sees you, and then what is his reaction? Okay? And in the end, you have to make your own hypothesis like a scientist. क्यों ये कर रहा है बच्चा? क्या वो attention seek कर रहा है मुझसे? या डज ही वॉन्ट टू एस्केप समथिंग? मैंने उसको काम करने के लिए बोला, जैसे कि ड्रेस चेंज करो, एंड ही इज थ्रोइंग दिस टैंट्रम, सो ही वॉन्ट्स टू एस्केप दैट फॉलोइंग इंस्ट्रक्शन. You got it? Right? So some possible hypotheses. There are 5 hypotheses for psychologists, but it's of no use, so I'm not telling you. One is attention seeking, another one is escape behavior, another one is tangible behavior, that he wants something, then he will throw that tantrum. The moment you give him, the tantrum is gone, he's quiet again. The tangible behavior. And then we have sensory issues also. Okay? And they can do all these things because of sensory issues. Right. So now we see how to look at the behavior, record the behavior, and what happened just before that, what happened after that, and how the child has responded, and you gave your hypothesis. All right. So looking at all this itself, you know how to set your goal. She comes from school always watching TV. So as soon as you come from school, so what can I do? Can I hide the remote today? Or can I distract by saying something else? Or can I sit and do some artwork when she's coming so that she comes and involves? Or how else can I change my instruction? There your goal setting comes. Remember, the goal has to be realistic. Ekdam realistic goal hona chahiye. Okay, the child has IQ of 50, and then we say we want him to become a teacher. or a scientist? Is it possible? He will be good at some other things. That is why people call them differently abled. Okay? He will be good at other things. Under the supervision, he will perform excellently. Do not ask him to do something else. That is some other's job. Okay? Let us set realistic goal. Today, he is just watching TV, let's say 4 hours. The realistic goal would be, he should watch TV 3.5 hours. Not 15 minutes. What a drastic change. Okay? And then, you can become greedy and make it half an hour the next week. And then 1 hour. And then 2 hours. Most of the time we are greedy. This is the example I give in all the talks. A classic example. We have an exercise called grain sorting, in which we put all बड़े-बड़े दाने डालते हैं ना एक कप में, जैसे कि काला चना, हाँ, सफ़ेद चना, मूंग दाल वगैरह, सबको मिक्स करके बच्चे को बोलते हैं, take this green gram and put it in the green bowl, take the white gram and put it in the white bowl or the red bowl, something. So the child was doing very well. The mother felt very greedy. What she did, she mixed up rice and methi. And the child, he got mad, he threw everything, and no more attention training. Let us not be greedy, The goal should be very realistic, okay? And it should be attainable, something which the child can achieve. And it should be well defined. Do not say he should change the clothes immediately and watch TV for 15 minutes. No. One goal at a time, okay? And we will plan long-term goals, short-term goals, and immediate goals. Immediate goals for that 1 week or for those 3 days. Short-term for those 3 months. And long-term for that whole year. Okay? And then for lifelong. All right? So what is the take-home now? Giving your time, very important. Shared activities. आपके वो पेपर्स में जो बंडल है उसमें एक रिसर्च आर्टिकल भी लिखा है, मैंने दिया है आपको, which talks about relationships between the 3 variables. And what are the 3 variables? Maternal life satisfaction, shared activities, and child well-being. These 3 have very strong correlations. The research is very hard to understand, but we are there. Please read it up. If the mother is not happy, the whole family is not happy. And now the mother will say, what about the father? He's the cause of my unhappiness. You don't have to live in this marriage. I'm sorry if I'm not trying to break families, but when we have a special child, it is time we put all our differences aside, and husband and wife work like teammates, work like 2 old friends, not like husband and wife if you have differences. At the end of the day, आप ये मत बोलो कि तेरी वजह से बच्चा ऐसे हुआ है, और वाइफ बोलेगी नहीं आपके वजह से ऐसा हुआ है. No, ऐसा नहीं होना चाहिए. You can separate if you want, but you have to work as a team. And when there is a special child, mother के ऊपर बहुत emotional load होता है. Very nice. I'm so happy. Good. Now another thing, this also happens in my practice. When I tell the mother to change the response, the behavior becomes too much. There were many parents who came and said, are you a doctor? They came and asked me. Because this is expected, because your response changed, so now the tolerance of that she will test. I will do more. Let me see if I get back the same response. Very nice. Yeah, ma'am, you carry on. You carry on as you're doing. Wonderful. Another few more times it will happen. When the child is throwing things and you change your response, don't think throwing things will stop. In fact, it will become more. Because this is a different response and the child is testing your tolerance level. Okay, it is true. There are many parents who came back to me and said, no, this is not working. It will work after not only few times, many times, but be consistent with your behavior. Okay, and the second would be knowledge to understanding the illness. We all have good knowledge. I know my child is ADHD. I know he is hyperactive. But when he throws something, I panic. Why? When I know he is hyperactive, that means I only have the knowledge of it. I haven't understood it. If I understood it, I would translate that into action and not panic and be quiet. Okay, he is a hyperactive child. It is understood, he will throw things. Nothing to worry, it's all right. I'm not going to be anxious because my anxiety, he will mirror that. Okay, so there's a huge, it's a long leap forward from knowledge to understanding. Many parents come and tell me, we have accepted the problem, Andy. We know we can live with it. He's ADHD, we have accepted. No, if you have accepted, you will never panic for any of those symptoms. We will work on it in a very calm manner. We would meet that pain in a very calm manner. We would not resist it. Is it time to stop? I'm getting delusional. Okay. All right. And the third point would be observe and record the behavior well. Looking at the problem itself, gives us many solutions to the problem. All these days, we didn't look at the problem. We were escaping from that by labeling our children. I want you to break it down, cut it apart, and see it. Okay? And setting realistic goals. Thank you. Q&A? Anyone? Any question? Okay, it's lunchtime. All must be,
Ma'am, you are from Hyderabad, right?
Yes.
Is there any such institute available in Chennai where we can go for
Yes. Yes. In Chennai, there are many institutes. You can go to one ABA in Chennai. ABA? Yes. Applied Behavior Analyst, who is a very senior person. She's done this applied behavior analysis course from US long back, and she does a great job. She's called Sharanya. You can take down her. Yes, sure. I'll give you her number. And there are, even Chennai NIPMED is doing a great job. NIPMED. NIEPMED. That is old NIMH. Now the government has changed it to NIPMED. National Institute for Empowerment of Persons with Multiple Disabilities, it is called. There you have lovely rehabilitation psychologists. It's the work of the rehabilitation psychologists. They do it very well, the therapy giving and all. Our job is to do the assessment. The ma'am spoke about TANT. That's a very beautiful model of assessment, but our country needs time to get so sophisticated to standardize it to our population. So meanwhile, NIPMED does a great job there. You can go there. Okay? Yes, sir.
मेरा लड़का अभी छोटा है 17 महीने का ही है तभी उसका जैसे मैं बोला फ्लैपिंग ही फ्लैप्स हैंड्स एंड मूविंग हेड अप एंड डाउन तो इसके लिए भी वर्क करना पड़ेगा उसके ऊपर क्या अभी टाइम
डेफिनेटली वो फ्लैपिंग हैंड्स
करना तो इसके लिए क्या करना पड़ेगा मैम वो रोकने के लिए फ्लैपिंग हैंड्स और मूविंग हेड
नो रोकना समथिंग ही इज बीन डूइंग इट फॉर
जब वो खुश होता है या खेलने के मूड में
फॉर प्लेजर दैट इज हिज वे ऑफ एक्सप्रेसिंग हिज प्लेजर फर्स्ट थिंग इज व्हाई डू यू वांट टू स्टॉप इट
मुझे लगता है कि वो जब ये करता है ना तो ज़्यादा स्पीड करते करते स्पीड बढ़ जाता है उसका,
ठीक है,
हाइपर एक्टिविटी लगता है उसका।
राइट. So see, this is your idea. When he is doing this, the speed increases and he'll become hyperactive, and this is not good. We are resisting. We are not meeting that problem properly. Okay, let him do it. You record that behavior. अब देखिए बैठ के कब वो करता है, कितने बार करता है दिन में. You know, only when we learn to record the behavior, we learn to predict. We'll understand when the behavior is going to come again, and that way we can prevent it. Okay, you'll tell me the problem now, I'll tell you many solutions, but that's not going to help. Okay, and about this hand flapping and all, not only we psychologists, there's somebody called occupational therapist. They do a wonderful job too. Okay, but now for the time being, please record that behavior. That is a sensory behavior which we find. Okay, अपने आप को stimulate कर रहा है.
Yes.
Okay, and can you provide that sensory stimulation if he stops flapping his hand? That deficit can you fulfill?
Yes.
We'll work at it. Okay? Yeah.
What I do is
That's not the end, sir. There is a lot of things to talk about it. Okay? So we will get back. Yeah.
my son is 4.5-year-old, so even he does that, flapping his hand continuously. So what?
All question and answers in the Q&A
No,
time.
just
yeah,
1
sure,
minute of
sure.
time.
You can.
So what I do is I hold his hand and he stopped doing that.
Very
he stops
nice.
doing that.
Very
Whenever
nice.
I hold his hand, he stops doing that. So
you can try that. Okay, she has
Thank
given
you.
that stimulation, the tactile stimulation that he needed. Okay, or the try, but don't have any expectations. Okay, it has worked for him, for her child. We don't know if it will work, but there's no harm in trying. Okay, but I want you to record the behavior. Right?
Are there ABA specialists working integrally in the school systems here if a child is very aggressive, or are the parents expected to get private behavior therapy and then they can go to integrate into school?
No, we don't have, I'm afraid, we don't have any ABA working in schools right now. At the most, Indian schools are able to provide a counselor, a psychological counselor, and if there is more fund, they are able to provide a special educator. Other than these two, nobody else. People like us, they call us as guest lecturers. We go and train teachers and give them a screening checklist to screen children for behavioral problems, and then they send them to the counselor, and then the counselor will call us back. So they need specific clinical help. You know, then we go. Right now, the system is like this.
मैम मेरा बच्चा 1 ईयर का है, उनको TSC कॉम्प्लेक्स है बोल के बोले, ये फिट्स जो है उनको कम नहीं हो रही है, एपिलेप्सी जो आ रही, स्पाइजम्स आ रहे हैं उनको.
ये न्यूरोलॉजिकल प्रॉब्लम है मैम. आई एम नॉट एजुकेटेड इन दैट. जी, न्यूरोलॉजी यू हैव टू टॉक टू द न्यूरोलॉजिस्ट. या ओके, बट आई एम सो हैप्पी दैट दे आर ओपनिंग अप. राइट, आई एम ग्लैड. ओके, यस, एनी बिहेवियरल प्रॉब्लम्स?
Hello, ma'am. Actually, we are living in a joint family. So almost we have all 5 kids in my home, nearly same age. My son is 7 years old. He's having one elder sister actually, and another 3 younger brothers and sisters are there. Now problem is that when we have to bring anything for the sports and ball, you mean to say anything, we have to bring for all the kids. Okay, so thing is that after taking one, so for example, he has taken 1 ball. For the other 6 also, we have brought balls. But after playing with half an hour, 1 hour, again he wants to change that mind. He wants for the another balls, which other children is playing. Okay, for timing, if we are adjusting with that also, again after some time he asks for another ball. So he's keep changing his mind again and again to get the new things to him.
Right.
So it's, at that moment for other children also, it's very difficult to explain them.
Right,
okay,
right.
This is having some problems, so give it, share it. Because other kids, they are not understanding that much. So that's
Yes.
the main problem.
So this is like his interest is very short, isn't it? We have to increase the interest now.
Same thing is there for everyone. He's not understanding that. There is no difference. It's all the thing is same.
Okay, in all the other children you mean?
No, I mean to say the ball.
In your son,
Yeah.
Not only for the ball, but for other things also his
Even if
interest
it is a
is low.
balloon, yeah, if it is balloon,
right.
any other.
That is what I'm saying. His interest is low. Isn't it? किसी भी activity में he is not able to hold interest for a longer time. Okay? We have to see why this is happening. Why is he easily bored? Isn't it? He seems to be easily bored. Why?
If it is bored, but the same thing the other person is also having.
Right.
What I mean to say that.
Got the same ball,
Yes.
same color and everything for the other children.
Right. So, yeah, I understood. He's bored with his ball. So, there is the seeking nature. He's seeking another person, right? Another person.
How to tackle that thing actually?
Sir, please record the behavior. See, now I gave you words like seeking. Okay? So, there are many such things you will come across when you record this behavior. Now, as you said, he does not hold interest for long time. That is the behavior. And you gave some examples. I gave him a ball to play. He plays for some time. Then he goes and seeks another ball. Okay. Now he has played it for how long? That you will record. He has played for 5 minutes. Okay. Then afterwards, if he plays for 7 minutes, then it is an achievement. We have to hold it till 7 minutes. You have to tell him, look, this is playtime. Only when the ghadi shows, the hand comes here, you will give the ball. Or when I say give the ball, then you will give the ball. Okay? This we often find, sir, where there are no family activities. Boredom is one reason for that. I spoke of shared activities initially. Do that and see. Okay? And this is not uncommon. What is the diagnosis?
Diagnosis is this is getting
Autism ऐसा कुछ है diagnosis?
Yeah, is there.
हाँ, तो उसमें ये होता है. This is also one kind of repetition. Play, give back. Play, give back. You know, interest is very restricted. All right.
Thank you.
So, but it is manageable. Therapies are available. You have to record the behavior.
Thank you.
Okay. Thank you, sir. All right. No one.
That's it, done. We can take a lunch break.
Yes.
Thank you.
We'll continue the session after the lunch with starting with a parent journey. Mrs. Namita is going to talk about her journey with a child with tuberous sclerosis, and then we'll carry on with the sessions. Okay. So I think this is 2 o'clock, right? So should be back by 2:45. We're already running late by 1 hour. So 2:45 should be better. We'll cut short by 15 minutes.
Thank you, doctor. Hello, parents. Well, no, that's okay. I hope everybody can listen. I'm going to speak in English. It's okay. And if anybody has questions in Hindi, I can answer them too. Okay, let me just tell you my journey as a parent. And it was way back in 2004, my son Ishan was born to me. And basically, I have done my engineering and I have been into my field very strongly. And when I got to know about this difficulty with my son, it was a big struggle for us because we didn't know, we had not heard about what is tuberous sclerosis complex during that time. As the time passed, we went to the doctors. We could just see a lot of symptoms and lot of issues with the child. Infantile spasms had just started, and doctors fraternity in Mumbai, though Mumbai is supposed to be very well advanced as regards medical facility, we faced a lot of problems, and it was very hard for us for first 5 years to get my son to be, even for us as well as my son, to even adjust with the medicines and with the therapies, and there were a lot of challenges. Having said that, the brighter side of it was basically we didn't stop. We didn't stop there. When my son, I could see, is not getting attention and not getting the solution to the extent that we were expecting, we ensured that we go on a research mode. We started Googling, we started understanding what is TSC, and the awareness part was very minimum. So once the research ended up with a TSC clinic in Cincinnati. Basically, that was a time when I understood there is a alliance, TSC alliance, and there is an organization which exists in the United States and which is working for the TSC children, and it's a super speciality which was not at all identified in India. I can say today in Ishan, my son was the first child in the entire India to go to Cincinnati during that time. And it was in the year 2013 that I took Ishan to Cincinnati Children's Hospital, and it was a game changer, I must say. And I'm very proud of taking my son over there. Though it was a 5-year struggle, first thing which we thought and we understood was never give up. And after he went to Cincinnati, his problems, his medical issues and his concern areas were addressed very well. He was put on Sabril. Sirolimus was a drug given by Dr. David France, and Dr. Kruger is still with Dr. Kruger, and that is the time. And till today, I am very, very happy to say that my son didn't even need Indian doctor even once. He's been well followed up, and the medicines have acted very well on him. Now, when we talk about tuberous sclerosis complex, as a parent, I have been studying my child and trying to analyze what are the areas which are to be addressed as a parent to resolve the behavioral issues, to resolve the other issues which are not related to medicines. What we understood was, once the seizures and other aspects were taken care of by the medicine, it's now about behavioral issues and his developmental issues which needed to be handled. To do that, we started working again very hard and got to know again an international program which is called a Domain International Program. Again, it is just a label, but what I want to share with you is, apart from the medicines, which definitely curtailed his medical concerns and issues, we also worked relentlessly on his physical activities, and believe me, that helped in resolving his behavioral issues. You will now ask me, how come physical activities have helped resolve his behavioral issues? And believe me, it is to a large extent. What I got to know was, when the child is put to an aerobic activity and not kept idle even for some few minutes, throughout the day when the child's brain is put to use, I feel the brain grows by using it. and we really had a very, very good experience when it came to his developmental milestones as well as his cognition. Of course, I give complete credit to the sirolimus that was started at that early age in his life. So his cognition also developed very well. Now, my son today is going to a normal school. He is in the 9th standard. His writing skills are very good. His comprehension is excellent. I can say he is not able to speak yet, but his verbal communication is not coming in the way of his living. We are working hard now. How do we help him to communicate in an alternative way? So another very important aspect which I would like to bring to your kitty is that other than the physical activities, medical interventions when it comes to the medicines and other things, another very important aspect is the diet. When the child is on a perfect diet, half of the behavioral issues get sorted out. By diet I mean is, again, you may have to do a proper blood test. Never go just by one dietitian's generic prescription. You will have to get some blood tests done, understand what is the lead content, tin content, etc. into the body of the child. It matters. The vessels in which you are cooking, they matter. Secondly, the environment in which he is living, when it comes to pollution, definitely it matters, and it's my personal experience. And the water that the child is drinking, that's mattering. So if you look at it, air, food and water, which are the primary requirements of any human being, if we are taking care of extremely well with these children, even that matters. Lot of hyperactivity has come down because of that. My son, for first 2 years that is 2016 to 2018, he was off salt, off dairy, off sugar and off gluten. We followed it religiously, but don't go by what I'm saying. You please get your children assessed and let them, if you want me to suggest you what are the blood tests, of course I can share it with you on the WhatsApp group. But then definitely that has helped my son to be very, very composed. He can travel 22 hours to the United States. Okay, now coming to another very important aspect. As discussed by the doctors earlier, one is the medical issues which have been taken care of by doctors. Second one is the physical activities which you guys have introduced. Third is the diet. And the fourth very important thing which I feel like telling and sharing every human parent is keep your child happy always. And when anybody, if you take me as a human being, if I'm happy, I'll do everything what is there. Now happiness doesn't mean giving them what they want. Not giving them chocolates or not giving them something. So keep them happy by saying that. I mean, take them to very beautiful places. Keep them connected to the nature. That's very important. They should know what is nature's beauty. My son, I take him for kilometers of beach walk. He's getting connected, and the beach walk is without chappals and without any sleepers, and he's getting connected to the earth. So it's sort of an earthing. Then when he goes to the hillocks, he's going on the rocks, he's climbing. There are some shoes called Vibrams. We cannot send them with naked feet because of the environment in India. But yes, so keeping the child happy is very, very important. If the child likes music, if the child likes to see some very beautiful things, but not the electronic gadgets. I'm really, I have kept him off the electronic gadgets when it comes to mobile, television. So ensure that these things are brought into the life, irrespective of the age of the child. Even if it is a 2-month child, you definitely can do it by just scanning the books in front of him. The vocabulary develops. Today my son can type any spelling on this earth. I have not taught him. He can type it and he can compose sentences, and it's all all because of the lot of inputs gone in multiple areas. So I would recommend you all to look at multifaceted development of your child by just not doing one thing and getting depressed, and your anxieties are getting transferred into the child. Always be happy, always be bubbly, always be cheerful, which will help them grow very well. And another thing very importantly which I want to tell you is during our time I had to struggle a lot. Financially, God blessed me with certain resources, but we had to really struggle a lot to get to the right doctor, right persons. But now that with Rahul's initiative and all our parents' initiative, we have formed this TSC Alliance group. You all are blessed parents. I'm telling you, it's such a big thing that Dr. Rasi Kruger and Dr. Gibson, she's coming here. I know their worth, I know their value, and you should be very, very active and try to see to that you participate in these forums, not just by asking basic questions, but trying to share your experiences, trying to bring in some positive notes, positive events also as you go along this journey. I have really been blessed with that kind of a child now, that I'm proud to say that though he has a TSC, it doesn't matter. It's like somebody has spectacles, somebody has some ear machines, somebody is having something else, he has a TSC, so what? But yeah, it took some time for me to do. You all are lucky enough that you have got such a big alliance, and US, Katie is here, US Alliance has walked up to you all, and we had to rush, and it was really tough. So please take advantage of this situation, and let's grow this group in a big way. And we have some certain plans which I'm planning to put forward to develop the children and to build some activities for them once they are grown up. What next? It might be your question after the teenage. So maybe that is one of the projects we will come up with. I'm contemplating on that. And other than that, I just have one more thing to share is even your spiritual practices will help you a lot. Whatever all said and done, your own vibrations and your own positivity, your own happiness gets transferred into the children. It's not just because they have TSC. Even if I'm not happy at home, my husband may not be happy. So it's just about vibrations which we need to have at home and at wherever. Definitely the child will develop, and it's all about mindset also, along with other things. So I think let's all be very positive and be happy that we have TSC Alliance India in place. And if you have any questions or any help from my end, you all are always free to contact me. I'm part of the group also. As a parent, I can always be helping you all.
How to join the group?
Yeah, you just send give us your number. I am also an admin of the group. I'll add you. So here, whichever parent is not into the group, please get added, and try and be very positive. Believe me, though there are issues and concerns, you will have to be on the medication. The child has to be on the medication. You will have to be very, very positive and take this forward very strongly. Because today I'm very happy. My son is in the 9th standard. He's going to the 10th. I may take him, I don't know. I'm just going to leave him free to do what he wants to. But there's a lot of hard work and positivity gone into it. So please take it up that way. Anybody has any questions?
You said
yeah.
Sent to US.
Yeah.
In US, everything medical treatment goes by insurance, right?
No. We went on our private as an individual. But if you are a citizen of the United States or you are on a work permit, you may be offered an insurance. If you want to go, you will have to bear the expenses yourself.
Approximately how much will be the budget?
Maybe I can talk to you offline. This is, because there's a lot to be put in. It depends on, but yeah, it's worth going and following up once. Yeah.
right now my child is going to normal school.
Okay.
But as he's having a PCA. Problem is that till now, sorry. So when we have sent him to school, he is in nursery.
Okay.
So because of his behavioral issues and all that, principle of this, they have given 1 year dropout to him. Again, we have readmission in the same school.
Okay.
It's a normal school. So now, what's the main problem is that because of this disease, because of this TSC issues, his mind is not getting that much developed.
No, yeah. Please continue.
His age is right now is around 7 years, but is still behaving like 3 years, 4 years child.
Okay.
So now even the school teachers, the principal is not allowing for the next year for his schools. So now my concern is that he is not totally mentally disturbed. Half is the issues. So now which school shall I take him for the next time?
Okay, see, I'll tell you, you can talk to the school because there is one section which has been introduced by the Government of India, wherein the tuberous sclerosis with associated autism or associated cognitive developmental issues, they should be allowed, those children should be allowed to get into the school. For that, you'll have to go to the government hospital and have him certified. The schools cannot say take him off first, A. B, when it comes to his behavioral problems or he is not able to cope up with his age group in the school, what they normally have been doing in the schools out there, there is an IEP. So individual education plan. So they don't impose the child to take up the age level academics. They will be allowed to do what they are able to, and they have a parallel stream. For that, I'm sure you'll need to go and take a certificate, which is very, very important. The school can't do anything. But if you just walk off, if they're saying like this and you walk off, it's okay if they will not. So please do that. I did it, yeah.
I'm sorry, actually
Yes.
I've already taken from the government school. His IQ level, they have rehabilitated around 65%. So
Okay.
as per their certificate, is supposed to go to the normal schools only.
Okay, then.
But problem is that still he is in nursery, and what their teacher concern is that other people is getting distracted because of this.
Yeah,
So that's
yes,
the main
which is okay. But then at the end of the
They are
day,
not denying me to keep him in school, but same classes again and again because the higher studies and all, he is not able to evaluate.
yeah, so as I told you, there are two ways of handling this. One is the IEP. Secondly, you can have him go for, if the school is for 8 hours, he should go for 2 hours. Maybe in such a period which is not a group activity. There are games periods, there are art and craft. So it's just about his age. For his age, once he grows up a little matured, these behavioral issues may get sorted out. And once the IEP is done, he's not supposed to be doing what the other children are doing into the class, any which ways. You understand? So that is what you'll have to talk to them. My son will not sit for the entire day. He can sit for a couple of hours. They will not say anything for that because those 2 hours the child is with the social environment, plus he is doing an IEP and he is able to cope up. Special schools, I have my own, if he is able to cope up with few activities, he shouldn't be going to a special school. If he is going to a normal school, fine, with IEP. That's very good. Because my son also initially when he was in nursery, up till 2nd standard, it was a very big challenge. I had to go and sit into the class and shadow him. But patience is needed. You will have to tell the teachers and the principal and give them assurity that yeah, we are here as parents to take care of these problems. So infrequently I can send the child, but ensure that he is there in the system. Because now my son has grown up so well, he is able to cope up. So it's a matter of time.
It's an individualized educational plan according to his developmental age, if we can give and tell the school that we are going to work on these skills. They are clueless. Basically, that's why they are seeing that there's no use. But if we tell them that these are the things that the school can do, These are the things that we as parents are ready to pitch in, and these are the things that the therapist is ready to pitch in. So that plan, what Mrs. Namita is saying, individualized educational plan, is very important for the school to work on as well. So the school will do its bit, not much, but we as parents have to do more. Absolutely. With the help of the therapist. But we have to take the help of the school for socialization and to be in the system. Every child has a right to education, whether they are special needs or not. So nobody can deny an admission. Let him stick there, but I think you should get an individualized educational plan and then take the school's help.
Yeah, please go ahead. That's the best way to do. Because eventually he will develop very well. I have seen many children, as they mature, they get into the system. But once you take them off, it's very difficult to get back, into the system. So you must try it. You shouldn't give up so soon. Go with multiple strategies, plan A, plan B, plan C, plan D. One has to work.
There will be lots of challenges, but then, there are solutions as well.
Correct.
So we'll have to work around the system.
Right.
Thank you, Mrs. Namita. Thank you so much. That was very interesting and so stimulating. May I call upon Dr. Sudeep? He is a pediatric cardiologist here at KIMS Hospital. He's going to talk about the TSC and the cardiac manifestations and why it is important for the cardiac surveillance in the parents' language. If you can speak in Hindi, that will be great.
Good afternoon, everyone. See, this is what Dr. Pranati told. First, I'd like to thank her because now it's in the all surveillance. Now, cardiac also is one of the major thing which is come into the picture because there are so many morbidities and mortality associated with that. And what are the things which people don't know about cardiac that we'll discuss here. Now, before that, previously the cardiac surveillance was not given that much importance. But from the last 2-3 updates from this Tuberous Sclerosis Association, they manifest as a surveillance for the cardiovascular manifestation. What are the things which are coming into the picture, how you have to follow, and what you have to discuss with the parents. So with just and usually cardiac presentation may present in one of this form. Suppose somebody is doing just the cardiac fetal echo during the T5 scan during the pregnancy, come out as a mass, or when sometimes with the breathing difficulty, cardiac failure, breathing difficulty, sudden death, syncope, giddiness, or some stroke. These are all usually the manifestation or high BP which can be present as the tuberous sclerosis cardiac manifestation. So with that one case scenario, because this is 1 day old diagnosed to have rhabdomyoma, means some tumor in the heart on fetal echo, but as such it not causing any problem. So pregnancy was continued and child delivered first day, but on first day developed severe breathing difficulty. So because the prenatal diagnosis is already there, they came to pediatric to us. Then we saw there is a mild distress. You can see this is the echo which shows the white color. This is a large mass. Out of the 4 chamber, right-sided chamber are getting little constricted. Because of that, he is having breathing difficulty. Also because of the large defect, the lung volume as well as the mediastinal volume also will get occupied if it goes beyond the heart. So this is there. So what we did, because he is having some mild obstructive symptoms. So now with the advent of the therapy now, the mTOR inhibitor, we thought we'll start it with that. So because having respiratory distress, we started with everolimus, 7th day developed. That after 7th day, usually it's a transient phase also, but distress little bit improved. But on the 7th day, because it's near the upper chamber of the heart, which is giving the beat conduction, so it developed the high beat. Normal beat will be 15, like 120 to 140. It's giving more beat like 200, 250 because of the conduction abnormality. So at that time, we have to give the adenosine and we have to start on some drugs. After that, the heart rate controlled, but the mass is still persisting. But after starting everolimus drug, he didn't have the respiratory distress after 7 to 10 days. So what the recently now with the last 5-6 years, people started trying the everolimus. That is the one drug which is usually used for the other tumors, but it is used here also whenever there are indication for do something. Otherwise, mostly they will be asymptomatic, no need to do anything, and until it is causing some problem in the heart, you don't have to treat anything. So that's what it developed. 2 things. It develops a mass effect distress. So we started everolimus, and because of that also, it it causes the SVT, means high heart rate. So because of that, we have to start other drug. But now over the 2 months now, from that point on, the child is asymptomatic. Everolimus slowly we discontinued after 6 to 8 weeks, but now he is already on the propranolol. So, but what the study shows, once you start everolimus, natural regulation will be 11% higher there. Suppose this is the tumor which is already naturally get small and small, but once you start drug, this regression will take faster, 10 to 15% higher than the natural progression. That's why it's indicated whenever any cardiac problem is there. So this is on the 7th day, we're having heart, you see beating is very fast, so we started. This is with the SVCB aberrant conduction with delta wave, but this is after the propranolol given. So if you see, mostly it's diagnosed in 2 ways, either in the pregnancy when they are doing any scan, so then it will be usually mass or some cardiac failure, then we'll come to know about this tumor. Then later it can present as any of the problem with the heart wall blockage, then it causing either severe heart failure or the breathing difficulty. Or third, without anything, they just go for anything. For the X-ray, you get it, some ECG, some abnormality or some murmur, or whenever echo for some other thing they come to know. So these are the usual manifestations. Otherwise it will be murmur or some thrombo stroke. Then you think stroke from the heart point of view, you come to know there is a mass in that. So these are the usual manifestation by it will be present. So usually I will not go much into detail with this because of the parent session, because usually it will be large single or multiple masses in the heart. So, but the good thing, sometimes even this tumor, this is one of the earlier marker. If suppose this is the multiple tumors are there, 70 to 90% is associated with tuberous sclerosis. That is the crux home take message. Any tuberous sclerosis, 70 to 90%, even if no other symptoms appear, no skin manifestation, but if multiple these tumors are there, small, big, then definitely is going to 90% going to have the tuberous sclerosis spectrum in the future. So this is the early indication to start all your therapy or to prime the parents to take care of whatever the symptoms are about to appear. And at least if you go other way, whatever tuberous sclerosis patient, if you measure, if you do surveillance, 50% come to have rhabdomyoma, may not be symptomatic, but it will be there. So this is important to do the cardiac surveillance because there are so many things, cardiac failure, as well as the breathing difficulty, as well as the ectopics or rhythm difficulty that is associated with tuberous sclerosis. So fetal life, usually when it appears, suppose TIFA, why it's important to do, because TIFA we are doing at 20 weeks. But it's usually appear after the 3rd trimester. So that's why even the routine fetal echo after TIFA, there is one echo is important to do. When any child is already affected, then it becomes more important to do it again and again because it appears usually in 3rd trimester because of the hormonal effect. It appears at 20 to 30 weeks of gestation. So whenever we are doing the TIFA, if anything, you have to again do it again after 4 to 6 weeks to assess where any. See, I also missed 1 or 2 times because when we saw it small echogenic focus, and later after we saw in the 3rd trimester after birth, it turned out to be a tuberous sclerosis cardiomyopathy or rhabdomyoma. So it is very important because if we're not seen, if we're not able to, the fetal loss is around 11%. Out of 100 patients who have large rhabdomyoma, even 10 may get the fetal loss will be there. So it's very, very important to diagnose fetal. That you can see this is 125 weeks gestation. See, there is a large mass. Luckily, she is not having any symptoms of the failure. Fetus is not having any symptoms of the failure. But they continued because after reading everything, they understood it's a spontaneous regressible, and it may the wide spectrum of the mild symptoms of autism to the severe. But the parents continued. After that, we lost the touch after the first echo, but we didn't know the neurological status. So this is the large fetus. You can see in the fetus, the large mass is present of the rhabdomyoma. So, see, the other thing is it usually get regressed over the period. Once you diagnose even neonatal age, up to 2 years, 80% will get disappear. So that's why that is the very good thing for the parents to hear. They think it's a large tumor, but once they understood even after there is up to 4 to 5 years, 80 to 90% will get disappear. But it's still important you have to follow because some it may be small, which may not be seen and again appear at the adolescent age with the hormonal effect again. So the cardiac surveillance important is once you diagnose cardiac rhabdomyoma, it's important to follow every 3 to 5 years. Initially in the 1 or 2 years, as usual, as per your symptoms and the size, and later after every 3 to 5 years up to the later center and later also, because I already told, because and you must be discussed also, कि it's one of the very earliest manifestation when you have no skin lesion, no neurological, no astrocyte, nothing will appear, but this may appear, so it may be the early harbinger of the disease. So the second thing, regression is the rule rather than exception. So that's the good thing, it will automatically get regressed. Only when it becomes symptomatic you have to treat, otherwise there is no need to treat, you have to just follow up over the period. So crux of this is the echo, that is not, see you can see there are different, once I show very large, you can see very small, just child come for without any symptoms, but when we saw there is a small tiny rhabdomyoma which is not causing any problem. So you have to just follow up, because that itself will show in the infantile age or the neonatal age that this child is 90% going to have the tuberous sclerosis complex. So you have to search for the over the period to see for the symptoms of the myoclonus, autism, developmental retardation. So this is the thing, eco-evaluation, the small that will give us the clue. So arrhythmia, what I already told, because of there is a just change in the ECG pattern. Arrhythmia means for the parent change in the ECG pattern. That means it's a normal then higher heart rate, or normal then and lower than normal heart rate. So whenever such things are there, so what is happened when child walks, her heart rate or his heart rate should be stable or becoming higher. But if it's not getting higher, it becomes fixed, then they may develop the syncope of giddiness, because the heart rate is not able to cope up with the exercise. In the second way, it becomes very high. So heart is unable, heart become fatigue. So once you know there is a ECG abnormality, you have to follow it over the period, not to develop into heart block or low heart rate or the very high heart rate. So this is the surveillance. You can see this is one patient who developed in the 6 months of the age, developed VT. VT means there is a very high heart rate which causes the giddiness. So we have to start on the beta blocker, and we have to see over the period. If it not improved, then you have to put a defibrillator like a shock. There is one pacemaker which is coming like a shock. You have to put the defibrillator also. So these are the important aspects. You can see this is the SVT which we improved with the drugs. So you have to see low heart rate, you have to see the very high heart rate, you have to see the very low heart rate, as well as the block also can happen. So this is already I told. So you can see this we missed actually. We thought this is the echogenic focus, which is very normal in the fetal echo, but later after birth it turned out to be the rhabdomyoma, because we not followed after 20 weeks, and it developed in the 28 to 30 weeks. So it's very important, once you get the two echogenic focus in the heart which is abnormal, then you have to go and see for the rhabdomyoma and its harbinger. So otherwise hypertension, sometimes it is called the coarctation. Coarctation is the tube which is supplying the body, it will get blocked because of the mass in the chest or because of the mass in the heart. So it will get compressing the coarctation, and it may got a small tube also. That is the very typical of the tuberous sclerosis. So management, I already told, it's the, as we know, spontaneous recovery, automatically it will come down. That is the rule. But that's why no need, just ECG surveillance and the cardiac echo surveillance and the symptom surveillance. Once you develop symptoms like breathing difficulty, heart failure, not growing weight, very high heart rate, very low birth, very low heart rate, then you have to treat that. And even there are two things now, the drugs are there, so you can treat with the drugs. But if suppose drugs are very high risk, you think it's very long time, it's emergency, you do the surgery also. So surgery not required only to 5 to 10% of these cases. Otherwise 90% you can able to do with the good surveillance. You have to do repeated echo, repeated ECG and cardiologist consultation, and then you can able to manage 90% of the patient. So most common cause of death is CCF only. So this is now the drug which we are using, everolimus. You can see this is the 11% faster regression than natural. So whenever there is very large any symptoms, we'll start this. And you can see there are number of case report, even in 1 month, 90% of tumor may get regressed, or there are the multiple tumors which get regressed over the period. And these are the number of case report which shows whenever symptomatic, rather than opting for the surgery high risk, you can start with the everolimus. And this is one of the paper that shows 6 patients. Out of the 1 died, 1 unable, lost to follow, but 3 improved over the period. And you can see this is a block in the heart which get very much reduced in the lower side, and that it may be improved. So everolimus is a good drug at present to do that. That's why the cardiac surveillance is very important. So in general, cardiac surveillance means all tuberous sclerosis, whenever diagnosed, sometimes it may be the first manifestation, so you have to remain a major diagnostic criteria. Echogram at the time of diagnosis is compulsory. If fetal diagnosis, again serial echogram in the fetal life as well as after birth is compulsory. Surveillance studies demonstrated until surveillance demonstrated, but still nobody knows in the future, again it may come on or that is a still future perspective to diagnose that. So surveillance studies every 3 to 5 years, cardiology consultation, medical and surgical intervention whenever needed, and pediatric to adult transition plan with ongoing cardiology surveillance. So these are the points we don't know what will happen in the future. These are the still points for the research in the future. But the take home message is cardiac manifestation is now included as the major criteria, manifest much before any other manifestation. So once you diagnose, you know the child is a tuberous sclerosis complex in 90%. So you have to follow as per that, and you have to search for the other appearance also. Spontaneous regression is the rule, but may appear later sometimes in adolescent. Even after regression, surveillance is indicated over the period, and long-term follow-up is needed, and medication or surgery indicated in selected substages where unable to get control with the drug or just getting more symptomatic, unable to get control with any other thing, then either you have to do the everolimus or the surgery. So it's a combined effect, you think, from the geneticists, from the pediatric neurologist, nephrologist, neurologist, pediatric cardiologist, electrophysiologist, CT surgeon, above all, the parents who are the main, like that you discussed, they are the main motive, they are the main thing who have to push the parents into the child into the mainstream with this help of these other people. So we are likely to help you at any time. Anything from our side, you are most welcome to consult. We can help you out in doing the cardiac things. Thank you for all your kind listening. Yes, sir.
My daughter is having rhabdomyolysis. She's a patient of TSC. Now recently when I went for... my daughter is diagnosed with TSC and she is having rhabdomyoma. The mass is slowly reducing only.
What's the age? Her age?
She is at present 12 years old.
12 years old.
12 years old. Other than this diagnosis, she is leading a normal life. Recently, when I went for medical checkup, they have also diagnosed the rhabdomyoma in my heart. So the doctor were not having the clue at that time. Then since I knew the history, I told the doctor that my daughter is having this, probably this could be that. Then he collected all the data and then he said that yes, it is that only, but you need not take any medication or something. He said it's okay, it's not disturbing you, you are normal, don't go for any treatment as such. So is that the right approach? Should I go for some treatment?
See, what we told, even because adolescent age, typical 12 years, the hormonal changes, even it may be small, it may come at the adolescent age or later. So until unless it's causing any symptoms, like I told you, high heart rate, low heart rate, cardiac block, no need to do anything because it automatically get regressed. So until unless, that's why out of 100 to diagnose, only 10% will need something in the form of medicine or surgery. Out of 10, if you take again 100%, 70 to 80% regress only with medication, symptomatic. Only of that 10%, only 10% may need the surgery. So it depends on what the symptoms. If it not at all, nothing is there, then there's no need to do anything. That is the very correct approach. Because unnecessarily there is no, because ECG is normal, X-ray is normal, no symptoms, no problem, no giddiness, no high heart rate, no low heart rate. There's nothing to do. You have to just wait and watch. That's why the importance of surveillance. You have to just follow every 3 to 5 years. It's getting more big with the ECG and with the consultation cardiologist. Now the ECG changes are happening. Then suppose ECG changes are happening, then you can, even when she's asymptomatic, you can start some medication that will control the high heart rate or low heart rate. So that's the importance. Even in asymptomatic, but ECG changes are started occurring, that means you need some medication for that. That's why the surveillance of cardiology reference with ECG is must in all these cases with cardiac rhabdomyoma. Okay. Because the most common presentation is arrhythmia, rhythm changes. Okay. Other CCF is there. More common is rhythm changes actually.
Actually, my doubt is second one. Actually, do I also have the TSC? That's what is my.
No, you are also having mass. They told. Huh?
Yeah.
So you have to take ECG. That is correct. ECG you have to take.
ECG is normal.
So then no need to do anything.
Leave it.
But his question is, does he have periods?
Yeah.
Does we have to?
The other criteria, no. It's a major criteria. I think maybe.
No, it's a major. You also have to follow up like her. You also need follow up.
Okay, for heart I will follow up. For the other TSC side, I have scanned, I have taken the MRI. MRI is normal.
Okay.
So, if with your permission, so a cardiac rhabdomyoma, as the doctor said, it's one of the diagnostic criteria. You do not have tuberous sclerosis if you don't have another criteria. We suspect that rhabdomyomas are all driven by the same genes, but we can't give you the diagnosis if you don't have any of the skin or the brain or kidney manifestations. So we would just list you as possible tuberous sclerosis. We would not give you a diagnosis if you had nothing else.
Okay, thank you.
Thank you.
Thank you.
Any more questions? We'll go on to the next lecture or interactive session with Dr. Shweta. She's a pediatric nephrologist from Apollo Hospital, and also she works at Butterflies Clinics. She's trained from AFMC Pune, and then later on went to do her pediatric nephrology in US and in Chennai. She's going to talk about the much awaited renal manifestations in tuberous sclerosis.
So, good afternoon, everyone. Thank you, Dr. Pranati, for inviting me here for the talk and for the for the introduction. So, I'm sorry. So, I'm going to talk broadly about the renal manifestations of tuberous sclerosis. So, while the neurological manifestations occupy the most important cornerstone, renal manifestations should also be kept in mind. And I'm shortly in the next 10 minutes, I'm going to discuss the importance of the renal manifestations and why we should be looking at the renal manifestations. Thank you. So I'm sure all of us know what is tuberous sclerosis. It's a multisystemic disease described first in 1880 with an incidence of 1 in 6,000 and affects all races and genders. And there are certain major and minor criteria for diagnosing the tuberous sclerosis.
Can you do it in Hindi? That's okay.
Okay.
A little bit at least.
Okay. No, I am well conversant in Hindi. आपको कोई भी डाउट है हिंदी में आप मुझसे पूछ सकते हैं. एंड हिंदी में कुछ इंपॉर्टेंस की कुछ पॉइंट्स की क्लैरिफिकेशन चाहिए वो भी मैं बता सकती हूँ. बट टू डू द एंटायर टॉक इन हिंदी I'll definitely give it a shot. Yeah. So these are the basic major criteria, and as you will see in the major criteria, the renal angiomyolipoma also forms one of the major criteria. The major criteria are important for diagnosis of tuberous sclerosis. So renal manifestation जो है, that is also एक major criteria है for the diagnosis of tuberous sclerosis. So symptoms कब start होते हैं? Most of the symptoms renal start, ये cardiac पहले start हुआ, neurological पहले start होता है, but renal manifestations they start approximately around 7 to 9 years of age, followed by skin and lung manifestations. So renal manifestations don't start in the beginning, and hence the importance of surveillance. So it's an inherited. Is it an inherited disorder? Yes, it is. But then there are high rates of spontaneous mutations as well, and about in 2/3 of the patients, बहुत सारे patients में parents को कुछ भी नहीं होता है. Mostly बच्चों को ही tuberous sclerosis manifest करता है. And genetics के हिसाब से TSC1 gene on chromosome 9 and TSC gene on chromosome 16. These are the ones involved. And जब TSC gene involved, 2 gene involved होता है, then the manifestation is more severe. And that is when renal manifestations mostly takes place. And now this TSC2 gene also is very adjacent to one of the genes causing polycystic kidney disease, which is one of the manifestations of tuberous sclerosis. Please ask me, interrupt me in between also if you want to know anything. I'll be happy to answer your questions. कुछ भी पूछ सकते हैं मुझे बीच में. So coming to what are the renal manifestations now and why is it important? Statistically, if you will see, around 48 to 80% of the cases of tuberous sclerosis will have renal manifestations, and hence the importance of screening for renal disorders. The renal manifestations are angiomyolipoma, which is the most common, followed by a close second in renal cysts, renal cell carcinoma, oncocytoma, and other renal lesions like renal artery stenosis and parapelvic or perirenal lymphatic cysts in patients with pulmonary manifestations. So the magnitude of problem, it is the second leading cause of death in patients with tuberous sclerosis. And it is the leading cause of death in adults with kidney disease and tuberous sclerosis both put together. So ये renal problems जो हैं वो सबसे सेकंड मोस्ट कॉमन कॉज है जिसके कारण बच्चे की या पेशेंट की डेथ हो जाती है, स्पेशली जब ये रीनल मैनिफेस्टेशन और ब्रेन का मैनिफेस्टेशन दोनों साथ में होता है एडल्ट्स में, तब ये हाईएस्ट कॉजेटिव एजेंट होता है डेथ के लिए. एंड द कॉजेज ऑफ डेथ क्या होता है किडनी से रिलेटेड? आइदर किडनी फेलियर हो जाए या जो सिस्ट होता है वो एंजियोमायोलाइपोमा एंड रीनल सिस्ट, यू पुटिंग मी इन अ बिग ट्रबल, ओके, उसमें ब्लीडिंग हो जाती है, हीमरेज, यू नो, हीमरेज हो जाता है एंड दैट कॉजेज शॉक एंड डेथ. एंड देन इफ देयर इज अ ट्यूमर, उसके स्प्रेड से बच्चे की डेथ हो सकती है. सो ये सब मैं इसलिए बता रही हूँ क्योंकि मैग्नीट्यूड क्या है प्रॉब्लम का ये समझना ज़रूरी है. हम लोग हमेशा फोकस करते हैं हाँ ट्यूबरस स्क्लेरोसिस है, बच्चे को ब्रेन का प्रॉब्लम है, बच्चे को कन्वर्जन आ रहे हैं, फिट्स आ रहे हैं, वो हमारा फोकस ऑक्यूपाई कर लेता है. बट वाइल वी आर फोकसिंग ऑन दैट, वो इम्पॉर्टेंट तो है ही, मोस्ट इम्पॉर्टेंट है, बट ये भी इम्पॉर्टेंट है, इसका सर्वेलेंस नहीं किया. बच्चे को ट्यूबरस स्क्लेरोसिस मल्टी सिस्टमिक है. वी कैन नॉट बी फोकसिंग जस्ट ऑन वन थिंग, वी हैव टू फोकस ऑन द चाइल्ड ग्लोबली सो दैट द चाइल्ड डेवलप्स इन ग्लोबली. सो कमिंग टू एंजियोमा, मैं एक एक करके लीजन्स के बारे में थोड़ा थोड़ा बताऊंगी. वन बाय वन आई विल बी टॉकिंग अबाउट द लीजन्स. कमिंग टू एंजियोमायोलाइपोमा, इट इज़ मोस्टली benign and it is the most common renal lesion in patients with tuberous sclerosis. Now look at the statistics reported in 75 से 80% patients जिनको renal lesion होता है उसमें ये एंजियोमायोलाइपोमा ही होता है. And in 49 to 60% of the patients, overall tuberous sclerosis के पेशेंट्स में एंजियोमायोलाइपोमा मिलता है. अपने इंडिया में एक स्टडी हुई थी इन CMC वेलोर, इट वाज डन इन 2014 एंड दे फाउंड दैट 60% ऑफ द स्टडी पॉपुलेशन, 60% पेशेंट्स को उनके पॉपुलेशन में, इंडियन स्टडी है इसलिए इंपॉर्टेंट हो जाता है हमारे कॉन्टेक्स्ट में. सो 60% पेशेंट्स को AML था. और AML और ये जो लैम है ना, पल्मोनरी कंडीशन, दे अराइज ऑलमोस्ट बाई द क्लोनल प्रोलिफरेशन ऑफ द सेम सेल्स, सो दे काइंड ऑफ को एग्जिस्ट. सो अगर आपको लैम मिलता है तो डेफिनेटली स्क्रीन फॉर किडनी प्रॉब्लम. If you find kidney problem, screen for the lung problem as well. Angiomyolipoma to begin with life में नहीं होता है. It increases as the age increases. The number भी increase होता है age के साथ, size भी increase होता है age के साथ, complications भी increase होते हैं with age. And especially in women, you know, who I'm talking about adults because ultimately our aim is to transition them into adult care properly, you know. So adult females, while pregnancy, these lesions end up growing and going into complications. So they need to be aware while planning pregnancy and while following up with the gynecologist. So complications mostly asymptomatic. There can be hemorrhage. Hemorrhage मतलब सिस्ट के अंदर hemorrhage हो गया, bleeding हो गई तो क्या होगा, उसके कारण ब्लड आएगा. अगर ज़्यादा ब्लड चला गया तो बच्चा शॉक में चला जाएगा, बेहोश होने लगेगा. एंड ये ब्लीडिंग के चांसेस तभी ज़्यादा होते हैं when the tumor is big. ट्यूमर का साइज जब भी 3 मिलीमीटर से ज़्यादा होता है तो स्पेशली वी हैव टू बी केयरफुल. एब्डोमिनल मास मिलेगा, BP बढ़ जाती है इन सब चीज़ों के कारण, ब्लड प्रेशर गोज अप एंड लीड्स टू इवन किडनी फेलियर, स्पेशली जब अगर मल्टीपल angiomyolipomas and they occupy a lot of renal parenchyma that causes kidney failure. So bleeding risk, as I have discussed, it increases in pregnancy. ये angiomyolipoma are of two types, the classical variant and the epithelioid variant. ये उनके microscopic structure के basis पर मैं बता रही हूँ. So the epithelioid variant, they undergo malignant transformation also. They are known to undergo malignant transformation, and hence the surveillance is required. Diagnosis is most ideally by radiological imaging, ultrasound, MRI and CT scan. MRI is the gold standard. International guideline recommends MRI for diagnosis. And renal biopsy is required when the imaging picture is not confirmatory. And imaging picture say especially there's a confusion between whether it's a renal cell carcinoma या फिर angiomyoma. So उसके confusion को दूर करने के लिए biopsy करते हैं. So ये एक CT scan है which जहाँ पे arrow है आपको दिख रहा होगा, that black colored area, that is an angiomyolipoma. Management, most important, surveillance. MRI at the time of diagnosis of AML and imaging thereafter every 1 to 3 years in known AML. And if the lesion is very small, then even 2 to 3 years of surveillance is okay if the child has been stable for 3 years. Serum creatinine, blood pressure, that is the renal function test and blood pressure, साल में एक बार ज़रूर करवाना चाहिए. That mandates a visit to the nephrologist once a year at least. So this again, coming to this Indian study which was done again in 2014 in CMC, the youngest child with AML was diagnosed at the age of 5 days. Though the average was 5 years, but the youngest age of diagnosis was 5 days. So hence, ultrasound is recommended as soon as the diagnosis of TSC is made. So we should not say that, okay, tuberous sclerosis, AML to आता है around the age of 7 to 9 years, so we'll start looking for that tumor around that time. So it can come as early as 5 days according to that study. The second most common lesion is the renal cyst, reported in 17 to 45% of patients with renal involvement and 14 to 47% of the tuberous sclerosis patients overall. The cysts can be single cyst हो सकता है, multiple cyst हो सकता है, और अगर साथ में genetic involvement हो, जैसे जो बोलते हैं हम लोग TSC2 and PKD1 contiguous gene syndrome, इसमें polycystic kidneys and tuberous sclerosis साथ में होता है, so the child will have polycystic kidneys and then glomerulocystic kidney disease. This is again a CT scan abdomen showing multiple cysts in the kidney. वो black areas जो आप देख रहे हैं, these are all multiple renal cysts. Renal cell carcinoma, it is relatively rare, but important thing इसमें ये है कि it's usually bilateral in these children. Usually renal cell carcinoma is bilateral in tuberous sclerosis, and compared to general population, it appears earlier than the general population. Diagnosis of renal cell carcinoma should be entertained when the lesions increase in size. And hence, again and again, I am re-emphasizing the importance of surveillance. And when there's no, this is a technical term, but there's no fatty tissue in the lesion. वो MRI में हम लोग differentiate कर सकते हैं कि fatty tissue है कि नहीं. अगर fatty tissue है तो वो AML हो जाता है. अगर fatty tissue नहीं है, then that is more towards carcinoma. And ultimately FNAC for histology and cytology. Treatment options, इसमें चूँकि both the kidneys are involved, so nephrectomy is not an option because the child will ultimately end up on dialysis. So we go with something called nephron preserving surgeries, that is partial nephrectomies or ablative therapies. Basically the quest is to preserve the kidneys, and that is why we are talking about everything today. Other renal lesions are oncocytoma, which is mostly benign, can be malignant, perirenal lymphatic cyst in patients with LAM, and renal artery stenosis, and also chronic kidney disease. Now, with the better management of these pediatric patients, more and more kids are growing up to become adults, and as they progress into adulthood, the chronic kidney disease burden is going to increase, leading to dialysis, and later on, if required, depending on the patient and the family situation, the transplants. The cause for chronic kidney disease in these patients are polycystic kidney disease, then multiple AMLs that I described, which can destroy the renal parenchyma, and sometimes when there's huge bleeding, the entire kidney is removed, and that leads to chronic kidney disease as well. So there was a very interesting study. While I was I was preparing for this talk, I came across this very interesting study. It was done in France, and the population was from France and Norway, and they did this study to see how aware the parents and the patient were of the AML, and they actually did this study in form of a questionnaire, and believe it or not, it was like 42% were unaware that AML could bleed. And bleeding is the life-threatening complication of AML. Everyone needs to be aware. 14% of the patients, they did not even know whether they had AML or not. Probably they were not undergoing any surveillance. Lack of knowledge about the risk of bleeding was found to occur more frequently in the group of patients without AML than in patients with AML. And also they found that imaging follow-up was inadequate. They did not receive any renal imaging at least every 3 years, which is recommended. So ultimately, my take-home messages. Renal manifestations, important part hai for tuberous sclerosis. In fact, one of the major diagnostic criteria hai AML. Initially, ये डायग्नोसिस नहीं हो पाती है, सो इट इज़ नॉट इनिशियल प्रेजेंटेशन में AML होता नहीं है बच्चे का. दे मोस्टली कम विद कार्डियक और ब्रेन मैनिफेस्टेशंस, तो उस कारण से इसके डायग्नोसिस डिलेड हो जाती है. एंड अल्टीमेटली ये लोग तभी आते हैं अटेंशन में जबकि कॉम्प्लिकेशन लाइक हीमरेज या कुछ हो जाएगा, तब पता चल रहा है मेरे बच्चे को तो AML था, उस कारण से हीमरेज हो गया, अब हॉस्पिटल में हैं इस कारण से. इसलिए सर्वेलेंस करना बहुत इम्पॉर्टेंट है. ये याद रखना है कि रीनल लीजन्स एज के साथ अपीयर करता है, एज के साथ ग्रो करता है, एंड एज के साथ कॉम्प्लिकेशंस में भी जाता है. स्पेशली अराउंड 15 years ऑफ एज चांसेस ब्लीडिंग का ज़्यादा होने लगता है. पेरीप्यूबर्टल प्रेगनेंसी अगर प्लान करते हैं इन फीमेल्स, देन उस समय कॉम्प्लिकेशंस बढ़ जाते हैं. सो दीज कॉम्प्लिकेशंस जो होते हैं दे आर यूजली लाइफ थ्रेटनिंग, एंड हेंस इसका प्रॉम्प्ट मैनेजमेंट करना ज़रूरी है. प्रॉम्प्ट मैनेजमेंट कब करेंगे? जब हम अवेयर होंगे कि ये प्रॉब्लम हो सकती है. So awareness is very important. Awareness, awareness and awareness. Take home message is only one. Be aware that renal complications happen in tuberous sclerosis. Discuss with your doctor, discuss with your caregiver, and keep an open eye for it to develop at any point in time in life. So basically, we can manage tuberous sclerosis very well if we work in a coordinated manner with the parents, patient, and the doctors. We are all here to help you. If there's anything that I can help with, please let me know. Kuch questions hai? Any questions? I'll be very happy to answer them for you.
Thank you, Shweta.
Thank you, Dr. Pranati. That was the first time I gave a talk in Hindi. Thank you.
Any questions? Anybody?
No? Thank you.
You want to go next, or Lokesh? Dr. Lokesh is going to talk next about epilepsy and in tuberous sclerosis. I think many of us have questions on this topic. We all know Dr. Lokesh very well. He's an eminent pediatric neurologist and one of the pioneers of pediatric neurology in Hyderabad, who raised the awareness about the pediatric neurology as a specialty. He works in Rainbow. He is trained from NIMHANS. He's done his DM from NIMHANS and his MD from PG Eimer and pediatric neurology from Bristol in UK, and he's practicing in Rainbow for more than a decade now. Thank you, Dr. Lokesh.
Thank you. हिंदी में बात करना सबके लिए तेलुगु ओनली तेलुगु आर देयर हिंदी ओके आई थिंक इंस्टेड ऑफ दिस वन आपको जो भी क्वेश्चंस है एपिलेप्सी के बारे में ऑलमोस्ट आप सारे पेरेंट्स जानते हैं. तो ट्यूबरस स्क्लेरोसिस में और मोस्ट ऑफ द बच्चे, बहुत कम बच्चे जो बिना एपिलेप्सी के ट्यूबरस स्क्लेरोसिस में आते हैं, एंड उम्र के हिसाब से अलग अलग तरीके का फिट्स आते हैं. तो छोटे बच्चों में यूजुअली 3 महीने 4 महीने में शुरू होता है जो एपिलेप्टिक स्पैज़म्स और इन्फेंटल स्पैज़म्स बोलते हैं. सुना होगा बहुत सारे बच्चों को अभी भी वो जो स्पैज़म्स जो है चल रहा है. कुछ बच्चों में आसानी से कंट्रोल होता है, कुछ बच्चों में बहुत मुश्किल से कंट्रोल होता है. और तो अभी जो बहुत सारे बच्चों से उनके पेरेंट्स से जो बात किया मैंने, उनमें अभी भी वो फिट्स कंट्रोल नहीं हो रहा है. ओके, तो उसके लिए जो सैब्रिल है, वाइगाबैट्रिन है, वो अच्छा दवाई है, बट उनमें भी कंट्रोल नहीं होता है, तो एवरोलिमस जो ट्राई कर रहे कुछ बच्चों में, और कीटोजेनिक डाइट, कभी कभार कुछ बच्चों में सर्जरी भी काम करता है। तो ये सारा स्टेजेस, अलग अलग स्टेजेस का ये होता है। थैंक यू। सो एज पेरेंट्स आपको कुछ क्वेश्चंस है, क्योंकि मेनली पेरेंटल फॉर्म है, तो आप पूछ सकते हैं ताकि वी कैन हैव ए डिस्कशन और ए डायलॉग। सो कोई भी क्वेश्चन हो, एपिलेप्सी के रिलेटेड हो और कुछ न्यूरोलॉजिकल रिलेटेड हो, तो आप पूछ सकते हैं, सो दैट वी कैन हैव ए डिस्कशन एंड डायलॉग।
We have done the scanning actually.
Yeah.
There is a tumor in brain.
Yeah.
So doctor, what they suggest that due to some spark, the epilepsy, the seizures is coming like that.
Okay.
From last 2 years he's okay now. Almost 1 year he didn't get any seizures. But is that the same thing? Because of that reason it is happening, or what? Because we have done 2 times the MRI.
Yeah.
So the tumor cell size is not increased. Still the same only.
जो ट्यूबर्स बोलते हैं, ट्यूबरस स्क्लेरोसिस में ट्यूबर्स या हमार्टोमास जो बोलते हैं, वहाँ से या उसके नज़दीकी एरिया से फिट से हो जो इलेक्ट्रिकल शॉर्ट सर्किटिंग आते रहता है। तो जनरली हमार्टोमास ग्रोथ नहीं होते हैं। दूसरे तरीके का सेगा बोलते हैं, सबमेटल जॉइंट साइड लास्ट्रोसाइटोमा करके जो बोलते हैं, वो अगर दिखेगा तो वो उसमें बढ़ सकता है साइज़, उसमें कभी ऑपरेशन का भी ज़रूरत पड़ सकता है, या तो एवरोलिमस यूज़ करने से उसका साइज़ भी कम हो सकता है। जो ट्यूबर्स या हमार्टोमस, वो साइज़ नहीं बढ़ता है, वो ऑलमोस्ट सारे बच्चों में 90-95% बच्चों में वो ट्यूबर्स रहता है।
Sega and tumor both will be there, sir?
नो, सेगा एक कम है, सेगा कम बच्चों में होता है, ट्यूबर्स ऑलमोस्ट 90-95% बच्चों में रहता है।
जो white patches पता है ब्रेन में, that is called Sega?
No, that is mostly hamartomas. Hamartomas. Sega is a tumor, small tumor. Sega is a tumor which is not seen in all of them. बहुत कम बच्चों में वो दिखाई देता है। उसके लिए हम हर 1 से 3 साल में ब्रेन का स्कैनिंग करते रहते हैं, ताकि छोटा सा साइज़ में पकड़ लिए तो हम सर्जरी के बदले में एवरोलिमस दे के भी ट्रीटमेंट कर सकते हैं। ओके, सो सर्वेलेंस इसीलिए करते हैं मेनली। ये सेगा है, नया बन रहा है, या उसका बना है तो उसका साइज़ बढ़ रहा है क्या, वैसे ही करने के लिए।
एक आने के बाद मल्टीपल आने के चांसेस है सेगा?
जनरली इतना फास्टली नहीं होता, एक ही बड़ा होता है, एक सिंगल लीजन ही ज़्यादातर होता है।
हमारा बच्चा 1 ईयर का है, उनको इन्फेक्टल स्पाइजम्स आ रहे हैं, सैब्रिल टैबलेट चल रही, लिविपिल टैबलेट टॉनिक भी चल रही, कम नहीं हो रहे उनको। डे में भी 15 टाइम्स आते हैं, नाइट में भी आते रहते हैं, और सोते भी नहीं उनको।
तो
नींद लगते कि आते उनको।
सो इन्फेंटल स्पैज़म्स जो है बहुत मुश्किल वाली बीमारी है। कुछ बच्चों में अच्छा कंट्रोल होता है। स्टीरॉयड भी यूज़ कर सकते हैं। स्टीरॉयड यूज़ किए हैं बच्चे में?
नहीं।
ओके,
ACTH इंजेक्शन कोर्स हो गया,
वो स्टीरॉयड्स ही है,
हो गया
ACTH। सो ACTH
कंप्लीट हो गया, शॉट्स दे दिए।
या सैब्रिल, ये दोनों इनिशियल स्टेज ऑफ ट्रीटमेंट में करते हैं। अगर उसमें कंट्रोल नहीं होता है तो जनरली इधर कीटोजेनिक डाइट ट्राई करते हैं या एवरोलिमस भी ट्राई करके देख सकते हैं। एंड कुछ बच्चों में एक ही जगह से आ रहा है, अगर ये फिट्स जो है स्पैज़म्स एक ही गड्ढे से, एक बड़ा गड्ढा है वहाँ से आ रहा है, तो सर्जिकल एवेल्यूएशन भी करेंगे। बट इस बीच में ये तीनों ट्राई कर सकते हैं, एवरोलिमस ट्राई कर सकते हैं एंड कीटोजेनिक डाइट ट्राई कर सकते हैं। साइमल्टेनियसली अगर कम नहीं हो रहा है, 3 महीने में ऐसे ही आ रहा है, तब तक प्री सर्जिकल एवेल्यूएशन करके देख सकते हैं। कुछ बच्चों में सर्जरी भी काम किया है।
ठीक है।
सो ओके, तो वो दोनों चीज़ कीटोजेनिक डाइट और एवरोलिमस ट्राई करके देख सकते हैं आपके बच्चे में भी।
ठीक है।
ठीक है। या या फिट्स की दवाई, जो फिट्स की दवाई एक बार शुरू करेंगे
जी सर,
कितना आसानी से फिट्स कंट्रोल हुआ और ईजी कितना नॉर्मल है, उसके हिसाब से मिनिमम तो 5 साल चलेगा ऐसे सिचुएशन पे।
5 साल
5 साल बिना फिट्स के रहना है।
जी।
उसके बाद में देख सकते हैं ईईजी करके ब्रेन का स्कैनिंग में कैसे देख के। बहुत बच्चे हैं जो बिना दवाई के हैं
जी,
फिट्स के बाद, अभी बिना दवाई के, बहुत साल बिना दवाई के नॉर्मल है, लेकिन एटलीस्ट 5 साल एक भी फिट्स नहीं रहना है, उनका ईजी नॉर्मल रहना है। वैसे सिचुएशन पे आपके डॉक्टर सोच समझ के कम करने की कोशिश करेंगे। उससे पहले बाकी बच्चों में क्या है, अगर ट्यूबरस स्क्लेरोसिस नहीं है या ब्रेन में कोई गड्ढा नहीं है, दूसरे तरीके का फिट्स भी आते हैं, तो उनमें क्या करते हैं 2 साल दे के कम करने के लिए कोशिश करते हैं, रिकरेंस रिस्क कम होता है। बट ऐसे सिचुएशन पर एटलीस्ट 5 साल देना बेहतर होगा। ओके। और कुछ क्वेश्चंस है? या right, right.
In order to avoid that coming again, can we go for the ketogenic diet or
not recommended?
Not recommended.
Not recommended. So only if it is refractory,
okay,
then we start it.
Okay.
And then once they are controlled, we use it like a drug, and you give it for maybe 2 years continuously, okay, and then take off the ketogenic diet. That's what we generally do.
Okay, thank you.
Okay. Any other questions? I think that should be fine.
We are going to present it. Actually,
yeah,
we were not able to identify some type of seizures.
Okay.
Actually, before my son was diagnosed with that,
you can go through some of the videos, so that they can identify.
Yeah, it will be better if you can tell what are all the types of seizures. We knew only 2 or 3 types.
Yeah. So generally, So this is a young infant, जो छोटे बच्ची है। एक मिनट। So एक तरफ ही देख रही है, आंखें जर्क हो रहा है, बस, और कुछ हाथ और पैर का मूवमेंट नहीं हो रहा है, लेकिन सिर्फ एक तरफ देखे वो मुंह में थोड़ा सा मूवमेंट्स हो रहा है, बस इतना ही फिट्स हो सकता है। सो फोकल सीजर्स बोलते हैं। तो ब्रेन में एक तरफ से शुरू हो रहा है और कभी कभार दूसरे तरफ भी जा सकता है। सो दिस इज ए फोकल सीजर। सॉरी, दोबारा देखते हो। सो जस्ट आई जर्किंग कोई भी साइड पे हो सकता है, आंखों का जर्किंग, हेड जर्किंग भी हो सकता है, और उतना ही, बॉडी का कुछ ज़्यादा मूवमेंट नहीं रहता है, इतना ही काफ़ी है, वो फिट्स बोले। आपको कुछ भी एज ए पेरेंट आपको कुछ भी अजीब सा लगेगा, ये मूवमेंट है, नॉर्मल नहीं है, तो वीडियो लीजिए, आपके डॉक्टर के पास जाके दिखाइए। दैट इज़ द बेस्ट थिंग आई वुड सजेस्ट। सो उससे क्या होता है, आप भी देखे, आपका जो भी डाउट है डॉक्टर इंडिपेंडेंटली देख के बोल सकते हैं वो फिट्स है नहीं है। उसके बावजूद भी डाउट है, देन आपको ये करेंगे, ईईजी करके उसमें क्लैरिफाई करेंगे। ये तो बहुत कॉमन फिट्स है, तो अलग अलग सीवेरिटी का रहता है। ये तो बहुत सारे पेरेंट्स के पहचानेंगे एपिलेप्टिक स्पैज़म्स जो है। सो ये नींद से उठते हैं, उसके बाद बहुत कॉमनली 10-15 ऐसे होते हैं। कुछ बच्चों में थोड़ा सा सीवेरिटी रहता है, कम रहता है, कुछ बच्चों में एक ही साइड में होता है। इस बच्चे में एक ही साइड, जस्ट राइट साइड को हो रहा है। सो कुछ गैप रहता है, उसके बाद अभी इंटेंसिटी इतना सीवियरिटी नहीं है, सो इंटेंसिटी भी कम होते रहता है इसमें। ये बेबी जस्ट जो ऐसे किया वो फिट्स है, बस नींद से उठते हैं, जस्ट ऐसे ऊपर कर रहे हैं, बस उतना ही है। तो ऐसे इंटेंसिटी क्लियरली कब कुछ बच्चों में पता चलता है, कुछ बच्चों में इतना कम रहता है कि देखिए अभी दोबारा हुआ। ओके, इतना, ये भी फिट्स है। सो ये स्पेशली ये 1 साल के नीचे शुरू होता है, बहुत हल्का सा ये शुरू होता है। आप पहचान पा रहे हो? जस्ट ये जो जर्क्स आ रहा है। और एक ये सडन साउंड से साथ ऐसे अकड़ जाते हैं। कुछ बच्चे हंसते हैं फिट्स के बाद, कुछ बच्चे रोते हैं ये फिट्स के बाद। ये अलग अलग तरीके का एपिलेप्टिक स्पैज़म्स बोलते हैं। ओके, सो ये कॉमनेस्ट तरीके का फिट्स है जो ट्यूबरस स्क्लेरोसिस में 1 साल के नीचे जो आता है। सो ये सारे फिट्स के लिए हमारा जो दवाई जो रहता है यूजुअली वाइगाबैट्रिन से कम नहीं होता है, स्टीरॉयड ऐड करेंगे। स्टीरॉयड से कम नहीं होता है, दूसरे कोई दवाई ट्राई करके उसके साथ एवरोलिमस या कीटोजेनिक डाइट, इनमें भी नहीं हो रहा है देन सर्जिकल एवैल्यूएशन ये करते। सो ये अलग तरह जब बच्चे बड़े होते हैं ऐसे फिट्स आ सकते हैं अगर कंट्रोल नहीं हो रहा है। सो टोनिक स्पैज़म्स बोलते हैं इसको। नींद से उठ के ऐसे ही ऑलमोस्ट ऐसे ये फिट्स आते रहते हैं। सो ये ट्यूबरस स्क्लेरोसिस अकेला कारण वजह नहीं है, दूसरे तरीके के प्रॉब्लम्स में भी हो सकता है, बट टाइप ऑफ फिट्स टोनिक सीजर्स जो बोलते हैं ऐसे कंट्रोल नहीं होता है। तो एक बच्चे को ऑलरेडी जो गिर के उसका सूजन जितना हुआ है वहाँ पे बस आंखें ऊपर चढ़ गया, हाथ पैर टाइट हो गया, बस उतना 1 फीट है। अकड़ जा रहा है, पहले आंखें ऊपर जाता है उसके बाद अकड़ जाता है, वो एक तरीके का फिट्स है। अगर कोई सपोर्ट नहीं है गिर जाते हैं, चोट लगा, बहुत चोट लग के यहाँ पे पूरा सूजन है उसका। ये टोनिक सीजर्स बोलते हैं। यूजुअली लेनॉक्स-गैस्ट्रो सिंड्रोम ऐसे कंडीशंस में दिखते हैं। ऑल्दो आवाज कर रहा है लेकिन ये एक तरीके का फिट्स है जो अकड़ गया पूरा। ये तरीके के फिट्स जो है इतना आसानी से कंट्रोल नहीं होता है, कितना भी दवाई करो। कुछ बच्चों में क्या करते हैं ऐसे जब सीवियर रहता है हर रोज़ फिट्स आता है, ऐसे सिचुएशन जो अभी 2-3 जो वीडियोस दिखाए लेनॉक्स-गैस्ट्रो बोलते हैं, वैसे ट्यूबरस स्क्लेरोसिस में भी कुछ बच्चों में रहता है, पूरा फिट्स कंट्रोल नहीं कर पाते हैं। तब क्या करते हैं, जो फिट्स का दवाई जो है उसका साइड इफ़ेक्ट्स मिनिमल रहना है ऐसे, और फिट्स जो है सुबह उठने के कुछ देर के बाद फिट्स आएगा, उसके बाद पूरा दिन फिट्स नहीं आएगा। अगर स्कूल जा रहा है बच्चा तो उसको जब घर में सेफ रहेगा उसी टाइम पे 1-2 फिट्स आने जैसे कंट्रोल आ गया वो भी अच्छा है। ताकि सेफ रहेगा, स्कूल में जाएगा आएगा कोई टेंशन नहीं रहेगा। जब घर में आएगा शाम को शायद 1-2 कुछ बच्चों में आता है, या तो सिर्फ अर्ली मॉर्निंग में आने का रिस्क रहता है सुबह उठने के बाद। ऐसे कंट्रोल आ गया तो भी अच्छा है। कुछ बच्चों में पूरा फिट्स कंट्रोल करने के कोशिश करने के टाइम पे कुछ बच्चों में क्या होता है, दवाई का साइड इफेक्ट ज़्यादा होता है। कितना भी कोशिश करो वो फिट्स तो बिल्कुल कंट्रोल नहीं कर पाते। उस समय पे हमारा एम रहेगा एज ए पेरेंट्स के साथ डिस्कस करेंगे, देखिए इतना फिट्स तो आते रहेगा, इसको ये एक्सेप्ट करना है, बट इज सेफ टू गो टू स्कूल। स्कूल जाएगा आएगा सेफली जाके आएगा। कुछ पेरेंट फैमिलीज को ऐसे भी कंट्रोल करना पड़ता है। आई थिंक दिस इज ए डिफरेंट काइंड ऑफ दिस वन। एक मायोक्लोनस बोलते हैं, सडन जर्क। ये एक ही जर्क रहेगा, सडनली बैठे रहते हैं झटके। स्पैज़म्स अलग है, ये मायोक्लोनस जैसे बिल्कुल एक्टिव है इमीडिएटली उसके बाद। ये बच्चा दूसरा जो स्कूल का रेडी हो रहा है, इस जस्ट ऑब्जर्व हिज हैंड्स। जर्क हुआ, जस्ट इतना ही, जस्ट वो मायोक्लोनस बोलते हैं। इतना सटल भी हो सकता है कुछ बच्चों में, बट जनरली यू गेट ए बिगर फिट्स इन मोस्ट ऑफ देम। ओके ओके सो आई थिंक वी हैव डिस्कस्ड ऑल दिस थिंग्स. ट्रीटमेंट जो है एज के हिसाब से क्या दवाई होना है वो होता है, टाइप ऑफ फिट्स के हिसाब से भी दवाई चेंज करते हैं. एंड अगर पहले 1-2 दवाई में अच्छा कंट्रोल हो गया, उनमें आसानी से कंट्रोल हो जाता है. अगर नहीं होता है तब भी हमको प्रॉब्लम है. ओके, सो जब वो कंट्रोल नहीं होता है तब ये कीटोजेनिक डाइट के बारे में बोलते हैं, एब्रोलिमस, एपिलेप्सी सर्जरी एंड पैलिएटिव सर्जरी, वेगल नर्व स्टिमुलेटर करके भी वो भी ट्राई करते हैं. जिनमें सर्जरी नहीं कर सकते लेकिन फिट्स बहुत ज़्यादा आ रहा है, गिर जा रहा है बच्चा, तब वेगल नर्व स्टिमुलेटर ऐसे वाला सर्जरीज भी करते हैं. ठीक है, सॉरी, vagal nerve stimulator. Yeah, actually if there is a refractory epilepsy, child is falling down multiple 100 or 50 episodes per day, this is shown to actually reduce the number of seizures. ये vagal nerve stimulator के साथ number of fits जो है कम होता है. पूरा शायद कंट्रोल नहीं होगा, it may not stop completely, but the resistant ones and the drops, quality of life could be improve होता है. And there is no surgery of the brain, you are just बैटरी रहेगा यहाँ पे और यहाँ से इलेक्ट्रोड यहाँ पे वेगस नर्व करके रहता है, उसके अराउंड वो इलेक्ट्रोड्स बांधते हैं और यहाँ से स्टिमुलेट करने से भी वो ब्रेन को सिग्नल्स पहुँचा के फिट्स को कम करता है. बट किसी में भी 100% कंट्रोल होता है करके नहीं है, 50 to 60%, 70% तक कम होता है. वो बैटरी लाइफ 5 से 7 साल रहता है, बाद में वो बैटरी चेंज करना पड़ता है. जिनमें वो जो अंदर गड्ढा है वो निकाल के ये नहीं कर सकते हैं. कुछ बच्चों में एक छोटा सा गड्ढा रहता है जहाँ से फिट्स आता है, वो जाके निकाल दिया तो अच्छा कंट्रोल हो जाता है. लेकिन बहुत सारे बच्चों में ऐसे नहीं होता है, तब ये ऑप्शन है. थैंक यू. Yeah.
Role of CBD oil in controlling seizures. Your perspective.
Yeah, I think it's very
Role of
tricky.
CBD oil.
Kruger definitely agrees with this. It is not जो CBD ऑयल बोलते हैं तो वो स्पेसिफिक नहीं है ट्यूबरस स्क्लेरोसिस फिट्स के लिए. सारे तरीके के रिफ्रैक्टरी फिट्स के लिए ट्राई किया है. ड्रावे सिंड्रोम करके है, वो जो दूसरा जेनेटिक डिसीज़ है. लेनॉक्स गैस्ट्रो सिंड्रोम है. सो ऐसे जिसमें भी कंट्रोल नहीं होता है उसमें CBD ऑयल ट्राई किया हुआ है. उसका असर जो है कुछ बच्चों, हमने भी ऑलमोस्ट अराउंड 10 बच्चों से ज़्यादा में यूज़ किया इंपोर्ट करके. Very variable. Only around 3 of them have continued of the 10 which we started. But Dr. Kruger will have more experience.
No, I smiled at Dr. Lokesh because we get this question all the time, every clinic, because you read so much on the, yes, because so much is on the internet. As Dr. Lokesh mentioned, there have been a couple studies for epilepsy, one called Lennox-Gastaut, the other called Tuberous, and some of our TSC patients do indeed have Lennox-Gastaut. And most recently at the epilepsy meetings in December, they reported the results of the cannabidiol study for tuberous sclerosis, which was very successful as well. It will not work for everybody. It will not cure everybody's epilepsy like the internet says, but it will help some. The most important thing is that what you can buy in the market is not the type of medicine that Dr. Lokesh and I are comfortable with prescribing. That there is a pharmaceutical company's version that is pure, free of toxins, and we know how to appropriately dose it versus everything else we're guessing. So that's the challenge I've had in my clinic and why many of my patients have failed, because I don't know what they're taking.
Yeah, I think that's a big problem, because what is easily available on the internet to be ordered, is it not the pharmaceutical version? So that's a problem. Yeah, sure. Thank you.
Thank you, Dr. Lokesh. Now, you want to... I welcome Dr. Samia Razvi. She's a pediatric pulmonologist working in Apollo Jubilee Hills.
Sorry, I didn't.
Probably she's the only one in Andhra Pradesh and Telangana. She's trained from CMC Vellore, her MBBS, and then later on did her rest of the training, pediatrics and pediatric pulmonology from US, and has returned to India about more than a decade ago. And she is going to talk about the LAM, Though we don't see in children, there is a clinic in Apollo set up by Dr. Sai Praveen Harnath, who does a LAM clinic. So Samia is going to raise awareness of this, and then whom to approach in case you have this problem as the child grows. Thank you, Samia.
You can start. Take 1 minute.
So good afternoon, everybody, and I'm happy to be here. But as a pediatric pulmonologist, I really don't deal with LAM, as you will see from my talk. And as Dr. Pranati said, my role here is to learn, as well as you, about the presentations of lung problems in children and adults with tuberous sclerosis, and what we can do to look for it, to watch for it, as the whole afternoon has been, to look about what are the symptoms you would look for when to seek help, and how does it affect your daily life or your life in general. Yeah, anyone. So just take a minute here. Thanks. Yeah. Thank you. So talking about tuberous sclerosis, I was told by Dr. Pranati that the main topic that you wanted to be discussed here was LAM, because that is the main lung manifestation or the lung disease that comes up. And as we know in tuberous sclerosis, it's highly variable. All the symptoms and all the organs or the systems of the body which are affected can be highly variable, and it can present over the lifetime. So sometimes it might start, some symptom might be seen when the baby is days old, some symptom might be seen in the pregnancy, in the prenatal ultrasounds, some might present late. And the key is that to recognize and identify these symptoms so that you can seek help for it. This is most true of the respiratory system, because respiratory symptoms in children or adults with tuberous sclerosis develop somewhere in the 30 to 40-year-old age group. Children very rarely present with respiratory symptoms, and some case reports have been there of a small child as young as 4 or 7 years old that has presented with either a pneumothorax or a lung tumor or lung mass, hamartoma. But most of the time the symptoms are recognized around puberty, or certainly by the age of 20, 30 years old, and we'll see why later. Most of the time in tuberous sclerosis, you're dealing with the neurological problems, with seizures, with epilepsy, and so respiratory symptoms are not thought of much. And if you look at respiratory symptoms, as a pulmonologist, I'd say that the primary respiratory or lung problems that we see that come up whenever you look or read about tuberous sclerosis is LAM, which is lymphangiomyelomatosis, or you come across something else called MMPH, or micronodular pulmonary disease, or also chylous effusions, that are fluid accumulations, fluid that collects in the chest or in the abdomen. But when I as a pediatric pulmonologist think about tuberous sclerosis and lung problems, it's usually due to lung problems that happen secondary to your seizures. Is the child having choking? Is the child aspirating, having difficulty swallowing, or getting into pneumonias? But that's not what we'll talk about today. As a pediatric pulmonologist, some of the patients that I do see may have, due to epilepsy, aspiration, pneumonia, swallowing problems. So those are the things that are secondary. But primarily, due to the lung that is affected in LAM, you see that it affects less than 1% of patients. So it's quite rare. It can happen with both type of genetic TSC1 and TSC2 mutations. And the primary one, as I said, is lymphangiomyomatosis. So it's a rare disorder that's almost exclusively seen in girls or women. It's quite rare in children. And this is basically a cystic lung disease. So just like you saw the renal cysts or the tubers or the angiomyolipomas that develop in the kidney, here in the lung you don't see so much of the tumors, though they can be described. You see more of cystic changes. And 30 to 40% of female patients or girls may have this. Again, remember that it comes on in 25, 30, 40 years old age. And 10% of men can have this. They say that almost by the age of 40 years, 80% of women may have this. And sometimes, just like the other tumors that Dr. Shweta mentioned, that at pre-puberty, when there are hormonal changes with estrogen, progesterone, as the girl is maturing, these can rapidly progress in those years. So the chest X-ray in LAM may be quite normal. It may not be done in the initial years. If your child has TS, there's really no reason to do a chest X-ray early on in the disease. But if the child is having repeated pneumonias, or if the child is having a cough, or some rapid breathing, your pediatrician or your pediatric neurologist might do a chest x-ray. But these x-rays which you see are classic of an older patient, and you might see some haziness, some changes. They might not really appreciate the cystic changes, but these would be seen on a CT, where you'll see these fine, thin-walled cysts that may be seen on the CT. And the right side cuts that you see actually shows where one of these cysts has ruptured. These are the small circular black dots that you see. The rest of it is the lung tissue, like a sponge. These are the small cysts. And then if one of these cysts ruptures, you have an air leak outside the lung, which is called a pneumothorax. And that is the most worrisome problem that you can have with the cystic diseases, that if one of those cysts ruptures at some times, it can cause a lot of problems with breathing difficulties and even an acute emergency. So the major LAM, or this lymphangioliomyomatosis, is one of the major criteria of tuberous sclerosis. And just as you see a cardiac mass like a rhabdomyoma, as the cardiologist Dr. Sudeep was saying, if a patient at any age presents with this cystic lung disease, one of the things that has to be looked for is tuberous sclerosis complex. And the symptoms that a patient might have might be very simple. They might just have some shortness of breath or difficulty breathing with the exercises, which they normally used to do, but now they're just finding a little harder to breathe. Sometimes they might have a pneumothorax. So as a pulmonologist, we'll say that every person is allowed one pneumothorax in their lifetime. That's called a spontaneous pneumothorax. It just happened. You might have been playing a sport, you might have been sitting at home, you might have been, flying, you might have been in activity or no activity, but you might just have a pneumothorax. So everyone can have a single pneumothorax, but in LAM, because of the cysts, you might have repeated pneumothoraces. So the only way to diagnose LAM is a lung biopsy, where you find that these cysts are caused because there's an increase in some muscle cells which are not malignant, they're not cancerous, but there's some muscle cells which just multiply and they cause a little destruction of the lung, and you have these cystic spaces. But as I'll tell you later, lung biopsy is not often done in LAM because sometimes the CT and the genetic picture and the other symptoms are quite obvious. So there is a certain test which you will do, like with a special stain, that will characterize a protein that is diagnostic of LAM, but biopsy is not always required. The other disease which I just want to mention is there is something called a multifocal micronodular pneumocyte hyperplasia. So this is a different type of cell which makes small nodules, not cysts, and this MMPH may also come up, but this does not have any known effect on your life or your symptoms in TSC. A third name which comes up is CCST, or a clear cell tumor of the lung, which is also a benign tumor. Again, both the micronodular disease, MMPH, and the CCST don't have any relation to symptoms. It's only the LAM that we worry about. So if you look at LAM, mostly in females, whereas the other one, which is the micronodular disease, can be there in males and females. And in LAM, you have symptoms, but in MMPH, you don't have symptoms. You might have multiple nodules in the lung. So LAM, worldwide, it's very unclear what the actual numbers are there, but it says, the estimates say that there might be about 3 to 8 persons who have LAM per million women. And large number of patients with LAM either remain undiagnosed or they may be misdiagnosed as some other lung disease. And though the literature says that this is more often seen in white people, or the Western Caucasian patients, and Asians are less likely, or African American or black patients are less likely, it might be that the access to healthcare is not there, and so more of white people or the Western counterparts are diagnosed with LAM. There is one other thing called sporadic LAM, and this happens in people who do not have tuberous sclerosis. The genetics are different because sporadic LAM happens because some of your somatic or your body cells have a mutation, so you have this kind of same cystic lung disease. It qualifies to be called LAM, but it's not inheritable, and it's seen equally in men and women, and the women will not, it's seen more in women actually, I'm sorry, but it will not be transmitted to the child. It's just a random mutation that happens. So we need to differentiate the sporadic LAM from tuberous sclerosis LAM, because the majority of patients that are seen in pulmonary clinics worldwide, most of them have sporadic LAM because they have symptoms. Tuberous sclerosis LAM is usually mild. Patients may present with a pneumothorax, but sporadic LAM patients are more sick, they have more symptoms. And tuberous sclerosis patients, because their LAM is not so symptomatic and is milder at the initial stages, and they're more focused on seeing healthcare for seizures or for other problems, they're not diagnosed as often. So in lamb, the genetic features are because of the inactivation of the same, the same genetic, the same mammalian, the mammalian rapamycin inhibitor is not working here. So in lamb, the TSC1 patients who have that mutation will be more likely to have lamb. But even in patients who have the same genetics, there can be a lot of variation because of different modifier genes. So even in a same family who has the same mutation, they may have different, someone may be more symptomatic than the other person. Symptoms, as I said, can be shortness of breath or difficulty breathing with exertion. They might have some dry cough that is going on for a long time. They may have chest pain in an older person, and that might be diagnosed as a cardiac problem or acidity. And sometimes they might have this fluid accumulation in the lungs, so they might have fluid in the lungs or in the belly, so that can be causing the symptoms. But a lot of times, patients with LAM are often diagnosed, as Dr. Shweta said, when they present with a kidney problem or angiomyolipoma bleeding. And at that time, whenever you have one, you look for the other. And then a CT might be done and you might find LAM. And as she also mentioned about estrogen and the changes, that these cystic changes or these cells that are multiplying, they're sensitive to estrogen. So hormonal changes at the time of puberty, pregnancy, or in the premenopause when they're still actively having progesterone and estrogen, this LAM disease might be accelerated and may increase rapidly. So patients may present with difficulty breathing, a sudden air leak or a pneumothorax, or they might be diagnosed when you just did a CT scan or X-ray for some other reason. Sometimes LAM is diagnosed, or other tuberous sclerosis is diagnosed later in adulthood because a patient may not have had any symptoms, but then might have a pneumothorax and then might be diagnosed with LAM, and then backwards or in hindsight you look for and find tuberous sclerosis. So the CT scan which I showed you before looks like this, and then you might find these smooth muscle cells which are not cancerous, but they're multiplying and causing the lung destruction and small cystic spaces. So LAM can be diagnosed by the characteristic cystic changes on the CT. They are thin-walled, and they are usually having a thin wall, they're uniform, they're scattered in both the lung fields. And other features of the cystic changes, unlike those due to infection or thickened cysts or different type of cystic presentation with other changes in the lung, it can be almost compatible with the clinical diagnosis of LAM, so you need not always have a biopsy. Other features that are there, such as the renal tumors, or you have some blood test which is not always available, like called the vascular endothelial growth factor, that level, or then having chylous leaks or water around the lungs or abdomen, that might help you to diagnose LAM. If you have all these, it's not necessary to have a lung biopsy, but if it's unclear, then a lung biopsy is required. So a lot of times LAM can be diagnosed by the CT. So you can have something which is definitely LAM, where you have a CT which is obvious, and you have all the other tumors and other features of LAM, major and minor criteria. You might have probable LAM, where the CT looks like that and the history is like that, but it's not clear, and possible when the CT looks somewhat like LAM. So the role of lung biopsy, it's rarely done in LAM because of these cysts. When you do a biopsy, you might still make the air leak worse, or you might run into where you rupture one of those cysts, and then it might be a problem just from the biopsy. But sometimes a bronchoscopy and a lung lavage, or you have to look for infection that could have caused these cysts. So it's important to rule out infection. So patients might need to undergo a bronchoscopy to make sure there's no other infection, like a fungal infection or a bacterial infection, that has caused the cystic problems. If you do have to do a lung biopsy, it should not be an endobronchial biopsy, because that will give you a crushed tissue. An open lung biopsy is the preferred method. So there can be delays in the diagnosis of LAM, because sometimes it might be diagnosed the cough or the dry cough, and the shortness of breath may be diagnosed as asthma. They might be diagnosed as COPD if the patient was a smoker or something like that. And young women, whoever present with a spontaneous pneumothorax or a sudden air leak, sometimes they say that, okay, it just happened because she was thin, she was flying, or she was deep sea diving or swimming, and they may not look for this. So the solution is that if somebody has a spontaneous pneumothorax, usually even in pediatric patients, we do get an HRCT to make sure that there is no subpleural cysts or small cysts, which can be, other than LAM, genetic conditions or familial conditions where you might have small cysts. But if a young woman presents with a spontaneous pneumothorax, it might be a good idea to do a CT at that point. So the natural history is, because these cysts tend to form and then they tend to progress around the premenopausal years, it progressively worsens your lung function, and the lung function may go down because baseline lung function might have been low. It depends. And if the patient is postmenopausal, they may not worsen so much because the estrogen, progesterone hormones are less. And depending on how the lungs respond to bronchodilators, they might or might not be a prognosis, might not get worse. And the outcomes, LAM, just like Dr. Shweta mentioned about the renal issues, they can cause significant problems and morbidity. Renal involvement usually is the most common cause of serious problems or even death in tuberous sclerosis. Most of the times, tuberous sclerosis LAM patients have a milder disease, and they can survive up to, for 10 years survival is like at your age, say if you're diagnosed at 30 or 40, 10 years survival maybe 75 to 85%. But it's important to diagnose because, as I said, the spontaneous pneumothorax might be life-threatening. So in screening of LAM, because LAM amongst female patients of TS may be between 25 to 50%, as I said, almost 80% by age 40, we should be screening for LAM more actively in women. And one way to do the screening or the surveillance or watchful waiting and looking for these symptoms is at every visit with the doctor, symptoms of cough or difficulty breathing, exercise intolerance where you can't do your exercise as normal should be asked from every adult who has tuberous sclerosis. And some of the guidelines do recommend a baseline screening at age 18 when young girls with TSC become adults, a baseline CT to see for any cystic changes at 18. Then when to do the next CT is not so sure. So some guidelines say do it at 30, and some guidelines say do it at age 5 to 10 years after the first CT if the first CT was negative. Obviously, if your first CT did have some cysts, you would have more frequent evaluations with a pulmonologist. So those who do have some cystic changes, they should have annual pulmonary function tests, which means breathing into a computer to see your lung capacities, and periodic CT based on your disease and symptoms. So when you look at the management of LAM, as the other drugs that were mentioned, sirolimus, everolimus, there are drugs for that. Then there's a way to monitor the disease, how your lung function is, how to monitor the side effects of the drugs. And one of the common problems which patients will ask any pulmonologist if you have cystic lung disease, how safe is it to travel by air or how safe is it to go diving or swimming? Because at both of the situations, the pressure in the atmosphere changes and the cyst can enlarge or rupture. And then with any lung disease, to prevent secondary infections, you need to have optimal vaccinations. So sirolimus, as mentioned for the other two systems, kidneys as well as the brain, based on the knowledge of the rapamycin pathway, sirolimus has been studied in Cincinnati by the CAST trial. And the initial study had about 11 patients from what I looked up, and they checked the PFTs. That's when they breathe into the computer and do the spirometry, and they found that there was a significant improvement in PFT when the patients had taken sirolimus. So after that, there was the MILES trial, which looked at the safety and the effectiveness of sirolimus. And in this, 89 patients were studied. So in this, there were two groups of patients. One group got sirolimus for about a year, and one group did not get sirolimus. And then they followed both the groups of patients, those who got sirolimus for a year and those who did not get sirolimus for a year. And then they stopped the medication, and then they followed a drug-free period of 1 year for both groups. And they found that in the sirolimus treated group, there was an improvement or the slowing in the lung functioning. So all adults after the age of 25 or say young adulthood, every one of us has a decline in our lung capacity with every passing year. That's the normal aging process of the lung function. So maybe after your young adulthood of 25, 30, you have a reduction in your lung capacity by say 1%, 1 to 3% each year. And in any lung disease, there is a worsening or the more rapid worsening. So when they looked for following the trend of lung function in these patients who took sirolimus and those who did not take sirolimus, they found that the rate of worsening of lung function was slower as compared to the normals. Because even in the normals, you will have some age-related reduction in the lung function. But when they stopped the drugs and they looked at both the patients in the drug-free period after a year, in that year, the rate of decline was same, which suggested that sirolimus actually just suppresses your worsening. It doesn't reverse. And then when you're on sirolimus, it suppresses your worsening in lung function. But when you stop it, you continue to have the same age-related changes as somebody who's not taking the drug. So the other drug that Dr. Lokesh mentioned, everolimus, it has been studied for other systems, but not for lung. It is approved for use sirolimus is approved for use, and it is assumed that everolimus will have the same effect on the lung, being of the same group, but it has not been studied as much. So when you're on sirolimus, usually you need to look also, when you're on any drug for long term, you're going to look for the side effects, and usually the side effects are mild. Most often you find with sirolimus, when it is used as an immunosuppressive or this rapamycin inhibitor pathway use in other diseases, you find stomatitis or oral ulcers, redness of the tongue, skin lesions, sometimes lipids will go up, sometimes there's nausea and diarrhea. And serious conditions sometimes like a pneumonia or proneness to more infections or some heart issues can occur, but these are rare. Usually the adverse effects are mild and they're seen in the first few months of starting sirolimus, but once you're on the drug for a longer period, these side effects are stabilized. So when you're on sirolimus, you should check lung functions, you should check labs which include your blood counts, your metabolic profile with your sodium, potassium, urea, creatinine, your lipid profile, and urine should be checked initially every month, then every 3 months. Patients are always cautioned about sun exposure when they're on sirolimus, and sometimes, ironically, pneumonitis can occur. Serum VEGF-D levels can be checked and they're known to decrease, but this is not always done. Vaccinations to prevent any other infections that might worsen your lung disease once you have cystic lung disease. Patients should get annual influenza vaccine, flu vaccine. They should get a pneumococcal vaccine. The basic one which children nowadays get in the routine series is the new Prevnar 13 on the pneumococcal conjugate vaccine, which is 13 types of pneumonia bacteria that you can protect your child with. And then there is the Pneumovax 23, which is a polysaccharide vaccine that protects you against 23 strains. So patients should get the PCV 13 if they haven't had it, and they should get the Pneumovax 23 every 5 years. Usually my infectious disease colleagues say that you can take Pneumovax about twice in a lifetime or 3 times max. So as for if you start taking it as a younger child, you might take it twice, but if you're taking it in adulthood, you might take it at age 40 and then at 50, maybe at age 60. So in general, when you're taking sirolimus, you avoid live vaccines like MMR, chickenpox, measles, rubella vaccines. Other precautions which patients often ask about with any cystic lung disease, or even if a child has a pneumonia and then that pneumonia is improved and you have a cyst in the lung, there's always a risk of worsening of the cyst when you fly because the air pressure is low at that height in the air travel within the plane, and the cyst can enlarge and rupture. So it's estimated in LAM that 1 to 2% per 100 flights you could have a cyst rupturing. So reasonably it's safe, but I think every individual has to take it in the context of their own lung disease, the size of the cyst, and take a doctor's opinion before flying. But you need not always be very scared about flying about with air travel if you have cystic lung disease, especially if the cysts are not near the surface of the lung, but if they're deeper. So because of this cystic lung changes, more than 50% of LAM patients who have this in adulthood will have at least one spontaneous pneumothorax in their lifetime, and the average number which LAM patients can have will be even 3 to 5 episodes in their lifetime. So because of this high recurrence, unlike a normal patient who does not have LAM or tuberous sclerosis complex, we might leave a patient who has, as I said before, everyone is allowed to have one spontaneous pneumothorax in their life. The same way, I think Dr. Lokesh will agree that everyone is allowed to have one grand mal or one Rolandic seizure in their life. So there are certain things that come within the norm. But for LAM patients, because the recurrence is so much, you would not leave a LAM patient after the first, it's not recommended to leave a LAM patient after the first spontaneous pneumothorax and just do observation like you would a normal patient. You would offer them pleurodesis, which is a procedure by which the two linings that cover the lung, the pleura, are stuck so that there is no space for the air to collect. That's called pleurodesis. It's a procedure that can be done by a thoracoscopic, minimally invasive process. And then there's prior pleurodesis, which lots of patients worry because ultimately in LAM or any other lung disease, you might be looking at a lung transplant if lung disease gets worse, just like you would look at a kidney transplant if kidney is getting worse. But pleurodesis, if it is done for this pneumothorax for a LAM patient, does not make you unfit for a transplant later. It just helps you from not getting repeated pneumothoraxes, which can be dangerous for life. So every patient with LAM as an adult should know about the symptoms of a pneumothorax, and they should seek immediate attention. If they have any odd lung symptoms, they should avoid air travel. And even on the other extreme, scuba diving, where you're again experiencing higher pressures when you go deep sea diving, and then as you come back up to the surface, those pressures are released and the cyst can enlarge. So scuba diving also, according to the British Thoracic Guidelines, is not recommended in LAM. So for all of you, the take-home points which I got from looking up and reading this for this talk today is: report your child's or your respiratory symptoms to your doctor at any time. Women especially need to be aware of symptoms of pneumothorax, chest pain, sudden sharp pain in the chest. And sirolimus is useful, which needs to be monitored. It may slow down the lung function, worsening in lung function, but it's given over a period of time. And CT scans, PFTs need to be followed as always, watching for worsening or any complications. Vaccines should be taken. Any patients with LAM who are undergoing any surgical procedures will have to get good anesthesia clearance because of the cystic lung disease. And VATS can be done with a mechanical abrasion for recurrent cysts, and this is useful to prevent life-threatening pneumothorax later. So I'll just end there and say thank you, and any questions about lung disease? I hope I wasn't talking too fast, but I wanted to just cover it. So anybody wants to ask? I think for most of the group here who are children, I think most of the problems that I discussed today with LAM are more pertinent to them as they grow older, girls especially when they're teenagers. But anyone, I would say that you just need to be aware of these symptoms, because in the case reports there are cases, rare, few, you can count them on your fingertips, maybe 2 or 4 patients with tuberous sclerosis who had respiratory symptoms in the early years. But it's just good to know these things for yourself and for your family.
Thank you, Samya.
Okay. Thank you very much.
Any other questions? I mean, we have a question hour now. We can take tea or have a question hour. I think Sonal wants to go out. She's been very patient today. Anything pertaining to tuberous sclerosis, development, psychology, behavior management, surveillance, epilepsy?
How it will impact the behavior changes? Do you see a drastic change in the behavior?
Certainly the seizure burden, I think, will add to the behavioral problems. If the child's seizures are under good control, we expect the behavior to improve as well. It depends on the seizure burden of the child and what was the child's level of understanding and the cognition before the seizure onset. And certainly seizure control for a year definitely will improve the cognitive and behavioral changes. I don't know if Dr. Dasi can answer that question. No.
You answered very well.
Yeah.
Speech and other things.
Each child is different, so it's very difficult to predict, but overall I think there will certainly be an improvement in the child's progress.
Take an example. My kid is 3.5 years old. His name is Gagan. He's not having seizures by God's grace these days. Okay, so what would be making me eat so much sugary items? After talking to Namrita, I understood I should stop. But you know milk biggies, right? He eats daily 1 packet.
No, this is my personal experience, and some other parents in the same group who tried what I told has really helped. Chocolates, sugar, sweet items are basically causing hyperactivity and behavioral issues mainly.
So At the risk of Ishan's mother getting mad at me, no. So when it comes to diet and neurological disorders, it's been very difficult for us to study these and find the direct links between how diet interacts with how the brain works. In the laboratory, we certainly see these relationships, but when we see these relationships and we try to move them into the clinics, it always gets much more difficult for us to know what is helping and what doesn't. And so anytime we've done studies where removing sugar or removing gluten from patients who just have epilepsy, who just have learning difficulties, who just have autism, none of those studies have worked. It's because we still don't understand those relationships yet, even though we see clues of them in the laboratory. So at this point, generally, when I see patients in my clinic, it's very difficult for me to recommend a very specific dietary change for them. But parents ask me, or they come to me with their own personal experience, and I believe them because I do think it's possible, but I also want to make clear that we as doctors lack the studies to tell us how to recommend that to you. So generally for my patients, I'll say, if you want to try it, please do, and then come back and tell me in a couple months. 2 to 3 months is a good time period so that we can evaluate if it's helped. And just like if I gave you a seizure medicine and you came back to me and said, my child is still having seizures every day, you're going to ask me as a doctor to change something. So when I have a patient who's made dietary changes and they come back 2 or 3 months later and everything is the same, I'm going to say, I don't think it's working. Okay, but it's certainly, in most instances, it's very appropriate to try. The last piece of advice I would give is when people use extreme diets. And I'll give you an example. In epilepsy, you heard us talk about the ketogenic diet. That is not a natural diet. And so it's one that we use as a medicine, and we use nutrition specialists to work with you to make sure you do it correctly, because it is not a natural diet. And you could miss vitamins, you could miss important minerals, your child could quit growing if it's not done correctly, and there could be other complications in the body. So normal diets where you change common things, very appropriate and very easy to do. But if you sometimes read about these extreme diets where they take everything away, or where you're taking 80% of your diet of one thing, you need to be very careful. You want to translate that?
Yeah. क्या बोल रहे जो डाइट यूज़ करते हैं GFCF डाइट या कोई भी डाइट नॉर्मल नहीं है सबको. सो कीटोजेनिक डाइट जब करते हैं वो तो एपिलेप्सी के लिए प्रूवन है, काम करेगा. लेकिन जब शुगर्स कम करना है या ग्लूटेन निकालना है, उसके लिए एविडेंस इतना नहीं है. तो अगर आपको बिहेवियर के लिए ये डाइट करना है, क्या बोलते हैं, 3 महीना ट्राई कीजिए. तो आप एक जगह पे लिस्ट रखिए क्या क्या सिम्टम्स है, प्रॉब्लम है. हाइपर एक्टिविटी है, गुस्सा करता है या मारता है, या बच्चों के साथ मिल नहीं रहा है, अपने आप में रहता है, जो भी सिम्टम्स है एक साइड पे लिख के रखिए. उसका कोई साइकोलॉजिस्ट के साथ स्कोरिंग कर सकते हैं, सीवियरिटी स्कोरिंग कर सकते हैं, वो रखिए. 3 महीने के डाइट के बाद दोबारा वो स्कोर कीजिए, आप भी एज ए पेरेंट, एंड टेक कोई साइकोलॉजिस्ट के साथ भी वो स्कोरिंग कराए. अगर क्लियरली इम्प्रूवमेंट है डाइट के साथ, तभी कंटिन्यू कीजिए, नहीं तो डाइट बंद कीजिए. या टू मच ऑफ शुगर और प्रोसेस्ड फूड जो है जनरली अवॉइड कर सकते हैं, हाइपर एक्टिविटी रहता है. बट ग्लूटेन एंड स्ट्रिक्ट जो कुछ भी नहीं देना है, कुछ लोग बोलते हैं दाल नहीं देना है, टमाटो नहीं देना, ऐसे भी डाइट बोलते हैं, ऐसे सारा ज़रूरत नहीं है करके बोल रहे हैं. ठीक है, सॉरी.
Sugar especially is and secondly, if you look at it from a medical point of view, I'm just telling you because of my experience, the weight of the child increases. Again, epilepsy can occur because of major weight, because the dosages have to be increased. If that doesn't happen, there's an issue. Sugar absolutely is a big no. Yeah,
We say sugar is not good for anybody.
Anybody, yes. Practically, that's not fair. And the chocolates, especially, I've seen children hogging chocolate because there's something they are deprived of, and then they get into hyperactivity mode.
But then once in a while, I think we can.
No,
give them as
the
a
child is
record.
having every day.
No, not every
so
day.
that is where I just thought I must into.
Yeah, that is not good. Yeah, that is not good.
That is.
Yeah, no, not every day, but once in a while as a reward, maybe you can try it. Yeah, not complete deprivation, but you can use it as a reward system for any positive behaviors that the child would have. Processed food has a lot of E numbers and preservatives, which are not good for anybody. I mean, we're not talking especially about our children or differently able children or children with disabilities, but it's not good for anybody. So I think, preserved food is not good for anybody. So homemade food is always better, and moderated sugar, everything in moderation. I mean, nothing in excess. That I think that works well. And a lot of physical activity, so that's very good as well to burn down the energy and regulate the sleep time and physical activity and have some structure and a family time. These all are very helpful for the child's behavior. In addition to the regularized therapies as a family, I think you can do that maybe.
Similar question in this line. Are there any household or triggers for epilepsy which we do at home? Like stress or sleep deprivation, which can cause epilepsy or seizures?
Sleep deprivation certainly, I think Dr. Lokesh also agrees. Sleep deprivation certainly is a single most trigger for not only the epilepsy, but also the behavioral disorders. Hyperactivity, inattention, memory formation, irritability. So that's very important that the sleep be regulated. And in order for the sleep to be regulated, you should have a sort of a rhythm or a certain structure in place. And that should include physical activity, both structured and non-structured play. Okay, non-structured play so that the child is free to run around and burn the energy. And physical activity is very important for a child. And especially with our children who are special, we tend not to take them out that often. But we have to make sure that they are taken out every day for an hour at least, so that they burn out their energy and then the sleep cycle is regulated. So that can help us in better control of epilepsy and the behaviors as well. And it improves the learning as well.
There's a question in the group that they want to know more about SEGA.
Symptoms of
More about symptoms of SEGA.
I'll take this one since I spoke about SEGA today. So SEGA, like I said, occurs only in about 10 to 20% of patients. It is usually going to occur in childhood. There are some situations where we worry about it in adults, but most of the time, even those adults had SEGA when they were children. The symptoms of SEGA early on are very difficult to ascertain. It can be just a change in behavior. A child can become more irritable. It can be a clumsiness where a child is dropping things or tripping or falling. And then as it progresses, the children may complain of double vision or they may complain of headaches. The difficulty is, as a child who is very young or is having difficulty learning or doesn't have speech, how do they tell us that they have a headache? Or how do they tell us that their vision is getting blurry or they're seeing two things instead of just one image in front of them? And that's where we as parents get very good about ascertaining the story of our children. Yesterday with the doctors, I told them the story of one of my patients who she was seeing a different neurologist in a city that wasn't ours, and she was nonverbal. She was 10 at the time, and mother noticed that she was not as active and she was dropping things with her hands. And so she took her child to the neurologist, and the neurologist said, oh, she just has delays, and so this is just a phase that she's going through. And that neurologist failed to listen to the mother. Mothers, and in many cases fathers, know their children better than any physician, and they know when something seems off. And so this mother took her child to the emergency room the next day and got a CAT scan done that showed that she had a large SEGA. So those are the symptoms you look for. You look for a sudden change in behavior, a sudden change in seizures, or a sudden change in seizure control when they were controlled before, or clumsiness, not as active. And then at severe stages, the child will become will just lay there and may even start vomiting. And that's when it's an emergency. They have to go to an emergency room at that point so that they can get emergency care. So those are the symptoms of SEGA.
How fast does SEGA grow?
So in most patients, it's very slow. So these changes that I described are usually something that occurs over the course of months at a time. The problem is that they will be slow until it's too much. And then the child will acutely, what we call decompensate. The child will become acutely ill, throwing up, not responsive, and they need to get to the emergency room as fast as possible. That happens. But usually you have a course of months to recognize these symptoms and see, because children will get sick. They will get a virus. They will eat some bad food, and they will get sick. So not any vomiting, not any clumsiness you need to be worried about, but you need to be worried about the type where it is clearly every day getting a little bit worse. That's when you need to call your neurologist and discuss with them what's going on.
The persistence and the increasing severity, I think,
Yes.
right? Yeah.
Yes.
I was just wondering if Dr. Manjula can talk a little bit more about sleep hygiene, maybe. And I think that is a common problem faced by the parents, the sleep, and how do they tackle the sleep problems. Some ideas.
I think I totally agree with Namita when she said physical exercise, it plays a very important role. Yes, please take it seriously. Again, this is a repetition of that shared activity, what I told you this morning. In shared activity, make it a point that you have a rigorous walking or a jogging exercise along with the family members. Okay. And regarding sleep hygiene, yes, remember the bedroom is a room only for sleep. And the other thing, I'm not using that word because children are here. Those are the only two things. No other activity should be done in the bedroom. Okay, first thing is that. And create an ambience that it instills peacefulness and, that calmness as soon as you enter that bedroom area. One thing. And as your day progresses, why do we not sleep? Just look at that. When we are fully awake the whole day, and automatically we sleep in the night. But when we are not sleeping in the night, somewhere we are sleeping during the daytime. I'm not talking about the literal sleep. The unconscious behavior that goes on, not being aware of the moment, Are you understanding me, what I'm saying? Yeah. So this brings us to another important thing, that is meditation. Okay? Meditation, I don't mean something like you have to sit in a corner and breathe in, breathe out, no thoughts. No, that's not meditation. It's not divorced from everyday life. It is part of life. Okay? Suppose you're driving, become aware. Use all your senses. Feel the inside of your mouth. You may ask me, how will the tongue be useful at that time? Feel the inside of your mouth, the teeth. Okay? Smell around you. Feel the temperature around you. and see what is around you. Become aware. Because most of the things that we do, we are doing it unconsciously. These moments of awareness is what you have to increase. You may remember it to do maybe now in the evening once. Tomorrow it should become twice and thrice. Like in an hour, become aware at least 4 to 5 times. It can be when you're drinking your coffee. Suddenly become aware that you're drinking your coffee. What are the sensations coming from your body? What are the stimulations from outside? This becoming aware is nothing but being awake. Okay? Now, small children will not understand this. So we have different exercises for them. Meditation in any part of the day, especially towards the evening. Research has shown that there's a strong correlation between this calm meditation and better sleep. So what we can do is we can give them something concrete, like keep a candle, ask them to blow the candle in such a way that it doesn't get put off, but the flame is flickering. Got it? So this is nothing but, it's called pursed lip breathing, and this induces relaxation in the mind and body. And with this, your breathing also becomes very slow and self-controlled. With this specific activity, we are also, generalizing self-control in general in all the other activities. You got it, what I said? So you have a candle, you're asking the child to take a deep breath and then blow the candle. The child has a tendency to blow the candle, in one go. The candle is off. No, our idea is not to off the candle, but blow it in such a way that the candle is not off. But the flame should flicker. When we say the candle should not be off, then the breath is not coming enough. No, it should be steady, it should be slow, and the flame is flickering. Okay? And when you tell the child to do, definitely she will not do it. You have to do it. Mother has to do it. Father has to do it. And then come on, your turn. You do it now. Okay, that way we can include them in our day-to-day activity. After the candle is gone, give them some item. Okay, without naming the item in their hand, like in a bag you put 4 or 5 things. Let's say the child has picked up the eraser. She will not say eraser is in my hand, but she will describe it. It is soft. It has some scent smell. And it is rectangular in shape. This is not being judgmental. This is just describing it being in the present moment. Okay? So these are some things that will help in sleep. Apart from that, what is sleep hygiene is, first point is bedroom should be used for sleep. And second thing is, just before sleeping, don't give any screen to the child. Okay? There should be 2 hours of gap between him playing the video games or watching a TV, even for adults. It's not good. Do something that is calming or boring. The best exercise would be reading. Reading a bedtime story for your children. How would you like it? I know. And it's very beautiful. Children sleep and you're talking to yourself. You realize that. I'm talking in English. So everybody okay? Samajh mein aaya, right? So these are few things. So before sleeping, there's no screen time, no other that, very strong physical activity should not be done, just going to the gym or doing those rigorous exercises. No, there should be calmness, like storytelling or a game of Samp CD or something, or carom board, something. Some activity which is enjoyable, that gives you a feeling of calmness and happiness, and then I retire to bed. And there should always be a specific time, like 10 to 6, lights are off in my house. That is the rule. Not that father says I have important calls to make, or mother says no, I have to make things ready for tomorrow morning. No, that should not happen. Wait for your child to sleep completely. Or you do all this before. Okay? And that's one thing. And regarding, I'm not a dietitian, but even food plays an important role, they say. I don't know much about it. You should talk to a dietitian about it. And overall, from the time you get up, let there be a structure. And this structure cannot happen in one day, because all these days we didn't have a structure in the family. So we were getting up at one time, then doing this, that. No. So one by one, after getting up, you have to do this. This is the family tradition. Then this. For everything, there is a structure. Okay? So sleep also comes in that timetable, what you have set for. Okay, so the first point is having a structure. Second thing is playing some calming shared activity, doing something which instills calmness and relaxation. No screens before sleeping, having a good meal. Okay, and then some kind of conversation with children. It can be story or what happened in your office, or let the child talk what happened in the school, something which is non-judgmental. And then this activity of meditation at some point of time in the evenings especially. Okay, the candle exercise what I told you, or that eraser exercise. So there are many exercises, okay, that will lead you to good sleep. Would you like to do some meditation activity now? Sure? Don't go off to sleep. Just 5 minutes. Can we have the lights off? This is the perfect, ambience to sleep actually. Right. All right. So this is just a very short activity, but you will enjoy it. And when you go back home, you can try this as a family. Okay? All of you close your eyes. We are not going to see anyone. Close your eyes and feel very relaxed. Sit in a very relaxed manner. Concentrate on your face. Your forehead should be relaxed, no frowns. The eyes, the eyelids. Let the noises around you happen. It's fine. Concentrate on your breathing. Breathe in very slowly. You can place your hands on your stomach if you want, and feel the stomach rising up, going down. Very rhythmically start breathing. Let your shoulders be relaxed. Your chest region completely relaxed. Your abdomen, your legs, your feet. Feel very thankful for the body that we have. It helps us to do a lot of things. It indicates us whenever we are in trouble. It tells us when things are not right. And now, as you're breathing in, breathing out, I want you to imagine you're somewhere near a water place. It can be a stream from your memory or a river. There is a tree beside the stream, a large peepal tree, and you're slowly sitting down and leaning your back to the stump of the tree and stretching your legs in front of you, continuing to breathe in, breathe out, and seeing the water flowing. You can hear the sound of water. All the other sounds around you, become aware of that. Don't give a name to any sound. Let the thoughts come and go. Don't control your thoughts. You come back to the activity of breathing in, breathing out. And as you're sitting there, seeing the beauty of running water, sparkling sunshine, some places it's brown in color, the stones underneath. And as you see far away, The water is blue and green. And now you see a leaf falling on this flowing water. Look at the leaf completely, the color of the leaf, the shape of the leaf, and how it is slowly sailing on that water. Don't push the leaf away, let it go slowly. And if any thoughts come to your mind, negative or positive, thoughts which you don't like, troubling you from childhood, take the thought and put it on that leaf and see it sailing away for the moment. Continue to breathe in, breathe out. This is a beautiful mechanism we have of breathing in, breathing out. It's a program we have in us biologically, which helps us to rest against all the automatic programs we have of fast heartbeat, high blood pressure. Against all this breathing in and breathing out helps. Appreciate this feeling right now. You can see leaves floating on the water. See them slowly floating away. Don't push them away. Let the thoughts come and go. You come back to this activity. And when you're comfortable, breathe in, breathe out, and slowly open your eyes. Good morning. Was it good? Yeah. So this was one kind of meditation. We have a concept in psychology called mindfulness, which is not a new concept. It has been there from the time of the Buddha, but it has gone to the West and come back again. And again we are doing. Mindfulness is nothing but being in the present moment, accepting this moment without making any judgment. Okay? Suppose you see a bottle, just looking at it without giving a name to it. When we give a name called bottle, that means we are living in the past. Okay? So when you see a tree, that one moment of connection that you make without giving it a name is what is mindfulness. Got it? And this you have to practice during daytime. As much as possible, become aware of, whenever suppose you're cooking, become aware of the sound of that vessel or the curry, okay, the temperature in the room. Become aware of the thoughts that's coming to you and going. But don't hate yourself for the thoughts that you're getting. Okay? So, this is how we get good sleep.
Thank you so much, Dr. Manjula. Any further questions or?
Is there any connection between protein and the number of seizures? I mean, I'm going into tangent here. What happens when my daughter has this mung meals, we call bone mung in our language. Whenever she eats that, her seizures increase. And I observe it like 10 times. I mean, more than 10 times. Whenever she eats those, whenever she eats those, her seizures will go up.
I don't know. I mean, I think I can comment about the ketogenic diet, which
I have no idea what that is.
He was doing mung meals.
But there are many different triggers for people to have a seizure. We just talked about sleep deprivation as one of those. But everybody is individual. And so what I find is my families will learn that there's certain situations, can be certain time of day. It can be after certain foods. There can be certain medicines that can serve as triggers, but typically they're not the same for every person. So when you find out for your child that there is a certain relationship, because every time it happens, or it happens many times, but maybe not every time, that is your story. And you learn how to avoid those triggers when you can. Okay.
Thank you, Sonal. We have a small token of appreciation from the Kims. It's an eco-friendly bag that they wanted us to give the presenters. So maybe Rahul, you should distribute them.
Yeah.
Yeah. To Professor Kruger.
Take photos. Take photos.
I see photo. Wow.
To Dr. Tangela Gibson. Thank you very much for taking time and coming all the way from US and giving us your valuable suggestions and time. Thank you so much.
Thank you.
For Katie. Thank you very much. She's from the TSC Alliance. Dr. Lokesh Lingappa. Thank you so much, Dr. Lokesh. Yes, you can take it home. Yes. This is for Dr. Samia Razvi. Thank you, Samia, for taking time off your leave and coming and helping us. Dr. Manjula Rao. Thank you very much, Dr. Manjula. And Mrs. Namita. Thank you so much for sharing your journey with us. And Reddy's Labs for sponsoring the event. Thank you so much. And TVSC Alliance, Mr. Rahul. He has taken a lot of effort and time and spent a lot of time. Yes, you get one too. And Mrs. Leela as well. And Gagan's mummy. I don't. They coordinated and helped us. Thank you so much, one and all, and thank you all the parents for taking your time out and coming and listening to us. And I wish that we remain as a group and continue to support each other. Please be a part of the TSC Alliance group. We are supportive. Mr. Rahul is quite supportive, and we have a WhatsApp group. And Mr. Rahul will inform you of all the important events and any questions that you may have that we might not be able to answer. Certainly, Professor Kruger and Dr. Gibson will help us. So thank you so much for being here. Thank you. Shall we have a group photo before we go for the tea? Yes.
I love to be at the corner. I love to be the back.
That's going to take time on my work schedule. Yes. I do a little bit. We used to have Lisa Young, but she moved to Tennessee, to Nashville.
Come on, everybody.
All the parents is
Leela.
Parents and Sonu is
Swapna. Raj, come here. Chalo, come here. Come here.
Oh, thank you. Mama is here. Mama is here. I'll just here for a second.
But she's smart enough to figure out she took it from you. If you got a new one, she'll come running back and take it.